Hey, this is Dr. Nick from the Ecg Academy with the first of many Chalk Talks that will help you become an ECG expert. It's easy. Just log on to ecgacademy.com for basic instructional videos, while these Chalk Talks will help you get used to reading the more complicated tracings. Anyway, let's start with this one. It's one that we see all the time in the telemetry unit. Nurses, doctors will often sit there wondering what it is. And I'll talk you through it. So, first look at the forest. There are 3 beats on the left side here that are kind of slow, and then there's these 6 beats on the right that are a lot faster. Well, if you look carefully at these beats, they kind of look like a normal beat. There's an upright P wave and a fairly normal PR interval of about 180 milliseconds. The QRS is a little bit wide. There's probably a little bit of an interventricular conduction delay there, like an incomplete right bundle branch block along those lines, and the T wave looks fairly narrow, nice and smooth. This beat looks exactly the same. And if we figure out the rate, let's start. It's about halfway between these two dark lines. So let's count off 300, 150, 100, 75, 60. And it's a little bit to the right of where this one lands. So I'd say it's probably 59 beats per minute if you want to be exact, maybe 58. Look at the next beat over, count it. 300, 150, 100, 75, 60. And it's even further to the right. So I think 58 or 59 is perfect. And we would call this sinus bradycardia because it is less than 60 beats per minute, and it looks like it's coming from the sinus node with upright P waves and these 2 leads. Remember, these 2 leads are going simultaneously, so you can see the beats from a different angle. Okay, and then we get this weird kind of 6-beat run of something. It's fast. If you measure the rate, it's a little less than 2 boxes. So this is about 150 beats per minute. This may be 160, 165 or so, and then it slows down again. This is 2 big heavy boxes, so 300, 150. And this is a little slower, so it's a little irregular, averaging about 150 beats per minute. But the QRS complex is sort of wide and bizarre looking. It certainly doesn't look like the normally conducted beats. So let's figure out what it is. Well, most people realize, if once you've read a bunch of EKGs, that a wide complex tachycardia like this is either non-sustained ventricular tachycardia coming from the bottom chambers, or some kind of atrial arrhythmia, atrial tachycardia or fibrillation, something like that, that is not following the normal conduction pathways in the heart, and it's what we call aberrant conduction. So it could be a supraventricular tachycardia with aberrant conduction, or it may be non-sustained ventricular tachycardia. So let's figure out which. And sometimes hard, but I think this will become clear to you in a minute. The best way to figure out whether this is coming from the atrium or the ventricle is to look at how it starts. What you're looking to see is if there's a P wave that sets off this tachycardia, and if the PR interval is normal, then it's likely coming from the top chamber. Well, keep in mind that P waves tend to be a lot spikier looking than T waves, and in technical terms, the frequency component of the electrical signal is much higher. In other words, the rate of change of voltage is much higher. The slope, let's just say, or the frequency content tends to be quicker than the T waves, which are more slowly changing electrical signals with a lower frequency content. So what you're looking for is a sharp, spiky signal on the T wave. So if you see a T wave that looks like this, or one that has a bite taken out of it like this, then chances are this high-frequency signal is a P wave. So let's go back and look. We'll pick a different color and look at this normal T wave. Looks pretty smooth, and if you compare this T wave to it, it looks virtually the same. There's no high frequency jiggle or any bite or anything that looks like a P wave. Same thing here. This T wave looks pretty smooth compared with this one, and I would say no, there's no P wave. Now some people would argue. They'd say, well, what about this? Could this little bump be a P wave? Well, I'll tell you why it's not. If you look at the bottom lead, you can see that the QRS complex actually extends back to here just before the heavy line. That's part of the QRS complex. So if you look at this lead at the same time, you can see that this first bump, this initial bump, actually is part of the QRS complex. It just happens to be rather small in the beginning, what we call isoelectric. So the QRS is wider than it seems, but that's not a P wave. Besides, the PR interval, if you measured it, would only be maybe 100 milliseconds, which is way too short for it to be conducting. Okay, so where do we go from here? Well, let's assume this is a ventricular beat because it's wide and bizarre and there's no P in front of it. Well, what you need to notice is this signal right here. This signal, which you can also see in this lead, is actually a retrograde P wave. How do we know that? Well, like I said, the T waves should be very smooth, and this sharp, spiky bite taken out of the T wave looks just like this. It's because this ventricular beat managed to get backwards up the AV node and back to the atrium, and the P wave is retrograde, meaning it's going in the opposite direction, and lo and behold, it's in the opposite direction than the normal P wave. That's what you'd expect in a retrograde P wave. Well, then what happens after that? You have this T wave and then another QRS complex, and then sure enough, there is another retrograde P wave. This time, the interval between the QRS and the P wave, this sort of interval is a little bit longer than here, and that's because the AV node really in general doesn't conduct that well in a backwards direction. The next beat that comes in looks exactly the same, but now look, there's no retrograde P wave because the AV node failed to conduct this signal backwards. If you continue examining these QRS complexes, you see that there's a retrograde P wave following this beat, and then the retrograde P wave disappears again. Finally, with the last beat of the tachycardia, there's a retrograde P wave. So if we count the number of QRS complexes, you have 1, 2, 3, 4, 5, 6. And how many P waves are there? 1, 2, 3, 4. So what we have here is a condition known as AV dissociation. AV dissociation means that there are more ventricular beats than there are atrial beats. The ventricle is running the show. That means this is indeed non-sustained ventricular tachycardia with variable conduction back to the atrium. AV dissociation, in fact, is the hallmark of VTAC because basically tells you that the ventricle is running the show and the atria are lagging behind. So the final answer is sinus bradycardia with a 6-beat run of non-sustained ventricular tachycardia that you can recognize because you have retrograde P waves and AV dissociation. Well, that's Rhythm Strip Chalk Talk number 1. I hope that helped. Stay tuned for more video Chalk Talks and log on to ecgacademy.com if you want to become an ECG expert. This is Dr. Nick from the Ecg Academy with the second of many Chalk Talks that will help you become an ECG expert. It's easy. Just log on to ecgacademy.com for basic instructional videos, and these Chalk Talks will help you get used to reading the more complicated tracings. Anyway, this is number 2, and it's not that complicated, but number 3 will pick up where this left off, and I promise you it'll be more challenging. This one, if you look at the forest, you're looking at an irregular heartbeat here. And the question is it irregularly irregular, or is there a pattern of regular irregularity? And you should be able to notice right away that there is a group of 2 QRS complexes, and then there's a pause, another group of 2 and a pause, and then finally a group of 2. So there's group beating going on, and it makes you think that there may be some kind of conduction disturbance. Well, let's look more closely. Remember, these 3 lines are going simultaneously, so you can look at 3 different leads. And if you look at the first beat, it looks fairly normal with an upright P wave, a QRS complex, and a pretty smooth-looking T wave. The QRS is a little abnormal. There is a strange-looking wide S wave here. If you measure the entire QRS complex, it's only about 110 milliseconds. So this wide S wave and this RSR prime in V1 suggests that there is an incomplete right bundle branch block going on. But that's something for a 12 lead to confirm. Anyway, the PR interval of this beat is about 200 milliseconds. It's at the upper limit of normal, right about one big box. The next beat comes along, and if we measure the rate, let's count off 300, 150, 100, 75, 60. So it's a little bit faster than 60, maybe 68 beats per minute. The PR interval still looks to be about 200 milliseconds, and the QRS looks the same. Well, if we measure off another 68 beats per minute, we find that there does seem to be a P wave that does appear to land on time, but there's no QRS associated with it. So it appears that AV block had occurred because this P wave never got down to the ventricles, and somewhere in the AV conduction system, the signal never got through. Well, let's keep on going. Following this pause, there is another PR interval that's 0.2 or so, another one that's fairly constant, and then this P wave blocks. And so you have AV block with a fixed PR interval. Now, if we look at all different AV blocks, we remember that you have first, second, and third degree, where first degree, all the P's conduct. It's just your PR interval is a little bit long. With third degree AV block, none of the P waves conduct. Well, clearly some of them conduct in this tracing, so we have second degree AV block, and you should already know that with a fixed PR interval and no increase, that should be type 2 second degree AV block. Well, there are a couple of things you have to make sure. First of all, you have to make sure that this P wave is in fact on time and is not simply a non-conducted or blocked APC. So if you grab your calipers and move it on over to the P waves, you look at the P to P interval, and sure enough, this P does occur on time. In fact, all the P waves appear to be regular, and that is one of the requirements to say that second degree AV block is present, and that is the P to P interval should be regular. The other characteristic of type 2 second degree AV block is that the pause that results from the blocked P wave should be exactly 2 times the previous R to R interval. So if we take our calipers and confirm that we have them sized to reflect the R to R interval, now let's measure and take a look at it. Lands halfway between that box, and the next beat occurs exactly where it should. And that's because the P to P interval is constant, the PR is constant, and the fact is that this QRS complex lands exactly where it should land. If you look at the ratio of P's to QRS's, it's going to be 4 to 3 or 3 to 2 or 7 to 6. It's always one more P wave than QRS complexes. So the easiest way to figure out what ratio it is look at the QRS's, and that's the second number. So the 2 QRS's, and therefore it must be 3 to 2 AV conduction with 1, 2, 3 P waves, resulting in 2 QRS complexes. So pretty simple. Type 2 second degree AV block with a 3 to 2 pattern. But stay tuned for the next Chalk Talk, because I'm going to show you something that looks a little bit different. Hi, this is Dr. Nick from the Ecg Academy with the next Rhythm Chalk Talk. The last one was really tough, and I know a lot of you may not have gotten it right away. But remember, Chalk Talks assume you know the basics. What I'm trying to do is get you used to reading more difficult tracings. This one won't be as bad. But don't forget, you can always log on to ecgacademy.com to watch a whole series of videos from basic to advanced. Let me help you become an ECG expert. And stay tuned for more Chalk Talks every week. Well, anyway, this, as I said, is an intermediate one. It's certainly not as bad as the last one. But let's just give you a little clinical background. Imagine this patient is being monitored for some post-operative problems, and the nurse calls that the patient all of a sudden has developed a heart rate of about 40 beats per minute. And you have to look at the EKG and figure out what's going on. Well, you look at the forest, and the QRS complexes certainly seem to be regular. And if you measure the rate starting at this heavy line and count off 300, 150, 100, 75, 60, 50, it is, 40 beats per minute or so. That's pretty accurate. Let's see. Are there any P waves? We can see P waves. Yes, indeed. If you look in front of the QRS complex, you see what looks like a normal P wave in front of every QRS. It's upright. The PR interval measures about 180 milliseconds or so. So that seems to be normal. So one of the more likely possibilities is that this is sinus bradycardia. And sinus bradycardia occurs commonly postoperatively, and you'd be tempted to just say, okay, this is sinus brady, and treat the patient accordingly. But there's something going on here that's more than just sinus brady, and that's what these chalk talks are all about, getting you used to looking for things out of the ordinary, things a little more advanced than what you'll see in the textbooks. Okay, and I'll give you a hint. Remember that the electrical characteristics of a QRS complex, in particular P wave. Let's start with the P wave. The P wave voltage changes relatively rapidly. If the rate of change of a P wave is fast compared with the T wave. Let me just put that in plain English. P waves look a little more spiky because in technical terms, the frequency content includes a lot of higher frequency components, whereas T waves tend to be lower frequency electrical signals with slower rates of change of voltage, so they're more smooth and gradually changing in voltage. All right, so that's a clue. When we go back to this EKG, we'll change color just to provide a little contrast. Here's the P wave and the QRS, and everything looks fairly normal. But when you look at the T wave, it's by no means smooth. These T waves are very bumpy. It looks like a camelback. And what you need to be able to recognize is that this is clearly a very abnormal looking T wave. And it looks abnormal because there is a P wave superimposed on top of the T wave. This P wave doesn't conduct, so there's no QRS following it. And so you think, oh, blocked P waves. Well, this must be AV block. No, that's not quite right. Because in order to be able to diagnose AV block, you need to be able to demonstrate that the P to P interval is regular. And if you take this P wave and you take the next P wave and you measure halfway in between, indeed, there is nothing there. And so that you might say, well, there's no P wave here, but maybe we got the P wave rate wrong. So let's measure from this P wave to this one. Where would the next one fall if that was the atrial rate? Well, it would fall in here someplace, and then maybe have another one over here before you came to this P wave. So neither of those cases are true. So what is this then? How would we classify this P wave superimposed on the T? Well, it's not on time, it's early. So in basic terms, it's a premature atrial beat, or a premature atrial contraction, or a PAC, or an APC, whatever you want to call it. It all means the same. It's an atrial event that occurs earlier than it should. Now, that can occur. Remember that the atria are made up of electrically active cells, and any cell in the atria can give rise to an electrical signal. When you're post-operative, there's lots of adrenaline circulating around, and so areas in the atrium can fire, and you can have an electrical signal that gives rise to a P wave, and that's what we are seeing as a premature atrial beat. Well, but it didn't conduct. Why didn't it conduct? Well, remember that the AV node takes some time to recover from the previous beat. It has a certain refractory period. So after this beat conducts down the AV node, there's a certain period of time where the AV node is busy conducting that beat to the ventricle, and it takes a split second to recover. So when this P wave hits the AV node, it finds that the AV node is not capable of conducting the beat properly. And so the AV node fails to conduct the beat, and you get a P wave that blocks. Well, I don't like the word block because it implies that something is wrong, that the AV node didn't behave normally. But in fact, premature beats like this commonly don't conduct, and it's sort of normal behavior for the AV node, because the AV node, in fact, acts kind of like a safety valve, and it prevents very rapid electrical rhythms like atrial fibrillation and flutter from being conducted down to the ventricles at super high rates. So the AV node's kind of like a funnel. Think of a funnel as a device where you can pour lots of water into the top of it, but only a certain amount is going to come out the bottom. So the AV node's like a filter or a funnel, and it filtered out this P wave because it was just too early. So then, what do you make of this rhythm strip? Well, officially, what we would call this is atrial bigeminy. Why? Because every other beat is premature. You've heard of ventricular bigeminy, where every other beat is a ventricular premature beat. Well, this is atrial bigeminy, where you have a normal beat and then a PAC, and then a little compensatory pause, and then a normal beat and a PAC, and another compensatory pause. So you have atrial bigeminy, but the PACs are blocked, or shall we say non-conducted. So what I like to call this strip non-conducted atrial bigeminy, and it's responsible for the fact that the ventricular rate suddenly went to 41 beats per minute. But there's nothing wrong with the sinus node. It happens to be the atrial myocardium that's the problem, because of all those post-operative hormones running around. You've got just a lot of atrial ectopy. And in the absence of symptoms, we generally would not treat this. In fact, some people would add an antiarrhythmic drug if it gets to be too slow, but that's really not necessary as long as the patient is hemodynamically stable. So it was an interesting strip. I hope you enjoyed that. These Chalk Talks, as I said, are designed to get you looking at things that you normally won't see in a textbook, and to get you comfortable with reading more difficult tracings. So I hope that helped. So remember to log on to ecgacademy.com so you too can become an ECG expert. Hi, this is Dr. Nick from the Ecg Academy with the next Rhythm Chalk Talk. Remember, Chalk Talks assume you know the basics. What I'm trying to do is get you used to reading more difficult tracings. You can also log on to ecgacademy.com to watch a whole series of videos from basic to advanced. Let me help you become an ECG expert. It's easy. And stay tuned for more Chalk Talks every week. Anyway, this rhythm strip is something that I found on the telemetry unit, and it's a very common strip. It's a common arrhythmia, but so I listed it as basic, but it doesn't exactly look like the typical textbook picture of this particular arrhythmia. So that's why I thought it would be fun to go through it step by step and teach you how to recognize this arrhythmia while when you're looking at strips on the units. Anyway, let's look at the forest first. You see the QRSs kind of marching through, and they look pretty regular. Let's grab our calipers and take a look and see whether they are indeed regular. So put them down. I happen to have them at the right rate. And the QRSs certainly do appear to be very regular. So, that's kind of interesting. What's the rate there? If we count heavy boxes, 300, 150, 100, 75, 60, it's between 60 and 75 beats per minute, so we'll call it 68. Well, that's fine. So we have a regular rhythm at 68 beats per minute, and now, of course, what should we do is look for atrial activity. What's the atrium doing? Of course, the best place to look for P waves is in front of the QRS complex. And if you look in front of this QRS, there's a bump right here that kind of looks a little like a P wave. Let's look at the next QRS complex, and it seems like there's the same signal there. In fact, there's a bump in front of every QRS complex. But if this was a P wave and you were to measure the PR interval, it would seem to be somewhat short, perhaps 120 milliseconds or so. Well, what's the normal PR interval? The normal PR should be 0.12 to 0.2 seconds, or as electrophysiologists like to think in terms of milliseconds, 120 to 200 milliseconds. Or for beginners, it's basically anywhere from 3 to 5 small boxes. And that would be the normal PR interval. This really does look short, doesn't it? It's almost like 2.5 small boxes, really. It doesn't quite make 3. So you'd have to call this sinus rhythm with a short PR interval. But when you think of short PR intervals, well, there are a couple of syndromes that come in mind, like WPW syndrome, where you, instead of having a PR segment that's fairly flat, what you have instead is a delta wave, which is a slurred upstroke of the QRS complex and a very short PR. But that's not really what we're seeing here. We're seeing just a short PR interval. But here's the trick. You really shouldn't just look at this. You really have to look at the whole thing. Because if you kind of glance at the baseline between these QRS complexes, there's a hint here. Because in front of this little bump here that you think is a P wave, there's a flat segment, but it's not exactly flat, is it? It's kind of slanted. It has a slope to it. So when you think about slopey things, what you need to think about are sawtooth waves. What does a sawtooth wave tell you? Atrial flutter. Now, how do you know it's atrial flutter? Well, if you look really closely, behind this bump, there's actually another bump that looks just like it, right there. And if I take out my teeny weeny calipers and bring them on over, you can see that, well, my marks got in the way of that one. Let's measure these over here. You have these two, which are a little bit slower than 300 beats per minute, probably about 275 beats per minute. And then if you measure on over, you see that there's actually a bump on the very beginning portion of the T wave. And so if you put your caliper lines on that, then you're reading the end of the T wave. And if you measure out after that, you see the next bump here, which is a flutter wave, occurs on time. All right, so when you're thinking about flutter waves, we're seeing 1, we're seeing 2, then there's one buried in the beginning of the T wave, and there's one buried at the end of the T wave. So you have to consider that there's 4 flutter waves for every QRS complex, and it just keeps repeating over and over again. So you could call this atrial flutter with 4-to-1 conduction. I don't like to use the word block. The word block implies that there's really something wrong with the AV node. And you realize that the AV node is supposed to keep all of the atrial signals from the ventricles, because if you had an atrial rate of 275 beats per minute and the AV node conducted every single one, you'd have a ventricular rate of 275, which could kill a person. So your AV node kind of acts like a filter, and it keeps all the atrial signals, very rapid ones, from reaching the ventricle. Well, in a normal person, perhaps in the middle of the night while they're sleeping, you could easily have atrial flutter conducting here at 68 beats per minute. Think of 68 is about 70. 70 times 4 is 280, and that's kind of where we thought our atrial rate was, about 275 beats per minute. So if the atrial rate's 275, 1/4 of that runs out to be about 68 beats per minute, which was kind of where we thought the ventricular rate was. So it all adds up. You've got atrial flutter with 4-to-1 conduction. Some people would just call this a moderate ventricular response, but these flutter waves are a little bit tougher to see. It's fairly basic. Most people should be able to pick those up, but 2 of them got hidden by the T wave, and that's why I thought this strip was a little bit more challenging than the ones you'll normally see. So that's Rhythm Chalk Talk number 5. I hope that helped. Remember to log on to ecgacademy.com so you too can become an ECG expert. And thanks for watching. Hi, this is Dr. Nick from the Ecg Academy with Chalk Talk number 6. Now, I want to get right into this one because it's a great tracing. It's a common problem that most people don't think about. And I want to introduce it to you here on our 6th Rhythm Chalk Talk. So let's get right to it. The first strip are 2 leads running simultaneously, and then you have a second strip from the same patient. And if you look at the first strip, you can see a fairly normal, regular-looking EKG with a P wave and a QRS complex and a nice-looking T wave. If you measure the rate, let's take this one, we can count off 300, 150, 100, 75, 60. So it's a little bit faster than that, about 64 beats per minute on this beat. And so it would look like a normal sinus rhythm. It's a little irregular, though. And so let's take our calipers out and measure it. I set these calipers up for about 64 beats per minute. And what you see is the first R interval is actually a little bit longer. And then it comes down to the 64, and then it looks a little bit faster. And this R interval is a little shorter, as is this one. And if you measure, this one's shorter, and then it gets longer again. And so what we have here is a very common abnormality known as sinus arrhythmia. It's a slight irregularity in the sinus rhythm, and it happens because the sinus node is influenced by changes in the autonomic nervous system. The vagal nerve in particular will cause changes, very rapid changes in heart rate that can cause the R-to-R interval to vary from one beat to the next. But this is normal. Sinus arrhythmia is considered a normal variant. So now let's get to the second strip. If we, let's look at this T wave, and the T to T appears to be regular. And if you place it on the caliper on this QRS complex, you can see that there seems to be a QRS right here that is probably on time. This one here, I would say. And then you have what looks like this 7 beats of a rapid, irregular-looking signal with a rate that's, let's count it off, 300, 150. So it's about 165, maybe 170 beats per minute, but it's grossly irregular. It comes down to 150 here. And you're not really sure what it is, but you think, maybe this is a run of non-sustained ventricular tachycardia. Once this is over, you see that the normal sinus rhythm comes back again, in fact, very quickly. But what bothers me, the first thing that bothers me is if this is a QRS complex, and it looks like it, because it looks a lot like this one, and it occurs on time, how can a PVC start so soon after the QRS? In fact, it almost seems to start with the QRS complex, right? On the top lead here, that doesn't make sense. And then if you kind of look through this tracing, you see something. In fact, you see this signal. That looks just like this. So you start to wonder, is this real or not? Well, let's get our calipers back out again. And if we map out these signals, given that there's a little bit of sinus arrhythmia and you'd expect a little bit of irregularity, there seems to be something that's right here. And if you bring our calipers back out, this beat occurs on time. With plus or minus a couple of small boxes, but remember, there's a little sinus arrhythmia going on. So what do we have here? This is artifact. In other words, our EKG systems are picking up little tiny electrical signals coming from our heart. But since the EKG electrodes are on your skin, it can pick up other things. It can pick up your muscles. It can pick up your scratching yourself. If someone shakes the wires, those signals can be picked up. And all those things are artifactual. They're not real. They're not really the EKG. They're just external interference. And that's what this is. It's artifact. And as such, it should be ignored. You wouldn't put a strip like this on the patient's chart. You just throw it out. You have to recognize that this is not real. Why? Well, this first signal here started on top of the QRS, which physiologically can't happen. You also have a regular QRS in the middle of it, and you can't have a regular normal sinus beat in the middle, sandwiched between two beats of ventricular tachycardia. It just can't happen. So keep this in mind when you read the strips, because I promise I'm going to show you more of these artifactual strips. But this is a great lesson to be learned, and I hope you keep this in mind, that not everything on paper may be real, and you have to recognize that there are limitations in the technology that we're using. So that's Rhythm Chalk Talk number 6. Remember, log on to ecgacademy.com to watch a whole series of videos from basic to advanced. Let me help you become an ECG expert too. Hi, this is Dr. Nick from the Ecg Academy with the next Rhythm Chalk Talk. This is number 8. Now, I've labeled this as basic because this is an arrhythmia that you will see fairly often. This ECG isn't that hard to interpret, but I'm going to talk about some other physiologic and electrocardiographic ideas that might help you understand other tracings in the future. After all, that's what we're trying to do, is give you some practice in reading some of these advanced tracings. So we'll get to it. This is a bit of a departure from my usual rhythm strip because I'm showing you the whole 12 lead. But down here there is lead 2, which is a rhythm strip that you can kind of take a look at. Look at the whole forest, and you can see that it's a little slow in the beginning, and then it seemed to speed up a little, and then it gets slow again at the end. So that gives you an idea that the rhythm may be changing here. So let's examine these ECG beats in detail. We can see an upright P wave in 1, 2, and 3, a normal PR interval of maybe 160 milliseconds, and then the QRS complex looks pretty normal. The T wave does as well. So now look at rate, and if we look at this S wave that lands on a heavy line, we can count off 300, 150, 100, 75, 60, 50. This is exactly 50 beats per minute. And so if the P wave is coming from the normal sinus region and we have 50 beats per minute, we can diagnose sinus bradycardia. Pretty simple, right? But if we go down to our rhythm strip, we can see that this third beat, something changes. The P wave looks different. It looks upside down. It's an inverted P wave in lead 2. And that kind of makes you think that the P wave is coming from somewhere else in the heart. After all, axis gives you an idea of direction. And if the P wave changes its axis, then usually that means the P wave is coming from a different spot in the atrium. So what else do we see? Well, let's bring up a pair of calipers and examine the rate. And if we bring this caliper down to the first beat, I've set it for 50 beats per minute, which is the P to P interval of the first beat. But if we bring this over, we can see not only does this P wave change its axis, but also comes a little bit early. And so this is an ectopic beat coming from some focus in the atrium. We're going to discuss that a little bit later. And if we take another pair of calipers that I've set for the P to P interval here, which if you count back, be about 300, 150, 175, 60, maybe 66 beats per minute, then you can see that the next P to P interval actually speeds up a little. And that so the rhythm kind of warms up. It goes from 66 to maybe 72 beats per minute. And then after this last beat here stops, and then the normal P wave comes in after a bit of a pause. Okay, so get rid of our calipers and start talking about the P wave. Now, not only is it inverted in 2, but it's inverted in AVF, but it happens to be upright in AVL, which makes you think that it is headed from left to right. Well, what do you mean? I mean from right to left. Are we getting confused? Well, in that case, then why don't we look at axis and kind of review what axis is all about? Axis has to do with the vertical plane, or the so-called frontal plane, and it has to do with the limb leads. So we can divide up this 360-degree circle into equal parts. And the first leads, 1, 2, and 3, are pretty simple lead 1 is going from right arm to left arm, and that's designated as 0 degrees. And then we have to divide with leads 2 and 3. We have to divide the circle up into equal parts. So where does 2 go? Well, 2, 3, and AVF are the inferior leads, so it's going to point towards the bottom part of the circle. But at what angle? Well, I always tell people to remember that in English we read from top down and from left to right. And so if you draw a line 60 degrees above the horizontal, because we do have to split the circle into 6 equal spaces, and this will be lead 2. And then, of course, lead 3 would be the last one. Since it's an inferior lead, it also points towards the bottom, so that's lead 3. And so you've got your first 3 limb leads in here with leads 1, 2, and 3. Now, where do the augmented limb leads go? Well, AVF, which is also an inferior lead, goes straight down, and that's where plus 90 degrees is. Let's see, this is AVF, and that's plus 90 degrees. AVL is going to point towards the left arm, so that comes up here. And then AVR is the only one sort of like kind of an odd lead because it sort of points in the opposite direction than all the other leads combined. That's why most signals are negative in AVR, because P waves and QRSs tend to point down and to the left towards the apex, and that's going away from AVR. So when a signal is going in the opposite direction than a lead, let's say AVR, if the signal is going down and to the left away from AVR, then it's going to be drawn as a negative deflection on the ECG. All right, so what does that mean in terms of our P wave? Well, here is, let's just erase this, and here's a drawing that I made of the heart. And here's your sinus node up in the right atrium. Your left atrium is a little bit higher than that and to the left, but when the sinus node fires, the signal spreads to the left and down, which is why P waves in a normal sinus rhythm tend to be positive in the inferior leads, and they're also positive in 1 and AVL, because the signal is traveling towards 1 and AVL towards the left. But now in this ECG, what you see is that the P waves are negative in 2 and they're positive in AVR. That means that this signal, this P wave, is arising from some crazy place. It likely is arising from the low right atrium somewhere, because it's heading towards AVL, where it was positive. The P wave was positive in AVL, but it's also positive in AVR. So it's traveling in those two directions, and of course it's going away from 2, 3, and AVF. It's arising from the low right atrium and traveling towards the head. So that tells us that's an ectopic focus somewhere in the low right atrium that takes over the rhythm. Well, let's go back to this and see what we're talking about. So you have this, by definition, an ectopic atrial rhythm. An ectopic atrial rhythm that is a little bit faster than the sinus bradycardia that's here. The P wave changes because the axis of the P wave is headed up and towards the right, but it's also positive in AVL, so that's why I think it's coming from the right atrium, since it's going towards AVL as well as towards AVR. So you have this ectopic atrial rhythm that has a little bit of a warm-up, because it starts out sort of slow and then builds up a little bit. But then after this ends, you have a fairly long pause. And that's pretty common, because we have this concept of overdrive suppression. Overdrive suppression is an electrophysiologic concept that any area in the heart, whether it be in the atrium or the AV node or Purkinje fibers or even ventriculomyocardium, is able to fire. It's able to deliver electrical signals. It has something called automaticity. But if another region of the heart is firing faster, then that automaticity is suppressed. That's why you don't have these ectopic atrial beats all the time, because the sinus node usually keeps them suppressed because the sinus node tends to fire faster. But here, what do we have? We have a sinus bradycardia. It's very fast. It's very slow, I mean to say. And so that allows some of these ectopic atrial foci to gain footing and create these arrhythmia problems. But when the ectopic atrial focus stops firing, then it takes a little while for the sinus node to kick in again because of overdrive suppression of the sinus node. We see this commonly in sick sinus syndrome, where you have a tachyarrhythmia and then post-tachycardia pauses. The common cause of lightheadedness in patients with tachybrady syndrome. All right, so I think the other thing to point out is that in this 12 lead, you do have an RSR prime pattern in V2, a little bit of it in V1, but the QRS complex isn't wide enough to really qualify for a bundle branch block, but this allows you to diagnose an incomplete right bundle branch block. All right, so what you have is sinus bradycardia with a run of an ectopic atrial rhythm that has a little bit of a warm-up there, and an incomplete right bundle branch block on the 12 lead that is worth mentioning, and a little bit of a sinus pause after this arrhythmia that's probably due to overdrive suppression. And this patient may be on medications or may have a degree of sinus node dysfunction, but it's a common presentation in someone who may have symptoms. On the other hand, it may be asymptomatic, so you have to take the patient as an individual. Anyway, I hope this was interesting to you. I hope I've clarified some concepts in terms of axis and rhythm, and I enjoyed showing this to you. And remember, log on to ecgacademy.com so you can watch videos from basic to advanced, and you too can become an ECG expert. Oh, and subscribe to my YouTube channel so that you get notified when I put up my next Chalk Talk, which will be soon. Keep watching, and thanks for viewing. Hi, this is Dr. Nick from the Ecg Academy with Chalk Talk number 9. Chalk Talks assume you know the basics, so what I'm trying to do is get you used to reading more complicated tracings. And this time I'm going to do it a little bit differently. We're going to talk clinically, okay? Because a lot of you will have to take board questions, and I want you to get thinking along those lines. So let's imagine a case, okay? And this is a 59-year-old woman who has a history of depression, and she's on Effexor, and she gets a urinary tract infection with fever and chills and so forth, and gets admitted to the hospital, and her doctor puts her on an antibiotic commonly used, let's say Levaquin. And then in the middle of the night, the nurse calls you up and says, something funny happened on the monitor. I wonder if you can take a look at it. And here's the rhythm strip they give you. And here's the question. What do you do? Okay, do you A, go back to sleep, it's only artifact? Do you B, give IV cardizem? Would you C, give IV amiodarone? Or D, none of the above? So let's get to it. Let's get rid of these, and let's start looking at this tracing, because it is pretty bizarre, and that's why I didn't make it basic. It's kind of an intermediate tracing. When you first look at it, you kind of have to look at the forest, because there's almost no pattern to this, and you see all these really weird looking beats over here, and it kind of does give a sense of artifact. And imagine if this is a very itchy patient, she's probably scratching herself all over the place and giving you all these numbers, but all these beats. But let's look more carefully, okay? Shall we look at the trees? So these first couple of beats, they really do look wide and bizarre, and I mean, they certainly could be ventricular beats because of that, but lo and behold, oh my goodness, thank goodness we actually found a normal looking beat. So we have somewhere to start. You have a nice looking P wave. We have a PR interval that's fairly normal. It's almost 0.2, I'd say, and a QRS that's narrow, and so great. So now we have, after a short pause of maybe 600 milliseconds or so, we have this the beginning of this run of something. And the first beat almost kind of looks like the normal beat, except the R wave's a little bit taller and it looks a little wider, and I'm not really sure about that. But then you've got these wide, complex beats starting at a rate of about maybe 160 beats per minute, and then it speeds up somewhat. It gets to be, almost 180, close to 200 beats a minute at the end. And then it seems to change, doesn't it? You have these wide beats, and then it kind of changes its appearance, and now you've got these funny, crazy looking beats, and then it finally stops, and you get another normal beat. And then the PR is a little bit long here, but I'm not going to make too much of that, because all of a sudden you've got a couple of wide beats again, and then a normal beat once again, and then a run of a wide, complex tachycardia. If that's what it is, if you're convinced it's not an artifact. I mean, when you scan around, you don't see anything that looks like a normal QRS peeking out from any of these beats, so let's assume it's not artifact for the time being. Here's another QRS. This time the PR is a little bit shorter, and then there's 4 beats of this wide something or other, and then another normal beat, and probably a P wave here. That's another normal beat. So, oh my goodness, 2 normal beats in a row. I guess we can figure out what the sinus node is doing. Okay, so if we measure out the rate, we get 300, 150, 175. It's between 60 and 75, closer to 75, so maybe 68 or 70 beats per minute, assuming this conducts. Okay, here, I'll make you feel better. Okay, is that better? All right. Anyway, all right, so we've got a sinus bradycardia, or barely a sinus rhythm, but then we have these wide, complex tachycardias. All right, so when we're figuring out where a wide, complex tachycardia comes from, what should we be looking for? Well, how does it start? Is there a P wave in front of the first beat? Because that's a really important clue. If you see a P wave with a normal or a slightly prolonged PR interval, then it's most likely atrial, and you start to think about cardism for some kind of atrial arrhythmia with aberrant conduction. So if we kind of look at the T wave of this beat that precedes the tachycardia, I don't know about that. I don't see any bumps or bites or anything high frequency that I would call a P wave. Remember, atrial activity on top of a T wave is usually easy to see, but I just don't see it here. So if there's no P wave in front of this beat, then the presumption is that it's ventricular. But if it's ventricular and you have rates in the 150 to 200 range, we're talking about ventricular tachycardia. Well, let's think about VTAC for a little while and kind of remember the classification of VTAC when you're trying to make an electrocardiographic diagnosis. You have several different varieties. So you have monomorphic ventricular tachycardia, and that, of course, is where all the beats look the same, at least in the same lead, right? If you look at a different lead, it's going to look differently, of course, but monomorphic means all the beats look alike in one lead, so it's the same morphology. Polymorphic ventricular tachycardia is a ventricular tachycardia where the beats seem to change over time, and you may have at least 2 different morphologies during this run of ventricular tachycardia. So that's called polymorphic VT. Now, these are generally at rates below 300 beats per minute. When you get to rates above 300 beats per minute, then the names change a little bit. A monomorphic ventricular tachycardia at above 300 beats per minute is often referred to as ventricular flutter. Think of atrial flutter as being an atrial rate of around 300. So monomorphic VT at 300 beats per minute or above, ventricular flutter. And then if you have a polymorphic ventricular arrhythmia greater than 300 beats per minute, what do we call it? That's ventricular fibrillation. Okay, so that's pretty simple. You know that. So as far as classification is concerned, you look at this run and you say, that looks monomorphic kind of sort of here. It does change a little from one beat to the next, but then clearly it changes in a big way. The beats become much smaller. I don't know what's going on. Help me out, Dr. Nick. Well, okay, there's one thing that I left out very conveniently because you guys were supposed to do it. Oh dear. You guys were supposed to make all the measurements, and maybe you did, maybe you didn't. You guys who know how to read ECGs should have pulled out your calipers. Let me pull out my trusty calipers and notice that the QT interval of this sinus beat over here in the beginning measures out to be a whopping 700 milliseconds. Oh my goodness. 700 millisecond QT interval. You better not go back to sleep. Let me tell you, something bad's happening here. So with 700 milliseconds, and then this tachycardia starts up, what's the first thing you really need to think about? Look, you got a long QT interval. You have a polymorphic VTach. Almost certainly what this is you guys know, right? Torsade de pointe. Okay, what is torsade de pointe? It's actually a French word, and it means revolving around a point. It's a polymorphic ventricular tachycardia that was named because the complexes seem to get bigger and smaller and bigger and smaller, and the idea is that the axis of the tachycardia seemed to be kind of spinning around in space, and that's why they named it this way, torsade de pointe. It's kind of a cool name. But when you look in the textbooks, you'll usually see a polymorphic VTach that gets smaller, and then it gets bigger, and then it gets smaller, and it looks very classic. In all the books, it looks the same, and that's kind of not what this looks like. But it is. It's torsade, trust me. Even though it looks sort of fairly monomorphic in the beginning, clearly the morphology changes, and what's happening is the axis changes, and that makes the QRS much larger initially in this ECG lead, but then when the axis shifts, suddenly the QRS gets much smaller because it's going to be bigger in a different lead, right? So you got this polymorphic non-sustained VT. It can become sustained, and it can sometimes degenerate into ventricular fibrillation. Torsade can. But what's causing it all? Well, this really, really long QT interval, I think in this particular patient, the cause is the drugs. So what you're dealing with here is something called the drug-induced long QT syndrome, Dillquitz. Right, drug-induced long QT syndrome, because Effexor is known to increase QT interval in some patients, and certainly Levaquin has been reported to increase QT intervals. So you got the combination of two agents, and most of these patients actually have the genetic predisposition to reacting badly to these drugs, and that's what causes the QT to get longer. All right, but let's kind of talk about torsade for a couple of minutes. I just want to get you guys thinking, how do you recognize it? Well, we'll get rid of the tracing, and we'll get rid of some of this stuff, and I want to sort of draw a little torsade on the paper here, because torsade has a very characteristic appearance. First of all, when you look at the QRS complex, it's usually narrow, but the QT interval is very long. And that's usually a precursor of torsade. You really have to see a long QT. Sometimes you'll see big U waves, especially. Now, the other thing that's characteristic of torsade is that it's pause dependent. What do I mean by that? Well, what happens to the normal QT interval when rates get faster? Okay, let's think about this. When you have a slow rate, the QT is generally longer. And when you have a faster rate, the QT generally shortens. That's why we correct the QT interval by using this QTC, or corrected QT interval. So generally, after a long pause, the QT will usually get longer. But in torsade, you'll see that the T wave becomes really bizarre after a pause. So let's say you have a PVC here, and then you have a compensatory pause. After that pause, the normal beat comes in, but if you look at that T wave, it's really big and long and with crazy U waves and so forth. And then what you usually see is the first beat of the tachycardia arrives from the T wave, or from the TU complex. And the first beat of the tachycardia arises from the T. So because the QT is long, what that tells you is the first beat of the tachycardia is widely coupled, sometimes 600 milliseconds, which is equal to 100 beats per minute. That's common. So you see this widely coupled beat. That's the first beat of the tachycardia because it's arising from this QT complex, which is very long because it's following this pause. So you've got the long QT, you've got the pause dependence, you've got the bizarre T wave after a pause, and the first beat of tachycardia is widely coupled and it rises from the TU complex, and of course it's polymorphic at rates usually in the range of 150 to 200, sometimes 220 beats per minute. So this is classically what torsade comes from. And if you guys want to do some more research into early after depolarizations, if you do a cell membrane, transmembrane potential, it's these early after depolarizations that cause the beats in torsade. But if you go on my website, I'll be talking about mechanisms of arrhythmias, and triggered activity or early after depolarization is going to be part of that discussion. So stay tuned for that. In the meantime, if we get rid of this and bring our tracing back, you'll see that indeed following this pause, you have a very long, bizarre T wave with a QT interval of 700 milliseconds. The first beat of the tachycardia arises, a very long coupling interval, and you've got this periods of monomorphic looking, but it really is polymorphic because these beats are much bigger, then it gets smaller, then it gets much smaller, and then of course it gets bigger again. So you got this polymorphic VTAC. This is classic torsade, but it doesn't look like the textbook. That's what I'm trying to do, is get you guys to understand that not every ECG looks the same. They don't all look like the textbooks, and that's why you need to watch these Chalk Talks and go on to Ecg Academy. So let's figure out what the answer to the question is. It's not A, because we've already figured out it's not artifact. You wouldn't give IV cardizem because it's not an atrial arrhythmia and you're not trying to block the AV node. You certainly would not give amiodarone, because what does amiodarone do? It increases the QT interval, and that would just make things worse. The answer is none of the above. What you would give for torsade is magnesium. That's right, a couple of grams of magnesium will help to settle this down. Of course, you remove the offending agent, and you get the patient stabilized in intensive care. It's a serious problem, but it is reversible. So that's Chalk Talk number 9. Remember, go to ecgacademy.com to learn everything from basic to advanced, to read ECGs. I do want to make you become an ECG expert, but also subscribe to my YouTube ECG Doc channel so you'll be informed as soon as I do my next Chalk Talk. Meanwhile, thanks for listening. See you soon. Hey, this is Dr. Nick with Rhythm Chalk Talk number 10. I just wanted to get you guys used to reading more difficult tracings. We'll call this intermediate, but it is a 12 lead and it's an interesting rhythm problem. So let's get to it. Looking at the 12 lead, you can notice that there is an irregularity to it, but we talk about regularly irregular or irregularly irregular, and I think what you guys should be able to recognize is that there are groups of two. There's group beating with 2 beats followed by a pause and 2 beats followed by a pause. If you kind of look at the first beat, you can see the P wave is upright in 1. There's a bit of a first degree AV block. In fact, it's quite a first degree AV block. The measure is about 280 or 300 milliseconds if you take calipers to it. And if you look at AVF, you have an upright P wave here. So it does seem to be a sinus mechanism of some kind, because the P's are up in 1 and AVF. And when you're looking at the 12 lead on the whole, you can see the voltage is extremely generous. You clearly have criteria for LVH with a very deep S wave in V2 and a tall R wave in V6. Plus, you've got this characteristic strain pattern in the ST segments and the T waves. So you can call it LVH with strain, and I think you could probably look at this P wave in V1 and decide this possible left atrial enlargement, because you've got, a fairly hefty negative deflection at the end that's 1 box wide and 1 box deep. But the hardest part is figuring out the rhythm. And if you look at the PR interval of this second beat, it clearly looks like it's getting long, right? Well, where exactly is the P wave, though? I just want you guys to be clear about it, because remember, P waves kind of give you a very sharp deflection because they have high frequency signals. And when you look at this T wave, you see it's nice and smooth. And when you look at the T wave of this beat, you can see there's a very large bump right here at the tail end of the T wave. So I would say this is the start of the P wave in this beat, and the PR clearly gets longer compared with this PR interval. Yes, you can say calipers if you don't trust me, but my eyes are looking at this and say this is almost 360 milliseconds, very long. So, okay, you got group beating, you've got pauses, you've got PRs that are getting longer. So what do you think? This is probably type, what would it be? Type 1 or 2? Type 1, second degree AV block. Well, if you said that, you are wrong. Nope. Fooled ya. Okay, so why not? Why isn't this type 1 second degree AV block? Clearly, the P is getting longer. You've got group beating. Well, let's take out our trusty calipers and figure it out. What should we be looking for with our calipers? Well, one thing's for sure. We should be able to see that, well, for one, let's look at the P to P interval. So we'll come down here. So there's about more or less the P to P interval, right? And so let's look at the next sinus P wave, and wait a minute, where is it? Hold on. We know that there's a nice smooth T wave here. We can see this is the P to P interval, but there doesn't seem to be a P wave here. After all, you would think that there should be, I should be writing a P here that blocks, and then it all starts all over again with, the PR getting longer, and then a P here that blocks, but there's no P. Okay, so this is a very common problem. We see it all the time. People make the mistake of calling this second degree AV block, but it's not. If it was second degree AV block, where's the P that didn't conduct, right? We should have a P wave that blocked, but it didn't. So how do we explain this? Well, since the P to P interval is clearly not marching through, what's the next likely diagnosis? Well, I'll tell you what this is. This is a sinus beat, and this is a sinus beat. And if you kind of figure out what's in between, the next sinus beat should have fallen here, but it didn't. It came here. Okay, so it's not a sinus beat. It's premature. So this is a PAC. It's an atrial premature beat that landed on the T wave. It conducted with a first degree AV block much longer than the underlying first degree AV block. Why? Because remember, the AV node doesn't conduct as well at faster rates or shorter coupling intervals because it's calcium dependent. We talk about that in the physiology of the AV node. So this P wave was a premature atrial contraction, or APC, whatever you want to call it, and it conducts with a first degree. And then what happens? You get a compensatory pause, and there's no other P wave in here. There's no P at all. What you get is the next sinus beat and then the next PAC. Okay, so you have a pattern of a sinus beat, PAC, pause, compensatory pause, sinus beat, PAC, compensatory pause. What do we call the pattern when an ectopic beat occurs every other? It's bigeminy. I think we've seen this before. This is atrial bigeminy with a first degree AV block. But there's no second degree AV block here. All the P waves conduct. What you have is a first degree AV block, but the bigeminal pattern makes you think that it's Wenke back 3-2, but it's not. It's a common mistake that people make, and I wanted you guys to see this. We had seen atrial bigeminy in the past that was non-conducted, but these all conduct, and it gives the appearance of a second degree AV block, but it's not. So I hope that was helpful. It was kind of fun. So remember, log on to ecgacademy.com for the basic ECG lessons that will take you all the way through arrhythmias, 12-lead ECGs, up to advanced stuff. In the meantime, keep watching on YouTube, and I'll keep posting videos so that I can help you become an ECG expert too. Thanks for watching. Hi, this is Dr. Nick, and we're going to be doing a Chalk Talk today. I've been trying very hard to get the Ecg Academy up and running, but I thought I'd leave a Chalk Talk on YouTube so all of my subscribers would get to learn a little something else today. Remember, chalk talks are for people who know the basics, but they're designed to get you used to reading more difficult tracings. So here's a rhythm strip that I got from our CCU. So remember, look at the forest first, and as you scan across, you can see there are QRS complexes that seem to be marching through at a regular rate, except for this one. This one is clearly premature, and I think we'll come back to that. There does seem to be a compensatory pause afterwards. So now let's look for P waves. If you kind of look in front of the QRS complex, you don't see much, but as you scan in between beats, there does appear to be a bump right there that seems like it could be a P wave. And if you look at some of the other beats in the same general region, you'll see that there seems to be a regular P wave that marching on through. So let's start to measure intervals. We take the beginning of the P wave on this heavy line, and you can see the PR interval is about 400 milliseconds. Pretty long, and since it's greater than 200, we call it a first-degree AV block, and it looks to be pretty constant. Let's bring out our calipers. You can put the calipers on the tip of the P wave or the beginning, depends on what you see best, but there definitely seems to be P waves mapping on through. Now let's pay attention to this beat right here. We've already established, using our calipers, that this P wave occurs on time, does it not? Because my calipers mapped it on through, and this P wave occurs on time. So where did this QRS complex come from? Well, it has to be a premature ventricular contraction, or PVC. Some people like to say ventricular premature contraction, or VPC. Why? Well, first of all, the QRS complex looks different than the underlying QRS complexes, so it certainly did not take the normal electrical pathways down the bundle branches. The other thing is that the PR interval here, from the beginning of this P wave to the beginning of the QRS complex, is way, way, way too short. This P wave couldn't possibly have conducted, so this QRS complex must have originated from the ventricles and did not arise from this P wave. Well, the next P wave does occur on time, and then you have a PR interval that's a little bit shorter. Look at that. It's about one small box shorter, so we'll call this 360 milliseconds. And this one's back to 400 again. Well, does that make sense? It sure does. That's because after this bit of a pause, the AV node has a little bit of a break, and so it's able to conduct this P wave a little bit more efficiently at a somewhat shorter PR interval than this one. This is not the same as Winky back, but it is a reflection that the AV node conducts better at slower rates and worse at faster rates. And the coupling interval from one beat to the next certainly plays a role in how the AV node conducts. Now here's the question, and when I look at a strip like this, I always have to wonder, am I missing something? Because we'd normally say, all right, this looks like a sinus rhythm with a first-degree AV block and a PVC here, but am I missing something? Because the way the location of this P wave, it's right smack in between the two QRS complexes. And when I look at a strip like this as an ECG expert, I always wonder, could there be another P wave buried in this QRS complex? In other words, could this be some kind of atrial tachycardia with 2-to-1 conduction? With an atrial rate, well, what is the rate here? 300, 150, 175. So could this actually be an atrial rate of 150 with a long first degree because of the rapid rate? And am I missing a P wave in between? Well, prove it to me. Prove to me that there's no P wave in there. Prove to me this isn't 2-to-1 conduction. Well, I'll show you how to do that. The PVC is the key. Here, let me just erase some of this. The PVC is the key because the PVC disturbs the cadence. It throws the rhythm off. And because we presume that there may be a P wave buried in this QRS complex, well, the next QRS complex should have landed here. Let's take our calipers and measure the QRSs now. So if you have a QRS here to here, the next one should have landed here. So if we presume that there may be a second P wave that is occurring in the middle of the QRS complex, this PVC would not have interfered with the atrial rhythm. And so you would have seen a P wave right here, and I do not see it. Remember, P waves have a rapid deflection. They have high frequency components, and you would see that T wave would have a little bump on it, and it does not. So I think we've proven that these are the only P waves. We just have sinus rhythm with first degree. The idea that this was 2-to-1 conduction has now been disproven, and I think this was kind of a neat tracing, don't you? Well, this is Dr. Nick from the Ecg Academy. Thanks for watching, and remember, log on to ecgacademy.com because by the third week in December, I should be offering a basic subscription to those of you who want to become ECG experts like me. In the meantime, thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and I couldn't wait to put this Chalk Talk together because when I saw this strip, I thought, wow, this is great. Anyway, please watch this video to the very end. Don't assume that you know the answer because I think you'll be surprised. Anyway, this was a strip that I got from the coronary care unit. When you take a look at the forest, you see that the beginning, the QRSs look fairly regular. If you calculate the rate here, it's 300, 150, 100, maybe about 90, 95 beats per minute. And you can see P waves in front of these beats here, and they look fairly consistent with a PR interval in the range of about 160 milliseconds. So we have a normal sinus rhythm with a normal AV conduction. But here, there seems to be a change in the appearance of the cardiogram. And the reason I was asked to see the patient is because they developed this sawtooth electrical disturbance here that looks pretty apparent on the cardiogram. And if you look for the atrial rate, it's about 250 beats per minute. And then it seems to go away at the end. Here's a normal P wave. And you can see the very onset of the QRS, and that looks like a normal beat here. And in fact, what the nurses did was they very nicely labeled this strip for me. A 5-second run of atrial flutter. I didn't write this, so I can't take responsibility for the spelling. It says 8 beats and back to sinus rhythm. That's why they asked for a consult. Let's talk about the physiology of atrial arrhythmias, and we'll start with the atria. Of course, you've got a left and a right atrium, and you've got the ventricles on the bottom here. What happens during atrial flutter is a premature beat somewhere arises. Could be the right side, could be left side, but that premature beat somehow finds a groove. It finds a pathway to get stuck and go round and round and round. And because the electrical signal is traveling round and round the same pathway with each beat, we consider this an organized atrial arrhythmia, and the electrical signal that's inscribed every time the signal goes around in the circle gives us a kind of a sawtooth pattern that I like to call the Black and Decker syndrome, because there's these discrete sawtooth signals that look the same every time the signal goes around. But generally, there is a premature beat, and you can identify the beginning of the electrical signal by the fact that it starts prematurely, and then you get this atrial flutter signal. Now, what happens to the sinus node during atrial flutter? Well, the sinus node here up in the right atrium basically gets suppressed by these rapid flutter waves. These rapid signals enter the sinus node and reset it. And as I mentioned in my physiologic lessons in the basic course, the sinus node, like most tissues within the heart muscle, exhibits something called overdrive suppression. And overdrive suppression simply means when the tissue is stimulated more rapidly than it wants to go, the automaticity or the ability of that tissue to fire gets suppressed. So the rapid atrial flutter rate suppresses the sinus node. Well, what happens when the atrial flutter stops? Well, then what happens is you have a period of time, usually a second or two, that it takes for the sinus node to wake up again. And that's what gives rise to what are known as post-tachycardia pauses. It's usually a second or two. In people with sick sinus syndrome, it could be much longer. The other thing that you have to talk about is what happens to the AV node with all this stuff. The AV node, as you know, doesn't conduct rapid signals very well. So when this premature beat occurs, there may be some delay in the AV node, and often PACs will occur with a first-degree AV block, but not much of a first-degree AV block. That signal eventually gets to the ventricles. But then now you have this atrial rate of about 250 beats per minute. And with that kind of atrial rate, the AV node can't possibly conduct every single one. So what happens in a healthy heart is that maybe every other impulse gets through, and you have a ventricular rate of maybe 125 beats per minute. In other situations, maybe every third one gets through, and that gives you something around 82 beats per minute. But somewhere in there, you're going to see a change in heart rate, usually an increase in rate, because the atrial rate has gone up dramatically. Well, now let's go back to this strip and see what's happening. In the beginning, as I mentioned, you have these normal P waves and the QRS complex, and then you have a fairly flat ST segment and a T wave. And now this P wave comes in, a QRS, and now on top of this T wave, there's a little bit of a bump. And that bump seems to go down and then up and then down, and then you have this fluttery-looking sawtooth pattern start. So it seems to start here someplace. If this is the PAC that starts the flutter, then why did this QRS complex occur so late? In fact, if we take our calipers out, we see that this QRS and this QRS came at the exact same interval. So this beat actually occurred on time, despite the fact that you have flutter waves that seem to start way back here. Now what happens to the QRS complexes is as you map them through, the rate does not change at all. So you're not getting 2-to-1 conduction, you're not getting 3-to-1 conduction, you're not seeing heart rates in the hundreds or anything. The ventricular rate stays at 90. And then at the end of it, you actually can see that this beat, this first beat here, which clearly has a P wave in front of it, occurs on time. And in fact, if you measure back from that P wave, it looks like this signal right here is also a P wave that looks exactly the same as this one. So how can you have an atrial premature beat that sets off atrial flutter that does not affect the timing of the QRS complex? How can you have atrial flutter that does not change the ventricular rate? And then how can you have atrial flutter that stops suddenly and then immediately a normal sinus P wave kicks in with no compensatory pause and no change in the sinus rate? The only explanation is that this is artifact. This is absolutely external noise that was introduced either by patient movement or the wires or something. Even though it looks convincingly like atrial flutter, it's not real. And every physician I show this to will swear up and down that this is atrial flutter, but it's not. Anyway, I think this is a great example of why you need to continue to subscribe to Chalk Talks and let me help you become an ECG expert too. So for the Ecg Academy, this is Dr. Nick. Thanks for subscribing. Hi, this is Dr. Nick with the Ecg Academy, and this Chalk Talk goes out to all my subscribers on YouTube. Thanks for subscribing. I'm glad you liked my Chalk Talk so much. Just remember, if you'd like to receive a new one every single week, you can subscribe to ecgacademy.com, and I'll go over strips from basic to advanced and make you into an ECG expert. Anyway, this was a great strip that I found on the telemetry unit. In fact, I was asked to do a consult on this patient for bradycardia. And when you look at this top strip, you can see that indeed the heart rate is pretty slow. It's so slow, in fact, we have to kind of measure time instead of counting off rates. So 1, 2, 3, 4, that's 1 second. 1, 2, 3, 4, that would be 2 seconds, which would make 30 beats per minute. So it's really about 35 beats per minute or so. And what the nurse wrote was heart rate down to 33, and she called it a junctional rhythm. Well, just remember Tulow's law. Don't ever believe anything you read on a rhythm strip unless you wrote it yourself. But when we look at these QRS complexes, they do look a little bit wide, but not excessively. And when you look in front of them, there does seem to be a small deflection in front of each QRS complex. In fact, the nurse was kind enough to circle this one. And so I'm not sure why it would be a junctional rhythm. For a junctional rhythm, you'd expect to not see any atrial activity prior to the QRS complex. You'd expect the P wave to be in the middle of the QRS or just after it. But there do appear to be P waves pretty consistently here, and you'd be tempted to call this sinus bradycardia at 35 beats per minute. But let's take a look at another rhythm strip. And what's the difference between this one and this one? Do you notice any difference in the way it looks? It's the same lead, but what they did was they increased the gain. They turned up the volume. And so this QRS complex is much bigger. And so the P wave is much bigger. In fact, the nurse was very nice to circle it for you. She circled all these P waves here so that you can pay attention to what she thought was important. She called it sinus bradycardia, 33 beats per minute with a PVC. Well, where's the PVC? This is the PVC, and I agree with that. You have a sinus P wave and a QRS, and then there seems to be no P wave preceding this beat. In fact, what you do see is a retrograde P wave in the middle of the ST segment. So I agree this is a PVC. Then there's a compensatory pause, and then you have this P wave and this slow rhythm coming in at a rather slow rate. But if you notice, she said it lasted 6 seconds and then the heart rate increased to 62. Well, look at the end of this strip.
at the end of the strip, you have the same P waves occurring, but if we take out some calipers and measure the P to P interval, move the caliper to a heavy line and count off, it's 300, 150, 100, 75, 60. So yes, indeed, it's about 60 beats per minute here. Well, what happened before this? Well, see, what you need to do is pay attention to the ST segments. If you look at this ST segment and this one over here and compare it with this one, what do you see? It should stick out like a sore thumb right there. That looks like a P wave to me. And so does this. And in fact, if you look at these ST segments, I think there's a high frequency deflection here that was missed because the gain was too low. Now, the corollary to Tulow's rule, which is that you should never believe anything you read on an ECG, is that if anything is circled, it usually distracts you from the important part. And that's just it. These little red pen circles here distract you from this part, which is the important part. In fact, what you have here is non-conducted atrial bigeminy. You remember bigeminy is a situation where every other beat is premature. You have a normal P wave, and then you have a PAC. And then you have a normal P wave, and you have a PAC. And that's what's happening up here, except it's happening throughout the whole strip, and it makes it appear like there's sinus bradycardia going on. But in fact, when you measure back from this P wave, and you know what the normal P to P interval is here, that means the sinus node was reset at this moment. And so this P wave got into the sinus node, managed to reset it, and then the sinus node fired pretty much on time right here. So in fact, the sinus node is in pretty good shape. And this slow heartbeat is just simply because of these non-conducted APCs. I like to say non-conducted rather than blocked because the AV node is supposed to prevent excessively rapid signals from getting to the ventricle. That's how it protects the ventricle against going too rapidly. So there's a certain refractory period after the AV node conducts this signal, and that AV node is unable to pass this P wave down until the refractoriness resolves. We talk about this in the basic section in AV block in quite a bit of detail. So if you're interested in this, you can log on to ecgacademy.com and look into subscribing to the basic section, where there's almost 10 hours of video lessons, which will give you a very solid foundation on evaluating almost any arrhythmia you might come across. Well, I hope this Chalk Talk was enlightening and give you a little bit more insight into what you need to be looking for in these rhythm strips, because I do want to turn you into an ECG expert. So for the Ecg Academy, this is Dr. Nick. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and I want to thank you again for subscribing to these Chalk Talks. I enjoy putting them together, and I'll try to keep you thinking. Anyway, imagine a nurse hands you a rhythm strip, and the history is that the patient is from a nursing home and seems a bit agitated, and they notice that the heart rate was quite fast on the monitor. And here's the strip that she hands you. So as you look across the forest, you can see that it seems to be a regular rhythm, and if you look for a QRS that lands on a heavy line, and try to figure out what the rate is, you get 300, 150, and it's a little bit slower than that, one small box bigger, so it's about 140 beats per minute. And the QRS duration is about 110 milliseconds. It's not quite 3 small boxes. So the next step really should be to look for P waves. So the best place to look, of course, is in front of each QRS complex. And there seems to be a bump right here, and when you look at the other QRS complexes, it seems to be quite consistent. If you measure this interval from the beginning of this bump to the QRS complex, it's about 140 milliseconds, and so it would be a physiologic PR interval. So if you were just reading this rhythm strip, you might be tempted to simply call this sinus tachycardia at 140 beats per minute with a PR interval of 140. The one thing that doesn't fit here, that the AV node doesn't really conduct well at fast heart rates. So you have a heart rate of 140, but yet the PR is still relatively short. And what you need to ask the nurse is, how did this start? Remember, Tulow's law is that you should never believe anything that's written on a rhythm strip unless you wrote it yourself. Well, the second corollary to that law is that someone will usually discard the part of the strip that's important. That is, the beginning of the tachycardia and the end of the tachycardia. When you just look in the middle, it's really hard to figure out what it is. So if I show you the whole strip, now here's what you were looking at before, and you can see what looks like what could be sinus tachycardia. But come up here to this beginning of this strip where the patient's actually in sinus rhythm. And here their sinus rate is relatively slow, 300, 150, 100, 75, 60. It's just a little bit above 50, maybe 51 or 52 beats per minute. Where's the P wave? Here it is. But look at that PR interval. It's actually more than 200 milliseconds. It's more like 240 milliseconds. And so this patient already has some first-degree AV block that's going on. So how can they develop a tachycardia with a short PR interval like this? The answer is this is not the P wave. Because if you look at the QRS complex, and then you see the ST segment and the T wave, and look at this beat, you have an ST segment and a T wave, but look right here, this appears to be a P wave that starts this tachycardia off, and following this QRS complex, you see a bump here that's exactly the same as this T wave. And so the bump is the T wave. You can see it's quite far away from the following QRS complex, but with the next beat, this T wave bump closes in because the QRS comes earlier. The patient is now in a supraventricular tachycardia, but this bump actually is the T wave of the preceding QRS complex. Here you have the ST and the T wave, and in fact, this was a patient with AV nodal reentry tachycardia where the P waves were not visible during tachycardia. These T waves masqueraded as Ps, but the Ps were actually buried within the QRS complex. The point of this chalk talk is to always ask for the beginning of the strip, even if you have to go back into the monitor, dive into the total recall, and find out where it started. That really will give you the answer. You had a sudden onset of tachycardia with a little bit of a warm-up, and then you have an SVT that slowly builds up over a few seconds, but the P waves are not visible. But the beginning really tells the story, doesn't it? So always look for the beginning of any tachycardia. It holds important clues to the mechanism. And with that, I'll end this chalk talk. This is Dr. Nick for the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a bit of a challenge on the 12-lead category, not so much because of the rhythm, but because I want you to learn to start recognizing where beats are coming from. So we'll get right to it. Now this ECG, if you look down here in the rhythm strip, seems to have a bit of a funky pattern to it. There are these wide-looking, bizarre, crazy beats, and they look to be fairly regular across the strip. But then there are these narrow beats in between, and you have a pattern of 1 narrow, 2 narrow, and a premature, 1, 2, and a premature. So it seems that every third beat is this wide, bizarre-looking QRS complex. So this pattern, as you know, is called trigeminy, and it can be atrial or it can be ventricular. So let's take a closer look at some of the trees here. We'll zoom in on this rhythm strip. And what we can see are these narrow QRS complexes. This one happens to start on a thin line, and we can count up 1, 2, about 2.5 small boxes, maybe a hair less. So that's about 100 milliseconds, the QRS complex. The QT is one small box in front of this heavy line, and the QRS is starting one small box ahead of it. So that's 400 milliseconds minus 2 small boxes, which is 80, so that gives us 320 for the QT interval. And now let's take a close look at the P wave. Now the P wave starts around here, so the PR interval is about 3.5 small boxes or 140 milliseconds. And when we look at this beat, it really looks quite similar. You have a very nice P wave, a narrow QRS, and then the T wave looks the same. Now this T wave looks the same as this T wave, but now you have this wide QRS beat, and it conveniently lands on a heavy line, and where the ST segment seems to start right about here, that's the J point, and that gives us a QRS duration of about 180 milliseconds. It's pretty wide. Now, where would the P wave normally fall? Because that'll help us figure out if this is atrial or ventricular. Because as far as I can tell, there's no P wave right here, which would make this a ventricular premature beat since there's no atrial activity in front of it. Well, let's take out our trusty calipers, and if we move them down to the P to P interval, which we'll set from one P to another, and we can set the first point on a heavy line and measure the rate, 300, 150, 100, 75. That's about 88 beats per minute. As you know, we can always count up the milliseconds and divide into 60,000. So if you have a calculator, it's 60,000 divided by 680, which gives us 88.2. So I was pretty close just guesstimating. Anyway, what we do with our calipers now is bring it down to this P wave and figure out where the next one would fall. And as you can see, if I erase this little purple circle here, that the P wave would have started right at the onset of this QRS complex. We don't see anything before it, We don't see a bite or a sharp spot on this T wave where we would consider maybe an atrial premature beat that conducted with a bundle branch block. So if the P wave would have been here, let's see where the next P wave falls. So we'll move our calipers over, and we see that the next P wave pretty much occurs on time. So all of this is starting to look like the P to P interval is perfectly regular, but you have these wide QRS beats that must be ventricular premature beats. So going back to this original tracing, it would appear that we have upright P waves in 1 and AVF. So we have a normal sinus rhythm at 88 beats per minute with ventricular trigeminy. But really, that's not the whole story, because what I want you to start to think about is, where are these PVCs coming from? Where in the heart are these originating from? And we have to start thinking a little bit more carefully about axis and vectors and directions within the heart. So if we just answer the question of where is the normal axis in this patient, look at these normally conducted QRS complexes, and the one that's most isoelectric is AVL. So in our circle, if this is 1, AVL is 30 degrees above the horizontal, heading towards the left arm. So our axis would be perpendicular to that. That would be 60 degrees below the horizontal. That would be plus 60. And we can confirm because it's positive in the inferior leads, so it has to be going towards the feet. So the axis of the normal QRS complex is plus 60. But what about the PVCs? What's the axis of the PVCs? You'd say, what do you mean? I'd say, well, take a look at the PVCs and try to figure out what direction they're headed. So you can see they're very, very tall in the inferior leads, 2, 3, and AVF. They're very small in lead 1, so that's close to being isoelectric. And it's close to being isoelectric in AVL as well. So I would say that the axis lies somewhere between the perpendiculars of 1 and AVL. So we know that if it's perpendicular to 1, that is if lead 1 was most isoelectric, and that would give us an axis of plus 90, and we know already that AVL is plus 60, so the axis of these PVCs is about plus 75. It's really kind of headed towards the feet. Not much different than the underlying QRS complexes, but it starts to give us a sense of where they're coming from. These electrical signals are headed towards the feet. Now the next question we want to ask is, what ventricle do you think these PVCs are coming from? And you think, what do you mean, what ventricle? They're ventricular, aren't they? Well, yes, but which ventricle? Are these left ventricular PVCs? Are they right ventricular PVCs? Or maybe they're coming from the septum? They're pretty wide, and septal PVCs tend to be more narrow because they begin to penetrate the conduction system, and the QRS complex may consist partways of rapidly conducting Purkinje signals. So septal PVCs tend to be more narrow. This being pretty wide, I'd say it's not coming from the septum. Now here's a general guideline. If you look at V1 and it looks more like a left bundle branch block pattern, then it's coming from the right ventricle. On the other hand, if V1 looks more like a right bundle branch block, then it's coming from the left ventricle. Does that make sense? Well, it does in a way, and I'll show you why. All right, if you think about the heart, and here's my John Nagy heart. I don't know if any of you remember John Nagy. So here's your left ventricle, and here's your right ventricle over here, and your Purkinje fibers are coming down from your AV node, and you have your main bundle of His and your right bundle branch, and then your left, which splits up into hemifascicles and so forth. Okay, now, if a ventricular premature beat arises from somewhere here in the left ventricle, the left ventricle depolarizes fairly early, and the right ventricle winds up depolarizing late through intramyocardial pathways. And so what happens is you get a lot of late signals heading towards the front of the heart. If you remember, if this is a section across the chest, with this being the spine and this being the sternum, the right ventricle is in the front part of the heart here, whereas the left ventricle is behind the right ventricle. So what you have are late forces heading towards V1 and V2. And what that gives you is a positive deflection in V1 if the PVC is arising from the left side of the heart. Now, these are general rules. They not 100%, but it gives you an idea of where it may be coming from. Now take the other situation where maybe now you have a PVC arising from the right side of the heart. the right ventricle will depolarize fairly early, and what you'll get is slow, gradual conduction across the left side, just like you had a left bundle branch block. And so with right ventricular PVCs, V1 will tend to maybe have a little R wave, but a very broad, deep S wave, and look a lot like a left bundle branch block. So think in terms of V1. If it looks like a left bundle, it's coming from the right ventricle. And if it looks like a right bundle branch block, then it's coming from the left ventricle. Get it? So back to this ECG. What do we have here? We have a QRS complex in V1 that looks a lot like a left bundle branch block pattern. And we have an inferiorward axis heading towards the feet with markedly positive QRS complexes in 2, 3, and AVF. This is a very characteristic morphology for PVCs that are arising from the right ventricular outflow tract. Now, where is that exactly? Well, if we take our heart and just look at the right side of the heart, okay, because we're dealing with right ventricular PVCs, if we just redraw the right side of the heart, okay, so here's the superior vena cava coming down. You have your right atrium, your inferior vena cava, and so here's your right atrial chamber. You have your tricuspid valve that leads to the right ventricle, and then, of course, the blood has to leave the right ventricle, so you have the pulmonic valve leading out the pulmonary artery, which goes out to the lungs. The area that we're interested in is right here below the pulmonic valve, both on the anterior side and as well as on the septum. Remember, the left ventricle is over here someplace. So this part of the right ventricle is really the septal area of the right ventricle. So right below the valve here is where these PVCs tend to come from. It's an extremely common place for PVCs to arise when you see tens of thousands of ectopic beats in one particular patient. Sometimes these patients can walk around with ventricular bigeminy or trigeminy all day long. And so this is the region they're coming from. It's the right ventricular outflow tract. It's just below the pulmonic valve where the blood leaves the right ventricle. So that's the outflow tract. And the region in the right ventricle below the pulmonic valve is generally where these PVCs come from. Okay, so the trick here is to recognize how they look. When you see very frequent PVCs, look at the morphology, figure out where they're coming from. In this case, you can say that these are consistent with the right ventricular outflow tract and the fact that you have ventricular bigeminy. You can often make the clinical diagnosis of frequent ventricular ectopic activity from the RVOT. It's usually benign, but can be very symptomatic, and it can also be a sign of other less common problems like arrhythmogenic right ventricular cardiomyopathy, which we'll talk about in the advanced section of the ECG course. Well, I hope this gave you some food for thought. Until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey, this is Dr. Nick with the Ecg Academy with this week's Chalk Talk. I want to thank you for subscribing to the Chalk Talks here at Ecg Academy, and I promise to keep finding interesting tracings to go over. Anyway, this 12 lead is a little bit of a challenge. If you kind of glance across, for the most part, it looks fairly regular. And if you look for a QRS complex that lands on a heavy line, you can count off 300, 150, and it kind of lands in between 100 and 150. But if you count off two QRS complexes, you can see that this one lands on a heavy line as well. And if you count them both off, 300, 150, 175, 60, so that means that the rate here is 120 beats per minute. So it's tachycardic. If you look at the QRS complex, it's up in 1 in AVF, and so the axis is pretty normal. Looks like lead 3 is probably the most isoelectric. So if you think about the axis, lead 3 is here, and so the axis is about plus 30. Well, now let's start looking for P waves and try to figure out what's happening with that. If you look in front of the QRS complex, you don't really see much of a P wave here. But what you do see are two bumps following the QRS complex in several of these leads over here. So you have to figure out, is one of these bumps a P wave? If it is, then I guess the other bump is the T wave. Well, let's look at V1 because that's always a really great place to look at P waves. And you can see a very sharp spike right here. I would say that it's pretty safe that these sharp spikes are the P waves. Remember that P waves tend to be very sharp and spiky compared with a T wave because they have a lot of high frequency components in them. And the rate of change of voltage is much faster compared with the usual T wave. So yeah, okay, I buy that this is a P wave. And since it comes so soon after the QRS complex, I know a lot of cardiologists would look at this and be tempted to call this an accelerated junctional rhythm, because you have this QRS that's driving along at 120 beats per minute with what looks like retrograde P's over here, because they're kind of upside down in V1 at least. So one of the things you have to think of is some kind of accelerated junctional rhythm. Well, accelerated junctional rhythms rarely get this fast, but you can sometimes see a very slow version of SVT where the retrograde P waves are coming after the QRS complex, sometimes because of an accessory pathway or some other variant of AV nodal reentry tachycardia. We can get into the different varieties of AV nodal reentry in the advanced course. But, that's not what this is. You do see these P waves following every QRS. But as I said, after you look at the forest, you have to be very careful to look at the trees. Let's come down here in the rhythm strip. And if you see that this QRS complex is followed by this double bump, and so is this QRS complex followed by a double bump, this one as well. But now what's happening is that first bump is beginning to fuse with the QRS complex. And in this beat, that first bump is completely fused with the QRS complex, and then all of a sudden, it looks like you have a pause. So you have a long R to R interval here, and that proves what this is. The QRS complexes are not driving this arrhythmia, and these are not retrograde P waves, but instead what's happening is you have an atypical winky back. Let me show you what I mean. Let's take our friendly calipers over here and map out these P waves. And the P waves are mapping out the way we'd expect them to if there was a sinus rhythm. But look at here, this P wave actually begins to fuse with the QRS. Why is that? It's because this QRS came late. If you compare this R to R interval with this R to R interval, you see how this QRS came a little bit later? Let's look at this lead here. You have this R to R is quite regular. It looks exactly the same, but this QRS is coming a little bit later. That's why the QRS and this first bump are fusing, because the PR is getting longer. This P wave here is conducting to this QRS. This P wave here is conducting to this QRS. And what's happening is the PR got longer. So this QRS came later and begins to fuse with this P wave. Now this P wave is conducting to this QRS complex. And when we move our calipers from this P to the next P, you see that P is occurring on time. And in fact, the next P occurs on time as well. So the P to P intervals are regular, but the PR got longer. And then suddenly what happens is this P wave right here, which is on time, fails to conduct to the ventricles, and you have block. And then the next P occurs on time with a relatively short PR interval compared with this PR interval. You can see this PR goes from here to here. If we measure that, it's a good 500 milliseconds. This PR shortens up to about 360, and then it gets longer again. And so this P is conducting to here, and it starts the cycle all over again. So what you have really in this segment of the strip is just a very long first-degree AV block, and these are not retrograde P waves. If they were retrograde P waves, they would be inverted in the inferior leads, but you can see that they're upright. So this could be sinus tachycardia, or it could be an ectopic atrial tachycardia at 120 beats per minute or so. But it's conducting mostly with a first-degree AV block, except every now and then what you get is a single dropped P wave, one that fails to conduct to the QRS, and that makes it type 1, second-degree AV block. But because it's not 3 to 2 or 4 to 3 or 7 to 6, it's more like 20 to 19, we consider this atypical winky back. It's one of the varieties that we see when the AV node is mostly able to keep up, but you've got enough conduction delay that every now and then just one impulse fails to get through. And then, of course, you have the pause that refreshes right here, and the PR gets shorter again, although it never really shortens to a normal degree. So there's clearly some degree of AV nodal dysfunction, but the underlying problem may indeed be an atrial tachycardia that has yet to be diagnosed. It kind of depends on the clinical situation. These P waves look like a fairly normal morphology, and the atrial rate, in fact, is about 120 beats a minute, maybe a little bit less than that. So it very well could be sinus tachycardia. But this is an example of atypical wankyback, something we don't see too often, but it will fool a lot of people because if you just look at this part of the strip, it's kind of hard to tell what's driving what. So on that note, I want to thank you again for being a subscriber to the Ecg Academy. This is Dr. Nick. Until next week, thanks for watching. Hey there, it's Dr. Nick with the Ecg Academy with this week's Chalk Talk. I labeled it basic because it's just a rhythm strip, but I think it's kind of interesting, and I want to just go over a few things with you guys. I found this on the telemetry unit, and when you first take a look at it, of course, remember, look at the forest first, and then you can start to study the trees. And you can see these QRS complexes coming through, and they appear to be irregular, with a couple of shorter intervals and then a longer one, and a shorter and longer, and then another short one. So there kind of doesn't seem to be any pattern to it, except, if you start to use your imagination, you might see a pair here and a pair there, but not really a classic case of group beating here. If you look at the right hand of the strip, you can see the rate suddenly slows down. If you measure back from this QRS complex, the rate would be 300, 150, 100, 75, 60, so a little less than that, probably 57 or 58 beats per minute. And in front of these two QRS complexes, it's pretty easy to identify a P wave. Now, the QRS does have a little notch in the beginning of it, so I would call this a nonspecific IVCD. But if you take the beginning of it right about here and the P wave starts right back here, you can see it's greater than one large box. The PR interval is about maybe 260 milliseconds. So it seems like you have a first-degree AV block underlying. But then what is this area here? It's irregularly irregular. It looks like this first beat has a P wave in front of it with a PR interval that's perhaps a little bit shorter, maybe 200 milliseconds here. And then the question is, well, what's happening over here? You have this irregularly irregular rhythm. You've got maybe this is a PAC. Since it seems to come early, it looks a little bit different from this P wave. So if we call this a PAC, and that's where this QRS comes from, then where did this QRS come from? And, a lot of people would look at this and say, well, it's irregularly irregular. It started with a PAC, so it's likely to be atrial. And because there's no pattern to it, perhaps we should call it atrial fibrillation. And in fact, the nurse who labeled this called it a 3.6 second run of atrial fibrillation. Well, remember Tulow's law is that you should never believe anything written on a rhythm strip unless you wrote it yourself. It's time to really take this apart now. I believe that this is a PAC, and here's this QRS complex, which looks exactly the same as this QRS complex, except maybe perhaps a slight shift in the axis, because it's a little bit more above the baseline than below. But then what about this QRS complex? It seems a bit different. This initial notching in the beginning does not seem to be present here. Rather, it goes up. The tail end of the QRS seems to be okay. So you wonder, well, what made this QRS complex different? It certainly doesn't seem to be particularly early. I mean, some people would say, well, you have to watch out for aberrant conduction during some kind of atrial arrhythmia. So could this QRS be wider because of aberrant conduction? Well, if we look at the next QRS complex, it's kind of back to the original morphology. And then you have to wonder, well, what made this QRS look funny? Well, if you look back, you can see what looks like a P wave here. Let me just erase that. I think this is a P wave. And now it's time to get out your trusty calipers. If you bring your calipers down to that first P wave and set the tip for the second P wave, and then move it over, you can see that it would land right in the middle of this QRS complex. And then if you shift it over one more time, you see what looks like yet another P wave, because this T wave clearly looks different from the previous T wave. Essentially what you have is a squiggle right over here, which times out to these other P waves. What I'm getting at is that I believe that there's a P wave right in here someplace that's deforming the QRS complex. And if you take these calipers and move them over again, you see that there's another P that comes right after this QRS complex. And then if you move it over again, you see that there's this fairly regular atrial tachyarrhythmia. How fast is that going? Well, pick up our tip of the calipers, put it on a heavy line, and you can see it's going a little bit faster than 150, maybe about 155 beats per minute. In fact, it starts to slow down here. If I put it on this P wave, then you can see that it's beginning to slow down. If I put it on here, you can see that the cycle length is getting to be significantly slower. But essentially what you have is a run of atrial tachycardia at about 150 beats per minute from here to here, here and here, here and here. Now it starts to slow down a little bit here. You can see a P, and then here there's this P wave. And then if you map these calipers out, there's this P times out a little bit slow, but then there should be a P wave right here, and you don't really see one. Well, that explains why the tachycardia ends, and you have this compensatory pause, and then, of course, what looks like a sinus rhythm here, a sinus bradycardia, with the first degree AV block takes over. Well, what you really should try to do is figure out what's the relationship between the P's and the QRSs. Try to figure out what's conducting and what's not. So let's turn all this stuff off and go back and figure that out. So this P obviously conducted to this QRS complex. Did this P conduct? Well, it had to, because the next one we know is buried in the QRS, so it couldn't have resulted in this QRS complex. This QRS had to come from this P wave. So we have prolongation of the PR, and this is the P wave that blocks, because there's no QRS following it, and it makes sense that this is the P wave that is responsible for this QRS complex. The next P is not followed by a QRS complex. You have to assume that this one came from this P wave, because this would be a little long for it to conduct, and then you really can't explain where this one went to. So this one blocked, and this one conducts. This one conducts with a longer first degree. This one blocks. You see how it's all starting to come together? And then this one conducts. This one conducts to this QRS complex. We'll get rid of our calipers. And then that's the last P wave of the tachycardia. That's the last of the Mohicans. And this is the last QRS complex of this run. So what you have here is a run of atrial tachycardia with a little bit of a cool down phenomenon. Remember, warm up means the heart rate speeds up as the arrhythmia gets started, and then we call it a cool down when the arrhythmia slows down towards the end. So you have this atrial tachycardia with a little bit of a cool down at the end, and you have some winky back. This is a 3 to 2 winky back cycle, and then some 2 to 1 conduction, so it's high grade block right here. Yet this one blocks, this one conducts, this one blocks, this one conducts. And then you have another 3 to 2 cycle and another 3 to 2 cycle. So basically this is, some people would call this PAT with block. I would prefer not to use the term block, because at a rate of 150 beats per minute, you wouldn't expect the AV node to be particularly happy about conducting one-to-one. And because you can see that there is already a first degree AV block underlying, there would appear to be some element of AV nodal conduction disease. But I've seen people who have arrhythmias like this, and they're mistakenly diagnosed with atrial fibrillation, and there's a temptation to put these patients on anticoagulation for stroke prevention. So it's important to very carefully analyze the atrial activity and make sure you know what you're dealing with. In this case, atrial tachycardia does not increase one's risk of stroke or embolic phenomenon, and would be treated differently than atrial fibrillation under the circumstances. I'm just trying to get you guys to focus in on the little details, because that's where the diagnosis will come from. Anyway, I hope that was helpful. This is Dr. Nick with the Ecg Academy. Thanks for subscribing, and I'll see you next week. Hey, this is Dr. Nick with the Ecg Academy, and we're going to do a different kind of chalk talk, because one of my subscribers sent me a couple of cardiograms and he wasn't sure what was going on, and I thought I would go over it with you all. Well, anyway, this is an ECG of the patient in a normal sinus rhythm, and this was the ECG that he sent me. And when you first kind of look at it, it looks like, it's a narrow complex tachycardia. Looks pretty regular when you look at the forest. And so you think, well, this looks like SVT. Well, that might be okay for an emergency room diagnosis, but if you want to be an ECG expert, you got to look a little bit harder. So first, let's take a look at the first tracing, the original one, and let's first see what's happening during sinus rhythm. When we look at this rhythm, let's start at the top here. For you advanced guys, it's pretty easy to see the rate's about 100 beats per minute. You can see a P wave in front of every beat. The PR interval looks pretty normal. Here's a QRS that starts on a heavy line, so reading back the P wave in more than one lead looks to be a little on the short side, actually. I'd call it about 120 milliseconds. Now, what's kind of interesting is the P wave axis, actually, because the P wave is up in one, but when you look at AVF, it really looks isoelectric. In fact, AVF is the most isoelectric of all the leads, and in fact, lead 3 looks negative. So if we think about the P wave axis, if it's isoelectric in AVF, then the axis must be 0 degrees. Well, would you expect a negative P wave in lead 3? Lead 2 goes down and to the left, so lead 3 is 60 degrees above the horizontal this way, and so an axis of 0 degrees is going away from lead 3, and that's why the P wave is inverted here. So think about where this P wave is coming from. Think about the atria, and you think the sinus node is up here, and so you'd expect the normal P wave axis to be down and to the patient's left, but this P wave is traveling kind of horizontally. So it's conceivable that an ectopic focus in the right atrial free wall is giving rise to this rhythm. But in fact, we know that the sinus node is a complex structure that does extend down the crista terminalis, which is the line that separates the trabeculated free wall of the right atrium from the smooth septal wall of the right atrium. So there's this line that runs down the posterolateral wall of the right atrium called the crista terminalis, and the sinus nodal complex does sometimes run down. So could be arising from somewhere near the sinus node or the sinus-nodal complex. Looking at the rest of the tracing, the QRS complex looks fairly normal, except that there's a generous voltage here, V5 and V6, with some ST segment depression, about 1.5 millimeters to 2 millimeters. Somewhat horizontal, but there is a little bit of coving here, a little reminiscent of digoxin effect, but not necessarily. So you've got lateral ST depression. You've got the R wave progression looks pretty good, except some people would have the nerve to call this a possible old septal MI because you're missing the R wave in V1 and V2. Otherwise, this is pretty unremarkable, but keep in mind that PR interval of 120 milliseconds is pretty short. So it would seem to me that this person's AV node is pretty fast. All right, well, let's get to that tachycardia. So here it is, and the heart rate now is a little bit above 150 beats per minute. So you can see a lot of these R to R intervals are 2 boxes apart. And it looks pretty regular until you carefully look at it. Now, before we get to that, let's look at these P waves. What's the P wave axis now? It's still negative in 3. It still looks positive in 1. It's, I think, a little bit more isoelectric in AVF, and it's just as isoelectric in lead 2, positive in AVL. So it's heading towards the lateral leads with a little bit of a shift now. If AVF is headed this way and lead 2 is headed this way, and it's isoelectric, equally isoelectric in both of these leads, then that would make the atrial axis about minus 15. So now it seems like it's coming from a little bit lower on the right atrial free wall, traveling towards the left side because it's positive in 1 in AVL, and it's quite a bit faster than the normal rhythm that we saw before. Yeah, what may stick out, and I'll just mention it briefly, is the ST segment depression is a little bit more pronounced, but those could obviously be just rate-related ST changes because now we're seeing a little bit of it in the inferior leads, so it's becoming a little bit more diffuse, and plus now you have ST segment elevation in V1 and V2, so a lot of this may be just rate related. But let's look a little bit more carefully at this arrhythmia. I'm going to bring the original graphic in, and I'm going to enlarge it. Okay, and let's first take a look at these R to R intervals. Because if you put your calipers down on this R to R interval, measure it, it's a little more than 150 beats per minute. It's about 155, okay? But when you come over to the next R to R interval, look, it's a little bit shorter. But then you come over to this one, and it's back to baseline, but then the next one's a little bit shorter. And what you actually see is an alternating pattern of the R to R intervals, where you have longer and shorter and longer and shorter and longer and shorter. Now, the difference is only about 20 milliseconds. It's very subtle. That's why when you first looked at it, it seemed to be regular, but there is a slight difference in the R to R interval. Well, the question is, why is there a difference, and does that give us a hint of the mechanism of the tachycardia? When you look at the P waves here in lead 2, they do look consistent. Every P wave looks alike, but something has to be changing because the R to R is changing. And what you need to be able to notice is that the PR interval is constant for every beat, and it's still fairly short. It's about maybe 150 milliseconds. But what's happening is the R to P interval is alternating. You see how this ST segment is short? This ST segment is a little bit longer before the P wave comes in. Then the ST is shorter again when the P wave arrives, and now it's longer again. And so what's happening is the R to P interval is changing in an alternans or alternating pattern, but the PR interval is remaining constant. Now, some people would be tempted to think that this is some kind of reciprocating SVT, like some sort of accessory pathway, or perhaps an atypical form of AV nodal reentry. And I can tell you that this alternating pattern is rather unusual for those types of PSVTs. Plus, the P wave axis is very unusual. Remember that in AV nodal reentry, one of the AV nodal pathways is the retrograde limb, with the common form of AV NRT escaping from the region of the fast pathway, and the uncommon form arising from the slow pathway, which is somewhere near the os of the coronary sinus. But either way, the P wave axis is very superior. When it's coming from the AV node, you generally have a marked left axis deviation of the P wave, and it's really pointing more towards the head. So that doesn't go along with this. Now, someone could say, well, maybe there's a right free wall accessory pathway that's somehow plugging into the lateral free wall, and that's why the axis is sort of like rightward. But again, you don't usually see this type of P wave in AVRT, AV reciprocating tachycardia, utilizing accessory pathway. This, of course, would have been a concealed accessory pathway because you don't see overt delta waves on the 12 lead. I told you this was going to be an advanced chalk talk. But my point is that this P wave is really originating somewhere out here and traveling leftward. And it doesn't really go along with an accessory pathway like this. Plus, accessory pathways usually conduct in a fairly fixed manner. They usually don't give you this alternating pattern of longer and shorter and longer and shorter. It's not impossible, but it just doesn't fit. This is in V3. There might have been some thought that perhaps some of these beats were junctional escapes because there seemed to be a P wave here and then no P wave, and then a P wave here and then no P wave. But it turns out that the ones that are missing are here on the top of the T wave. You see how smooth this T wave is and see that that has a little bump in it. And so what you have is a short RP with a P wave that conducts and then a longer RP. So now the P wave becomes more visible. So don't be fooled by the flat part here. This is not a junctional beat, but rather is coming from this P wave that's superimposed on top of the T. So I think as far as the diagnosis of this EKG, we really have to call this an ectopic atrial tachycardia with one-to-one conduction down a very healthy AV node. And the PR interval is still fairly short during the tachycardia, but this alternating pattern is hard to explain. And I think what you have to consider is that we talked about the crista terminalis. The crista is this anatomical line, this ridge on the posterolateral side of the right atrium. And it actually represents a line of fusion in embryology, that the atrium came from two sheets that fused along this line. And this ridge physiologically acts like a functional line of conduction block. That signals at slow rates tend to get a slight delay as they go across this ridge. And for some reason, this area of the heart is very commonly found to be the source of ectopic atrial rhythms like this ectopic atrial tachycardia. Now, potentially this could be a micro reentry circuit involving the crista, or it could be an ectopic focus that's encountering alternating degrees of functional block across the crista, so that one beat gets across it pretty quickly, but that leaves a somewhat refractory region along the crista, so the next beat maybe has to go around a slightly different course, and because of the changing conduction, the next beat is able to go back along the original course, and it basically alternates in this manner in a very small area on the lateral wall of the right atrium. It would take some very detailed electrophysiologic mapping to prove that, and that's obviously beyond the scope of this ECG course. But I wanted to at least give you a sense of what I look for when I begin to read a complex electrocardiogram like this, and give you some practice with these complex arrhythmias. Well, I want to thank Dr. Hassan for supplying us with this very interesting tracing, and I want to thank all of you subscribers out there for continuing to support the ECG Academy. This is Dr. Nick. Until next week, thanks for watching. Hey, this is Dr. Nick with the ECG Academy and this week's Chalk Talk. Thank you all for subscribing to the ECG Academy. These Chalk Talks are designed to keep you thinking, so let's get to it. Now, I think if you look at the whole forest, you see that there's a kind of what looks like a regular rhythm here. There's quite a bit of artifact in this tracing in between beats, so it's kind of even hard to tell what the underlying rhythm is. You might be able to imagine a P wave here, but it's not exactly consistent, except that if we take calipers and we lay these calipers on the R to R interval, you can see the rate here is about 300, 150, 175, 60, just about 60 beats per minute. And if you move it over to the next QRS complex, it maps out nicely, and even this one over here is pretty regular as well. But there's a good chance that this is either a sinus rhythm or perhaps some kind of fixed atrial flutter. That's really the two possibilities. Atrial fibrillation would not be likely because it's so regular. But then what happens over here is you have this sudden increase in the rate of these signals, and the QRS complex appears to become widened. They're so close together that it's hard to tell the rate, so you sometimes have to take two QRS complexes and count off the rate. Well, here's one that lands on close to a heavy line, and if we count 300, 150, 100, and this one's in between, so that's about 125, maybe 120, but since it counts for two R to R intervals, we're talking about 240 beats per minute or so. The question is obviously, what is this rapid wide QRS complex rhythm? Could it be ventricular tachycardia, or could it be some kind of SVT with aberrant conduction? When the telemetry tech or the nurse or the doctor looks at this strip, this should be the second question in their mind. But what is the first question? The first question is this real? Because remember, recording systems are prone to being interfered with by external electromagnetic sources. Why would I even suggest that this might not be real? Well, I'll tell you why. Because as I glance across this, I see a couple of things that bother me. First of all, even though these QRS complexes look fairly regular, some of them are quite a bit wider than others. And I also see this kind of notched beat right here that I see again over here, and I wonder what that is. You might say, well, maybe that's some kind of polymorphic ventricular tachycardia. Here's where the calipers again become very valuable. If you take these calipers and move them over, you'd see that if this rhythm had been continuing, the QRS complex would have landed here someplace. And that's all well and good. But just out of curiosity, let's move the calipers over again. And you notice something. There's a deflection here. And you think, well, maybe that's just a coincidence. But what if we move the calipers over again? Well, now that deflection comes very close to this notched beat. And what if we move it over again? Well, these two notched signals seem to be occurring at the same rate as the underlying rhythm. Well, sometimes it's helpful to take your calipers and stretch them out so that you can actually cover 2 beats. Now what I've done is I've stretched this caliper out to cover 2 beats. And if I put the caliper on this point, it obviously lands in this spot here. But let's take it from this beat. You see how it lands there? And now if we take it from this beat, it lands here. So the point of this strip is that you actually have QRS complexes that are marching through at the same rate as what you saw over here. And you just can't see them because they are obscured by artifact. And that's exactly what this strip is showing. This is a tough one, but recognize what this notching looks like. It's a very, very sharp signal in the middle of a very sinusoidal wide signal. And that's a clue that you may be looking at 2 different signals at the same time. One, of course, being the real one, the QRS complexes that are marching through, and the other being some kind of artifact that's being laid on top of it because the patient is moving around the bed or scratching or shaking the wire for some reason. So just remember to keep these limitations in mind. Always ask that question number 1, is this real? And on that note, I'll sign off for this week. This is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is interesting and provocative. I went to do my usual strip search. That's what I call it when I go through charts looking for interesting strips. And I came upon this one. It's kind of interesting, but I'll give you the history after I'm done going over this strip. So if we kind of look at the forest, we see a couple of beats on this side, and then a long period where there don't seem to be any heartbeats, and then a couple of beats on this side. And so whenever you see a pause, you have to think of 2 different potential causes for a pause. You have to think, is this a sinus node problem, or is this an AV nodal problem? Well, anyway, this really should be the second question you ask yourself. What should be the first question you ask yourself? Is this real, right? Just like the last Chalk Talk, you want to know if this is artifact or not. Because the monitoring equipment that we use is not infallible, and you always have to look at a strip like this and wonder if it's real or not. Well, now let's take a closer look at the trees. And we see these 4 QRS complexes. They seem to be kind of sort of regular in the beginning, but then this interval seems to be a lot shorter with a rate of about 80 or so, and here you have rates quite a bit slower. So I would say it's just slightly irregular. The QRS does appear to be a bit wide. It's at least 120 or 140 milliseconds or so. And you wonder if there's some kind of a bundle branch block pattern going on, because there does appear to be a little bit of notching here. But when we look for atrial activity in front of each beat, what should stick out is the fact that you have a lot of atrial activity in front of each beat, but not in front of this one. So the atrial rhythm seems to be changing. And I hope you guys will notice that there does appear to be a recurring electrical signal here that has a bit of a sawtoothy look to it, but it does seem to change a little. These 1, 2, 3, 4 sawtoothy looking signals don't look the same as this last signal, but I think it's safe to say that this is probably some kind of atrial flutter, except that it changed right here because now you don't see those flutter waves, and this is the last of the beats here. And then there seems to be this long pause. But at the end of the pause, there are 2 beats with very clear, nice P waves in front of them. And these look like sinus beats at a rate of about 60 beats per minute. So the question is, what happened here? And is it real? Well, there are 2 clues that tell you that it really is real. First of all, this flat section here is not truly flat. There is a little bit of a jiggle to it. it kind of drifts up a little bit, and then it drifts down a little bit, and underneath is a little bit of high-frequency electrical noise. Now, if this was truly artifact, it would be the kind of a make-and-break artifact that you might see if one of the electrodes became loose, or if the patient disconnected themselves, or if there was a loss of the connection between the transmitter and the receiver. But if that was the case, if this was truly an artifact, it would be much more likely to be flat. Well, I'll show you what it should look like if it's artifact. It would look like that. Okay? And here's the clue that it would be artifact is that you have this little jiggle, and then suddenly the voltage seems to change almost instantaneously where the electrical signal is broken. Then you have an extraordinarily flat line that stays at exactly the same voltage until some other point here where the signal is actually reconnected, and then you have the rhythm resume. Now, this is artificial. I did this myself with Photoshop. I wanted you to see what a real artifactual make-or-break line would look like, but that's not what we're seeing. Let me get rid of that. So what you're seeing is something that indeed is real. The second hint is that what you have is a change in the rhythm. Here you have what looks like atrial flutter, and here you have a normal sinus rhythm. So the rhythm changed, and you had this enormously long pause. Now, is this AV block? No, because you don't see P waves, you don't see flutter waves, there's no atrial fibrillation here. This is just a little tiny bit of noise. So it's not an AV block kind of situation. It's really a sinus pause, what we call a post-tachycardia pause. It happens because the sinus node exhibits something called overdrive suppression. And especially in the setting of sick sinus syndrome, this overdrive suppression can be enormously exaggerated. So during atrial flutter, the sinus node is getting pelted with rapid electrical signals that suppress the sinus node's automaticity. So the sinus node kind of goes to sleep, and especially when you have sick sinus syndrome, it can suppress it quite a bit, in this case about 6 seconds. Now, when the atrial flutter or fibrillation stops right at this moment somewhere, it takes all this time for the sinus node to finally wake up and start to fire. And this is a very common manifestation of tachycardia bradycardia syndrome. So this is a patient who may not be symptomatic from their atrial arrhythmia, but in fact this woman presented with episodes of staring, and it looked like she'd lost consciousness briefly. Studies long ago showed that it takes a median of 6 to 8 seconds for someone to lose consciousness when their heart suddenly stops. So you need a 6 to 8 second pause for someone to have syncope or fainting, and this just about fits the bill. But this is a post-tachycardia pause due to tachybrady syndrome, and it's as real as they come. And this patient wound up getting a permanent pacemaker, and she should do just fine. So I hope that cleared up a few things about pauses and artifact and tachybrady syndrome. Until next week, this is Dr. Nick with the Ecg Academy. Thanks for subscribing. Hey, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk covers a very common problem, namely a wide QRS tachycardia. We went over this in detail in the course, and if you're not thoroughly familiar with this, you may want to go back and watch the videos that I have in my basic section. This is a basic concept, and I've labeled it as such, and telemetry techs and nurses always have to make decisions about the nature of this kind of a problem. Well, if you look at the forest, you can see there are narrow QRS complexes coming through. It's a little bit irregular here. This one seems to come in early. And then you've got this wide complex tachycardia here, 4 beats on this strip, and then 3 beats on this strip down below here, and they look fairly similar. So the question is, what are these? And of course, the first question you should ask is, are they real? Well, they look pretty real, so I'm not going to make you think it's artifact. But then the question is this ventricular in origin, or is it atrial in origin? And if it's atrial, what's making the QRS complex wide? So let's start looking at the trees in a little bit more detail. The underlying QRS complexes do appear to be relatively narrow. The QRS is about 110 milliseconds or so. You have a very discrete, healthy-looking P wave in front of each of these QRS complexes. with a PR interval in the range of about 140 milliseconds. If you take calipers, I think you'll find that to be true. And then this P looks a little bit different, so you start to wonder, the atrial rhythm may be wandering just a wee bit. But then this beat clearly comes in early. I can take calipers, but the rate over here is about 75, and then you have here a rate of about 110. Now, the QRS complex looks a little bit different than the underlying QRS, and there certainly may be a slight degree of aberrant conduction here. But the question is, did it come from the atrium or did it come from the ventricles? It's a bit narrow to come from the ventricles, but it's not impossible. So what we need to do is look in front of this beat and see if we see a P wave. Well, we don't see anything that looks like these P waves. So how do we know if there's a P wave there or not? Well, the best way to look at that is to look at the segment following the T wave in these beats and see if it looks different. And I would say that, yes, indeed, it does look different. See, here's the T wave. And in these beats, you have a relatively flat segment following the T wave, but here you've got this sort of like mountain hill double bump. And I think it's safe to say that there is some atrial activity in here. There is a P wave buried in here. It's hard to see exactly what it looks like, but that's certainly good evidence for me to call this an atrial premature beat, or premature atrial contraction, whatever you want to call it. Well, then you have a usual compensatory pause with another sinus beat here, and this probably is a sinus beat, but you're getting a little bit of motion artifact on this strip. And then, of course, you have this wide QRS tachycardia. You have to use the same technique to decide what started this off. The question really amounts to, is there a P wave in front of this first beat? And you don't have the flat part following the T wave like you did in these tracings, but now what you have to do is turn your attention to the T wave itself. Look at how smooth these T waves are, but in contrast, this T wave looks like it has a little something in it, something more than just a T. And I think it's safe to say that there is a P wave superimposed on this T wave. Remember, T waves generally tend to have very slow changes in voltage. They're predominantly low-frequency signals, whereas P waves contain much higher frequency components. The rate of change of the voltage is much quicker. Think of it as the slope. The slope of a T wave should be fairly slow, but if you see any high-frequency jiggles sticking out of the T wave, such as you see here, then that's more likely to be a P wave. Now the question is, what's making these QRS complexes wide? If you look at the P to R interval, theoretically the P starts here someplace, and the R is over here, you'd see it's actually longer than the underlying PR interval. And the QRS complexes are wide. Let's see, this one starts pretty much on a heavy line, so you have about 140 milliseconds maybe on this QRS complex. They all look about the same. And so likely what you're dealing with here is a functional bundle branch block, a functional aberrant conduction, because this P wave landed at a point when one of the bundles was refractory. It hadn't recovered from the previous beat. See how this PAC here was coupled at a rate of about 100 beats per minute? But this PAC was coupled, if you measure it from this P wave to this P wave, at about 150 beats per minute. So that was too fast for both of the bundles to have recovered. One bundle failed to conduct, and that's what started this run of aberrancy. Now, you might say, well, what about these three beats? Maybe these are ventricular. But they look so much like this one that it's hard to imagine that you're going to get a 3-beat run of non-sustained VT that looks exactly the same as this atrial premature beat with aberrancy. And so what you really have to remember is Toulo's law. This says 4 beats of VTAC, but don't believe anything you read on a rhythm strip unless you wrote it yourself. So we're going to call this atrial tachycardia with aberrant conduction. Well, let's look at this bottom strip. It's the same thing. Here we have a sinus beat, and here we have a PAC. You can see there's a little bit of a bend in the tail end of this T wave that you don't see here. So there's a P wave superimposed, and then you have a sinus P, another one, and then look at this T wave, how clear. You can see how easy it is now to see this P wave superimposed on the T wave. So that's a PAC, and it conducts this with the same aberrant pattern as this top strip, and this time you have 3 beats in a row of aberrant conduction. Now, it's hard to actually see how fast the atrium is going. For all we know, this could be 2-to-1 conduction, This last beat over here looks like an inverted P wave. This could be the last of the tachycardia beats. Maybe there was a little run of winky back here so that you have one with a shorter PR and then it gets a little bit longer and then longer, and maybe there's a P here that blocked, and so this one shortens up again. Hard to say for sure, but one thing is for sure, that this is not VTach. It's an atrial arrhythmia or atrial tachycardia with aberrant conduction. Okay, so this should be clear to you. And next time you come upon a strip like this, make sure you look for those P waves, because that's where the answer lies. Well, that's it for this week's Chalk Talk. I thank you so much for subscribing to the ECG Academy. Until next week, this is Dr. Nick. Thanks for watching. Hi, this is Dr. Nick with the ECG Academy, and this week's Chalk Talk is interesting. It's a kind of problem that I see pretty often, and it's often mistaken for something else, and so let's go over these two strips. This was an admission strip on the patient, and the patient was admitted with palpitations. You can see it is rather rapid and somewhat irregular. If you have a hard time figuring out what the rate is, you should look for 3-second marks and count up 6 seconds. Or you can always do it by hand. Okay, so I've counted off 6 seconds here, and we'll measure the number of R-to-R intervals. So this would be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, almost 13, so 12 and a half. That gives you 125 beats per minute. And it's doesn't seem to be much of a pattern to it. The QRS is within the normal limits, and you can see some atrial jiggles here. I think there's some atrial activity that was labeled rapid atrial fibrillation by the person who read this strip. And then sometime later, the rhythm becomes regular, here at a rate of about 110 beats per minute. And so it slows down, it becomes regular. And when you look in between the QRS complexes, you see what looks like an organized electrical signal here. And this regular, consistent signal was felt to be evidence to call this a regular sinus rhythm at 100 beats per minute. Well, I'm sure you know what I'm going to say, is that you should always look at a strip like this and wonder, what am I missing? Could it be that simple? And the fact is, it's not that simple. The first thing that you have to remember is that when you see an atrial event that lands right in between the two QRS complexes, you have to wonder, why is the timing of this atrial event such as it is? Because if you measure the PR interval, it would be quite long, here about 340 or 350 milliseconds. That's the first question. Why is there first degree? Why is the sinus rate 110 beats per minute, especially if the patient looks pretty stable? And one of the clues that I talk about in my basic ECG course on the ECG Academy is that when you have an atrial signal that lands right in between the two QRS complexes, you have to wonder if there may be another one that you could be missing. In other words, could there be another atrial signal in between these two? Is this some kind of atrial tachycardia at a rate of 220 beats per minute with 2-to-1 conduction? And then you have to decide, if that's a possibility, then prove to me that it is or it's not. Now, the problem is, when a second P wave lands on top of a QRS complex, it may be hidden because it's mixed up in this QRS. So here's where you have to look at the QRS morphology very, very carefully and say to yourself, is there a high-frequency deflection on this QRS complex that I cannot explain, and does it look like this signal? And when you look at this QRS, it's hard to say, but that's where you need to look across the whole forest. And when you look at this QRS complex, it looks a little bit different, because at the tail end, well, all right, I'll tell you what. Let me make it a little bit bigger. Make it easy for you to see. Okay, so here's the beginning of the strip, and look at this QRS complex. And when you scan across, you see that they all look alike, don't they? But when I drag this strip over, you start to see that the QRS, this one in particular, start to look a little bit different. And then this one is back to the original one. What you have here is a nice R wave and then a little bitty S wave. But this S wave looks like it has a little notch in it. Now the S wave is back to the original form, but now this one again has a little notch, and now this one clearly looks different, and so does this. And that's the clue. Because if you look at this signal right here, this sort of downgoing signal, it looks exactly the same as this. Well, if I take out a pair of trusty calipers and bring one over to this little negative deflection, stretch the calipers out so that the other point is on this deflection, we see that indeed these negative deflections map out exactly. And so we've proven that, in fact, this is atrial tachycardia with 2-to-1 conduction. But if you just looked at this QRS complex, you couldn't tell. You have to compare the QRSs, looking for a high-frequency deflection that would be evidence of the second atrial event, proving that this is 2-to-1 conduction. So start looking for subtle changes in the QRS complex that represent atrial events that you wouldn't otherwise see. The funny thing is that when we look up to the original, I think you can see that there are atrial events that seem to march through here as well. So I think the patient was in a slow atrial tachycardia all along, and it just started conducting 2-to-1, which caused the QRS complexes to become regular. Don't make that mistake. So just remember that someone who starts out with atrial fibrillation, who then becomes regular but at a rapid rate, faster than you'd expect if it was a sinus rhythm, you should look for flutter or tachycardia with 2-to-1 conduction. Well, I hope that was helpful. Until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk. I label this as advanced only because it's a very complicated presentation of a problem that we don't see very often in the first place. But you need to be able to recognize unusual forms of things. That's why you're subscribing to these Chalk Talks, because you already know the basics, and I'm trying to get you used to reading more difficult tracings. So as you've looked at this tracing already, you see that it does look kind of bizarre, rather complex. If you just concentrate on the rhythm strip down here, I think you can see pretty normal looking QRS complexes here and there, but there are these wide complex beats in between them in a kind of a bigeminal pattern, and then you have these 3 wide looking bizarre beats in a row, followed by 3 normal looking beats in a row. And then it goes back to bigeminy. So the question is, what are the nature of these wide QRS beats? Are they atrial? Are they ventricular? Are they aberrantly conducted? And try to make some sense of this. So let's look at the individual beats here. So if we go up to lead 1 and AVF, we can see these P waves are upright. And if you look at these normal beats to find the sinus rate, you'd find it's 300, 150, 100, a little less than 100, maybe about 90 beats per minute. So it's a normal sinus rhythm to start with. The PR interval is rather short. It's only about 120 to 140 milliseconds. When we look at this wide complex beat, you see it's very wide, but not terribly. It's only about 140 milliseconds wide. It's got this big, bizarre-looking T wave, and a lot of people will look at this bump over here in front of it and wonder if that's a P. Well, let's see if it's consistent. You can see that there does seem to be a bump here in front of this beat. In front of this beat, there's a bump, but it's a little bit wider. And then here, there's a bump, but here that looks like a double bump. So let's take out our calipers and see what that shows. I'm going to bring the calipers down to the P waves, and I already set this for the P to P interval. And now let's drop it down to this P wave and see where it works out. Now look at that, which is interesting. That second bump of the double bump signal times out with the atrial rate. So I think that this signal is the P wave and that this wide signal is something different. This wide signal that's preceding these beats, what could that be? It doesn't seem to be the P wave. So what do you think it is? Well, it's following the T wave of these beats, and it's consistently following the T wave. And so I'll tell you what this is. It's a U wave. This is a U wave, and so it has nothing to do with the wide QRS beat. What you're seeing here is a T and then a U in most of the beats. What we haven't done yet is to calculate the QT interval. Let's ignore the U wave for the time being because it's really throwing things off. And if we take this T wave and extend it to the baseline and then measure that interval, this QT interval is about 480 milliseconds. If we take this R to R interval as being about 640 milliseconds, and we take your calculator out, so the QTC would be 480 divided by the square root of the R to R interval in seconds, so that's 0.64. Take the square root of that and then equal it, and it comes out to be 600 milliseconds. 600 for a QTC is very long. Now here's another thing that's very interesting, that if you take a look at this T wave here, and compare it to this T wave. Look at how enormously bizarre looking this T wave is. Yes, indeed, that is the T wave. And the reason it's become so enormously bizarre is because it followed a pause. Okay, this is a pause-dependent T wave abnormality. And the QT interval here now is closer to 600 milliseconds, which would make the QTC more like 800. I hope that by now you're starting to realize what this is. This 3-beat run of a wide QRS tachycardia is torsade. That's right. It doesn't look like the usual torsade, but that's exactly what it is. It's a polymorphic ventricular tachycardia that's arising from the U wave in a patient with a very bizarre prolonged QT interval and clear evidence of fluctuating T wave morphologies, especially following pauses. So this is a bradycardia-dependent T wave abnormality. That's exactly what gives rise to torsade. So you might even want to call this impending torsade, but in reality, this 3-beat run meets the criteria. It's polymorphic, and it's occurring in the setting of a long QT interval. The first beat is widely coupled to the previous beat, and it is pause-dependent as it occurs in a bigeminal pattern. I think if you look really closely, you can even see retrograde P waves here and here, essentially proving that these are ventricular in origin. Now, if none of this sounds familiar, you better go back to the basic course and check out section 15 on ventricular tachycardia, because I have a very concise discussion on torsade and what makes polymorphic VT torsade or not torsade. That's Shakespeare's line, torsade or not torsade? That is the question. Well, that should be the question, and I hope I provided you with the answer. Well, that's this week's Chalk Talk. I want to thank you for subscribing to the Ecg Academy, and I'll see you all next week. This is Dr. Nick. Thanks for watching. Hi, this is Dr. Nick with this week's Chalk Talk for the Ecg Academy. Thank you again for subscribing to my Chalk Talks. The idea here is to get you used to reading more difficult tracings, although I label this basic because this is a concept that you would learn if you take my basic course on the Ecg Academy. When we look at this rhythm strip here, this is actually from a Holter monitor of one of my patients. Most people will very easily recognize this very long pause here, and this second, somewhat shorter pause. So let's figure out what happened. If we look at these first 3 beats, we can first establish the heart rate. If we count off from this heavy line, 300, 150, 100, 75, 60. So it's between 60 and 75, close to, I'd say, 68 beats per minute. Now we'll start looking for P waves in front of each beat. And I think it's safe to say that this looks like a P wave here, and there's a similar P wave right here. If you look at the PR, it's really quite long. Now make it easy for you and bring some calipers over. I'll put one pin of the caliper at the beginning of the P wave and the other pin at the beginning of the QRS complex and see if that is consistent, and it does appear to be. So how long is that? We'll put one pin on a heavy line, and you can see it's actually 400 milliseconds. So that's a very long PR interval. So this part of the strip, at least, we can call a normal sinus rhythm with a first degree AV block. But then what happens after that? I think you can see the next P wave here, and it does not appear to be followed by a QRS complex. So the first thing you want to ask yourself is this a PAC? Because PACs can land when the AV node is refractory, and that will fool a lot of people. If we resize our calipers and place it on the P to P interval, and then move that over, it's plain to see that this P wave occurs on time. And in fact, so does the next one, even though the morphology is slightly different. The P to P interval appears to be fairly stable. And in fact, you can map it across, and you see here's the next one. And so the atrial rate is not varying more than maybe 40 or 60 milliseconds, which is well within the range that you'd see with sinus arrhythmia. So you can see this P occurs on time, and it failed to conduct, and so this is blocked. But so is this one blocked. This one has a QRS following it, and if we take the calipers that we use to measure the PR interval over here, it looks close, but it does appear to be a little bit longer. So now you're thinking, well, gee, I thought the PR was fixed and then it drops a beat. So is that type 2 second degree AV block? But now over here, the PR looks like it got longer. So is this type 1? And then this one seems to block, and then you have this one here that also conducts. And the question is, what do you call this? How is this classified? Is this first degree? Is it second degree type 2? Is it second degree type 1? Maybe you want to call it transient complete heart block. Well, the answer is none of the above. Clearly, these beats are conducting, and it would appear that these are conducting as well, so you don't have complete heart block. Be careful about not calling a 2.8 second pause complete heart block, because it's really not. It is second degree AV block, and you were almost right to call it type 2 because the PR interval does not appear to change before the blocked beat. But type 2 implies that you're only going to block a single P wave. And the rule is that if the PR interval is fixed prior to the blocked P wave, then we classify it as type 2. And what does that imply? That implies block below the AV node. That's infranodal block. But we have blocked 2 P waves in a row. And so you automatically shift into a new category known as high grade. And some people will call it advanced AV block. And that implies 2 to 1, 3 to 1, 4 to 1, and so forth. That's what this is. It's considered high-grade AV block because you blocked 2 P waves in a row. So it's really 3 to 1 block right here. Or is it? See, here's the cool part of this strip. Remember I showed you that the PR interval here is a little longer than the conducted P waves over here? Well, you probably didn't notice that this QRS morphology is a little bit different. This we have a kind of an RSR prime, an up-down, up pattern to it, and it's mostly isoelectric in this lead. Well, look at what this QRS looks like. It's entirely positive. Now, this lead looks similar, but it's not as deep as this lead. It's not as negative. And in this lead, lead V5, it seems that the QRS is much taller than the conducted QRS complexes. So what is this beat? It's not conducted. It's a junctional escape. It's a junctional escape because it looks a little bit different than the underlying rhythm, and so it's escaping from some place in the bundle branch system. We see slight aberrant conduction in junctional beats, and we'll still consider it junctional. The fact is that the PR is longer, and so in reality, this P wave blocked as well. And just at this moment, the AV junction fires as an escape beat. So this is a junctional escape beat, and that shows that, yes, 3 P waves in a row failed to conduct. And if you really want to split hairs, you can call this one number 4, although this occurs shortly after the AV junction fires, so I really wouldn't get too excited about it. But then the question is, where did this beat come from? Because in fact, it looks a lot like this beat. The morphology is the same as the junctional beat, isn't it? And I would be tempted to call this a junctional beat as well. Based on the morphology, this PR is a little bit on the short side, so I think the junction fired just at the moment that this beat would have conducted. But it's still junctional based on the morphology. This beat over here, in fact, this might be a fusion beat because it's a little more positive than it is isoelectric here. So you had a massive failure of conduction in this region, but the correct ECG diagnosis is high-grade AV block, and that's the pearl I wanted to get across to you today. Well, I hope you enjoyed that discussion. Until next week, this is Dr. Nick for the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with this week's Chalk Talk. This is a wide QRS tachycardia that I saw in one of my patients in the coronary care unit. If you look at the top strip, and these are continuous strips, you can see what looks like a normal sinus rhythm with normal P waves in front of each QRS complex. Here's a QRS that lands on a heavy line, so we'll count backwards, 300, 150, 100, 75, 60, 50. So the rate's about 52 beats per minute. So we have a sinus bradycardia. And then what happens is you get this wide complex tachycardia. Now, when you look at the forest, you can see it starts out slow, and then it seems to speed up, and then here at the very end it gets slow again. So it's irregular, but there's no pattern to it. In other words, if you look at the rate over time, it starts out at a certain rate, it goes up, and then it starts to come down again. But there's not a beat-to-beat variability, so it's not irregularly irregular. A lot of people will be tempted to classify this as some kind of atrial fibrillation with aberrant conduction. But if you've gone through my basic course, I think it's easy to say that that's not what this is. So first thing you should notice, every QRS looks alike, and so the electrical signals are going through the heart in a consistent basis. The key is, how did it start? We want to take that first wide QRS beat and look in front of it to see if there is evidence of a P wave that may have started off some sort of atrial arrhythmia with aberrancy. But you can see this portion of the ECG is straight as an arrow. It's flat as a pancake. It does not have any evidence of a P wave. And in fact, when you examine this QRS carefully, you see that in the ST segment, which should be fairly smooth, you see this high-frequency downward deflection. Remember, P waves have fairly high-frequency content to them, as opposed to ST segments and T waves, which are generally very smooth. Not always, but in general, the slope of ST segments and T waves are much more gradual than the change in the voltage of a P wave. These are more sharp and spiky, and T waves and ST segments change voltage more gradually. So this right here, if that's a P wave, where did it come from? Well, since there's no P in front of this beat, the beat is very wide and bizarre, and you have this atrial event after, you have to conclude that this is a ventricular premature complex with a retrograde P wave. And the retrograde P wave occurs because in roughly 1/3 of patients, the AV node is capable of conducting in a backward direction. So if you have the two atria here and the ventricles here, and your AV node is connected to your Purkinje fibers, if you have a PVC that arises from the ventricle here, it can enter those Purkinje fibers, travel up to the AV node, and then make its way up to the atrium as a retrograde P wave. The P wave morphology will generally be different than the sinus P waves, and in fact, it's usually inverted. So here in lead 2, we're seeing downward deflections, which all make sense. Okay, let me get rid of this stuff here and see what else we have. So we have this wide complex beat with a retrograde P wave, and then here comes the next one. Looks exactly the same, but what's the rate? Okay, this one lands about on the heavy line, so 300, 150, 100. It's a little faster than 75. It's about 78 beats per minute. And then another one that's coming in a little bit faster. Here it's going to be about 85 beats per minute. And then this one is coming in right about 100. Maybe a little less. Maybe we'll call it 95. So you have a gradual acceleration in heart rate, 78 to 85 to 95. And in the fastest portion, right about here, you have a rate of about 140. So if you only took this part of the cardiogram at 140 beats per minute, and it's wide, and look at that, there's consistently a retrograde P wave. You can see them in these beats as well, so there's a consistent retrograde P wave. But if you only looked at this part, you would have to call this monomorphic ventricular tachycardia. It's not atrial because what's driving what? In the beginning, look at the distance between this P wave and the following QRS complex. So this PR interval, so to speak, is very, very long, but the R to P is fairly short. At the fastest rate, the R to P is a little bit longer, but the PR is much shorter. Now, does the AV node behave better at faster rates? No. The AV node gets worse at faster rates. So the fact that this PR interval is getting shorter is proof that the P wave is retrograde coming from this QRS. The only thing that makes sense is that these are indeed retrograde P waves. And as such, this is a ventricular arrhythmia. But getting back to the point I started, that if you only saw this part of it, you would have to call this monomorphic ventricular tachycardia. But you can see that it started out very, very slow. It sped up, it got to be 140 beats per minute, and then it starts to slow down again. So that by the end, you're back to a rate of about 90 beats per minute. And so the best way to classify this arrhythmia is accelerated idioventricular rhythm. AIVR, it starts out less than 100 beats per minute, and it gets faster. So we say that this arrhythmia warms up. It has a warm-up phenomenon that causes this arrhythmia to speed up, and then at the end, what do you think we call it? Cool down. So it cools down, and then eventually stops, and then after a slight compensatory pause, you have the sinus beat kick in here, which looks a lot like these sinus beats. But what makes this AIVR is the rate that it starts out, the fact that it starts to overtake the sinus rate, warms up a little bit so that it does get rather fast, and then it cools down again. Now, when we think about arrhythmia mechanisms, it's likely that we're dealing with an automatic arrhythmia. So there's a focus in the ventricle that begins to fire abnormally, and it takes over the heart rhythm, but then it goes away just as fast as it comes. This is not uncommon in people after angioplasty or stenting after an acute MI. There's something that we call a reperfusion arrhythmia that occurs because the myocardium was recently ischemic, and now you've got blood coming down, and some of the toxins and products of cell injury are now washing downstream, and it can affect the irritability of the ventricle. So AIVR in those circumstances is known as a reperfusion arrhythmia, and it's generally self-limiting, so that if you just kind of keep an eye on it, it usually goes away by itself. This kind of arrhythmia can sometimes be a sign of electrolyte abnormalities or ischemia or other kinds of metabolic problems, so it merits looking into those kinds of clinical causes that you need to rule out. And I would call it automatic ventricular tachycardia that started with AIVR and finished with the same. But as I said before, this is an uncommon arrhythmia, and when I saw it, I felt I had to make a chalk talk out of it. Well, I hope you enjoyed that. Until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is labeled as basic, but it's actually pretty challenging, and it leads to some serious thoughts about physiology and how to determine the nature of a strip. So let's get to it. As you look at the forest and get a sense of whether this is regular or irregular, you guys should have a sense that there is group beating going on here. You've got groups of two separated by pauses. So when you see group beating, a number of things should come to mind. Of course, the first thing some people think of is winky back. Since there are two QRS complexes, then naturally you would be looking for 3-2 winky back or type 1 second degree AV block. Well, let's take out a pair of calipers and make some serious measurements here. Okay, so I've set this for the QRS complexes here. If we figure out the rate, let's put it on a heavy line and count off 300, 150, 175, 60, so just about 60 beats per minute. And let's look at the next pair. You can see it's a little bit faster than that, maybe by about 40 or 60 milliseconds. The next one is right on time, about 60 beats per minute, or about 1 second. But now this one is off a bit. It's actually off more than 100 milliseconds. So let's try to figure out why that could be. So let's look at the P waves. Well, here, of course, these P waves are 1-to-1. And if we measure out for where the next P wave should be, we don't see it. So there's no P wave where we would expect it to be. And if we measure out, this P wave does not measure out either. So there goes our theory of 3-2 winky back, because in order to have winky back, the P to P intervals should be regular. So that's not what this is. Even though if you look at the length of the pause, it's less than 2 times the previous R to R interval, but we're missing the P wave, so this can't be winky back. So when you have a bigeminal rhythm like this, what else could it be? Well, there are a couple of possibilities. And when I say a bigeminal rhythm, I mean every other beat is premature. So if you consider this a regular beat, then if you had mapped it out, if it was regular, it would have landed here, but instead you have this premature QRS complex. So you have to figure out what's causing the irregularity. Now, there are a couple of different possibilities. It's conceivable that this is a normal beat and this is a PAC, and then we have a normal beat here and then a PAC. This could be atrial bigeminy. If that were true, the P wave of the premature beat would probably look a little bit different than the P wave of the normal beat, so you would see a distinct difference in the P waves. And if we look at this P wave in different leads, it really does appear to be the same. That goes against this being a PAC. Okay, what's the next choice? It's conceivable that what we're dealing with here is an unusual variety of SA exit block, and we covered this in the chapter on sinus node dysfunction. So SA exit block, basically what happens is that you have the atria and the ventricles, and the sinus node fires, but those little extensions of sinus nodal tissue don't work right, and the signal does not get out to the rest of the atrial myocardium. But since these are calcium-dependent tissues, what you can have is actually 3-2 SA exit block. We'll cover this in detail in the advanced course. But basically, this first sinus beat gets out quickly. The second sinus beat occurs in here someplace, but takes a while to get out to the atrium, so the P wave is delayed. The next sinus beat would occur here someplace, but it blocks and never gets out to the atrium. And then the next sinus beat occurs on time with a very rapid conduction to the atrium, and that's what gives rise to this bigeminal kind of a pattern, where the sinus node actually fired here, but it never got out to the atrium. That would go along with the fact that the pause here, the P to P interval, is less than 2 times the previous P to P interval. This is actually not a common finding, and I only mention it to get you to think about how cool the advanced section is going to be when I finally get those videos done. Well, I'll tell you what I think this is, but you have to promise to trust me. I think if you look at this T wave, it looks smooth, and this T wave has a little tiny bump on it. And you're thinking, wow, that's not that convincing. But look at these 2 T waves. This is very smooth. This one has a negative deflection a little bit sharper than this one here. And I think if you look at this T wave, it resolves to the baseline very quickly, whereas this kind of has a little jiggle at the end. And if you look at this T wave, it looks like it resolves down to the baseline, but this one has a bump on it. And I think these are very, very subtle findings, but I think what you have here is non-conducted atrial trigeminy. So what that means is every third beat is a PAC, but it doesn't get through the AV node because it's too premature, it's too early, it's within the AV nodal refractory period. But I'm convinced that that's what this is. So it's kind of an unusual arrhythmia. The point here is that you have to think of all the different possibilities of what it could be, and one by one sort it all out and rule out the ones that are impossible, and then whatever's left becomes probable. But you need to know the physiology, and you need to be familiar with all these different arrhythmia mechanisms in order to be able to solve this kind of a difficult tracing. Well, I hope that was food for thought. And until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey, this is Dr. Nick with the Ecg Academy with this week's Chalk Talk. I just wanted to thank you all for subscribing to these Chalk Talks. I try to make them as interesting as I can and drop a few pearls along the way. Anyway, I found this strip in our telemetry unit, and if you look at the forest, you can see that there's this long run of a wide complex tachycardia. If you compare these first couple of beats, you have a P and a QRS complex. They look fairly normal. The PR interval is fairly short. It's about 120 milliseconds or so. And at the other end, you can see 2 more normal-looking beats with a P and a PR that's on the short side and a normal QRS. And then you've got this wide complex tachycardia that starts out about 2 boxes, so that's about 150 beats per minute. But then it speeds up, and around here, it exceeds 200 beats per minute, because if you take this QRS, which is on a heavy line, and you measure 2 R to R intervals and count off the boxes, that's 300, 150, 100. So that means that it's more than 200 beats per minute. If this is about 115, we're talking about 230. But then it begins to slow down towards the end here. It slows down here, and then it kind of speeds up a little bit again. So there is a little bit of a variation in the rate, but on the average, it's probably about 180, 190 beats per minute. I suppose if you wanted to get fancy, you can count off 3 seconds. So here's a QRS that lands on a heavy line. We have 1, 2, 3, 4. Here's 1 second. 1, 2, 3, 4. Here's 2 seconds. 1, 2, 3, 4. Here's 3 seconds. Count the number of R to R intervals and then multiply by 20. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, a little less than 10. So there it is, just a hair under 200 beats per minute. That's probably the most precise way you're going to be able to measure a rate like this. But the question is, what is it? Well, should I show you what the nurse wrote on here? Yep, that's it. 17 beats of non-sustained VTach, rate 167. So her rate wasn't exactly accurate. But the question is it VTach or isn't it? It's one of those, it smells like it. It tastes like it. It must be VTach. Except, how do you prove it? Especially when you're going to say, well, Dr. Nick says we should look at the beginning and see if we see anything like a P wave. So if you look at this T, it looks very smooth. And if you look at this T, well, gee, it seems to have a bump on top of it, huh? And remember, the T waves have very low frequency components to it, so the rate of change of voltage is very slow, but P waves have much higher frequency components to it. They can be much sharper with a higher slope, faster voltage changes. So if you see a T wave that's got a bump on the top of it, or a T wave that's got a bite taken out of it, then chances are that that's a P wave on top of the T. So do you believe that that's a P wave there? Because if it is, then the idea is that you have a P that likely conducted aberrantly, and then look at that, you have another P that conducted aberrantly, and another P. And look at that, there seems to be a very high frequency deflection on top of every single ST segment along here. Look at that, it's very, very consistent. Now, if it was VTach, what would you look for? The hallmark of ventricular tachycardia is AV dissociation. So if you see that the ventricular rate is faster than the atrial rate, then you can say definitely VTach is present. So that means that there has to be some breakdown in this one-to-one association between QRSs and P waves. But if you march on through, you can see there is a P that seems to be in between every two QRS complexes even here. So you don't see AV dissociation. What would that look like? You've seen it before, where you have a retrograde P, and then you have another QRS complex during a ventricular tachycardia, and then you may have another P wave, and then you can see that it's gone again. You get these retrograde P waves that are there sometimes, but at other times they're not there. So what I'm saying here is that you have one-to-one association. And if it started with a P wave here, then that means it's very likely atrial tachycardia with aberrant conduction, right? Well, maybe, but prove it to me. Think in terms of physiology, because that's the key to understanding electrocardiography. Okay? Physiologically, what happens to the AV node when it's bombarded with rapid signals? Does it conduct better, or does it conduct worse? Well, we know that because it's a calcium-dependent tissue, it conducts worse. And if this doesn't sound familiar, then you should be taking my course on basic electrocardiography. The basic ECG course talks about the behavior of the AV node. Now, if you look at the PR interval of the normal beat, it's very, very short, right? If this is a P wave and it conducts longer, does that make sense? Well, sure it does, because this is a PAC. It's a premature atrial contraction, so you would expect it to conduct with a longer PR interval, because premature beats and faster rates conduct worse through the AV node. They take longer. Okay, so far it makes sense that this is PAT. All right, what's the next thing? Well, let's see what happens to the PR interval through the rest of the strip. So we're going to pull out a pair of calipers here, and let's bring our calipers up. You know what I'm going to do is make it easy on you. I'm going to erase some of this stuff here, because I want to be able to see those PR intervals. So here are calipers. I already set it up so that we can measure the PR interval of the second beat. I want you to see something here. I put the point of the caliper at the beginning of this P wave, and we can trace that down to this bunch of light dots. And the end of the caliper is right on that QRS complex. So the PR interval for this beat is 280 milliseconds. That's this right here. So you got 280 milliseconds. Now let's compare that PR with the first PR. The first PR is quite a bit shorter. That makes sense, doesn't it? This PR is maybe 210 milliseconds. So you get 120, then 210, and then 280. Because the atrial rate is much faster now, the PR is getting longer. It's kind of like Winky back. So now let's take our calipers and look at the next beat. So we'll put the calipers on this next P wave, but Wait a minute. It looks like the PR got shorter again, because from the beginning of this P wave to this QRS complex is from here to here. So now it's back to 240. And in fact, it's getting shorter and shorter from here to here is only about 160. Does that make sense? Could the PR be getting shorter as the rate gets faster? Not likely. That's not how the AV node is supposed to behave. The other thing is, if you assume that this P over here conducts to this QRS, and this P conducts to this QRS, and this P to this QRS, and so forth, so that would mean that this P conducts to this QRS, right? You follow me? And this P conducts to this QRS, and this one to here. But then we still have a P, and there's no QRS following it. So are you saying that this P wave blocked somehow? That this P wave somehow never made it down the AV node? But coincidentally, this also happens to be the last P wave in this run, and then what you have is a normal sinus P wave that is the next atrial event. Well, that's just too much of a coincidence. It would be highly unlikely for the tachycardia to break in on the very last beat of the tachycardia you get AV block. So this just isn't adding up. And you know what it means? It means that, indeed, this is ventricular tachycardia. That this little bump in the P wave was just a little bit of artifact, and that you had a ventricular event leading off this whole salvo here, and the P waves are all retrograde. And this patient has very healthy AV node in both directions. Antegrade, the PR is very short, and retrograde, the PR is very short. But notice that even though the PR is changing from one beat to the next, the R to P doesn't change much. That P wave, for the most part, always lands more or less the same distance after the QRS starts. From the QRS to the P wave, this interval, the R to P interval, is fairly constant. But the P to R interval changes because this P is not associated with this QRS complex. It's associated with the one before because it's retrograde. Okay, so even though it looks like VTAC, in order to prove it, you really have to know the physiology and be able to recognize these subtle P waves and understand that they are retrograde and not antegrade, because when you see them right in the middle, you have to figure out, well, which QRS is it associated with? And I've just shown you how to do that. So I hope that was really helpful. And until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk might raise a little bit of controversy, but feel free to leave some feedback because I try to answer questions that may arise with these ECG discussions. Anyway, I thought this was an interesting one and somewhat thought-provoking, so let's get right to it. We'll kind of review this ECG from a 12-lead standpoint first. So if you examine the ECG and look for the axis, you can see that lead 2 appears to be most isoelectric of all these leads. 3 and AVF are downgoing, so there's a left axis deviation. Lead 2 goes down and to the left, like we read in English, at 60 degrees above the horizontal. That gives us an axis of minus 30. So there's some left axis deviation. But if you notice, the QRS complex does appear to be a bit wide. It looks to be about 120 milliseconds. So the question is this a bundle branch block pattern or not? Well, there is an RSR prime here in AVL, but you do have little tiny R waves in V1 and V2, which is somewhat atypical for a left bundle branch block. Plus, there's a very rapid downstroke here with a relatively early intrinsicoid deflection, and you don't have an RSR prime in V5 and V6. So I would call this a nonspecific IVCD or interventricular conduction disturbance. But if you notice that there's very poor R wave progression in the precordium all the way out to V5, V6 is the transition point where the R wave grows larger than the S wave. So there is late transition here, but I think most cardiologists would probably write this as an old anterior MI, or at least they'd qualify it and say cannot rule out old anterior MI. A lot of them would look at the patient's age and the clinical circumstances, but clearly there's an absence of anterior forces here. Whether it's electrical or not related to the IVCD is pure speculation. Now that we've kind of reviewed the QRS morphology, let's pay attention to the rhythm. When you look at the forest, it does look quite regular. And if you find a QRS that lands on a heavy line, like this one, and count off 300, 150, 100, 75, it's just under that, like maybe 72 beats per minute. Now, I could take a pair of calipers, and we could measure this, but I want to show you a little trick. If you find a QRS that lands on a heavy line and examine the relationship of the next QRS with the next heavy line, you can see that this QRS falls just a teeny bit to the right of the heavy line. So it's a little bit less than 75 beats per minute. Fine, but let's look at the next one and see where it falls with respect to the heavy line. It's again a little bit further to the right. It looks like about maybe 40 or 60 milliseconds. So then we look at the next one, and you see it's about the same increased distance from the heavy line to the right. So it appears that the QRSs are gradually moving away from this heavy line in a fairly constant fashion. And so that's actually a way of testing the regularity of a rhythm without a pair of calipers. You can take a piece of paper, obviously, and move it along the ECG. So there's lots of ways that you can assess it without having a pair of calipers. And so it really appears to be quite regular. But where are the P waves? When I look in front of each QRS, I don't see a P wave consistently. So the question is, where's the P wave? Now, a lot of people would just simply consider this a junctional rhythm because there's no P visible, and a lot of cardiologists would just simply read it that way. And that's one possibility of what this could be. But you really have to make an effort to look for P waves buried somewhere in the T wave because it could be a sinus rhythm with a very long first-degree AV block, giving rise to a P wave that's sort of buried in the previous T wave. Well, let's look carefully at this area right here. I'm going to enlarge this. So here's V2, and the lead changes right here, so you have to pay no attention to this little jiggle here. So you have the QRSs that are marching through in a regular fashion, as I mentioned before. And what you see is a T wave that looks like a bifid T wave. Got two bumps on it. And if you take out a pair of calipers and you measure the QT interval, you can see it goes from here to here. And if we put one pin on a heavy line, you can measure 200, 400, about 460 milliseconds. So let's measure the next one. It's exactly the same. And the next one, it's just about the same. So 460 milliseconds is the QT interval. But when we look at the T wave itself and the ST segment, we see something interesting. There's this sort of double bump here, and it seems to be consistent. Or is it consistent? Well, the second bump clearly occurs in a very consistent fashion at the tail of the QT interval. But this first bump seems to change. The peak of the first bump is about 60 milliseconds after the J wave. But here when you measure the J wave, the peak of the bump is more like 100 milliseconds after the J wave. You see how if you compare this to this, it looks different? This first bump is occurring later. And then here it's occurring later still, about 160 milliseconds after the J point. And it's almost like these two bumps are merging. First they're far apart, then they're getting closer, and now they're even closer. They're only here about 60 milliseconds apart. So what does that tell you? It tells you that this first bump is not part of the T wave, and it's not part of the QRS complex because it is dissociated. It's moving separately. In fact, since it's moving to the right with each successive beat, it means that the rate of this first bump is actually slower than the rate of the QRS complex because the interval is longer. Therefore, these must be the P waves because they're not part of the QRS, they're not the QT, they're separate. Okay, so now let's move over to the earlier part of the tracing. I want to show you something else. If you look at this QRS complex, and you look at this one, you see a very suspicious looking bump here. You could even see it here in lead 1. And I believe that that's a P wave also. Going back to the original magnification, I'm talking about this bump right there. And you can even see it in lead 1. So I believe that that's a P wave as well. But that in the next beat, that P wave disappears into the QRS complex, and it doesn't emerge until here, where you begin to see it in the ST segment, as I pointed out to you before, here and here. Now, I can't explain why you don't see one here. It could have been a sinus arrhythmia that caused the P wave to be buried in this QRS complex, then perhaps move a little bit forward, and then slow down again until we start to see it out this side. But the bottom line is, since the P waves are moving to the right with respect to the QRS complexes, the atrial rate is less than the ventricular rate, and therefore AV dissociation is present, which means that the lower rhythm is driving the heart and the atrial rhythm is sort of lagging behind, which really confirms that this is in fact an accelerated junctional rhythm with AV dissociation. We don't see that too often. It's usually sinus rhythm with a long first degree AV block that masquerades as an accelerated junctional rhythm, but this one really appears to be junctional. Well, I hope you enjoyed that discussion, and I do appreciate your subscribing to the Ecg Academy. Until next week, this is Dr. Nick. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and we have a chalk talk that is one of those back to basics. I thought every now and then it's good to review basic principles that help you interpret ECGs properly and let you become an ECG expert. Now, this patient was actually sent to me for consultation because of this Holter monitor that was obtained. And when you look at it, you say, oh my God, that does not look good. Now, the patient was asymptomatic at the time, but that really shouldn't matter, since we all know that arrhythmias can occur in the absence of symptoms. So we want to first take a look at the forest, right? You look across and you see what looks like 3 sinus beats in a row with very clear P's and QRS's at a rate somewhere between 75 and 100 beats per minute, probably around 80. And then we have what looks like a polymorphic ventricular tachycardia. A lot of people would look at this and call it torsade because it's getting sort of bigger, and then it gets smaller, and then, sort of like goes crazy. But what you really have to do is put your analytical eyes in. Assess this strip as an expert. And the first question is not, is this ventricular tachycardia? Is this supraventricular tachycardia with aberrancy? No, what should the number one question be? Is it real? That's right. Is it real? Whenever you're faced with a complex electrical signal like this, you have to understand the limitations in the ECG machines. And the fact is that they'll display any electrical signal that's coming into it. So if we kind of erase this and now take a careful look at the forest, you really need to be able to sort of with your eyeballs, use your eyes as calipers and kind of march yourself on through. Now we'll take real calipers and do this. You can actually see past all this undulating stuff that there is indeed a QRS complex there. You just have to be able to recognize it. And if you happen to have a pair of trusty calipers, you should be able to march it on through and notice that, yeah, there's a squiggle here that is very sharp and spiky and looks a little like this QRS complex. But if this QRS complex is on time, how can that be if you've got all this complicated squiggly signal ahead of it? You really can't have QRS complexes on top of QRS complexes. There's a certain refractoriness and usually corresponds with a QT interval. It's hard to have a beat that lands before the peak of the T wave, at least. And if you go ahead and map this out, you see that there's two very, very sharp signals, one right after the other, which is kind of unusual. But then when you keep on going, you see this sharp spiky thing, that's actually the QRS complex. And all this undulating stuff is all artifact. Probably the patient scratching themselves or shaking the wires or something. And so as you can see, the QRSs do march precisely when you use calipers, but you really need to be able to use your eyes and kind of filter all the junk out and convince yourself before you get all excited that this is nothing but artifact. And it brings back Toulo's law that even though the Holter monitor company marked it as a ventricular run, you should never believe anything you read on an ECG strip unless you wrote it yourself. So that one was short and sweet, but I think a valuable lesson. So until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey, this is Dr. Nick with the Ecg Academy, coming to you with another Chalk Talk. I label this as intermediate just because you have to think about quite a few things here. But in reality, it's a basic concept. Just don't accept everything you see at face value. If you want to be an ECG expert, and for that matter a good doctor or nurse, you really need to dig a little deeper. Okay, so we'll start with this rhythm strip, and this was a gentleman on the telemetry unit at my hospital. When you glance across at the forest, it seems to be quite regular. Here at a rate of 300, 150, 175, yeah, just about 75 beats per minute because it does seem to stay on that heavy line. So 75 beats per minute, and there's a P wave in front of each beat, although it does seem to be rather small, but it's clearly there. The PR interval is really at the upper limits of normal, almost 200 milliseconds. But you'd look at this and say, well, that's just a regular sinus rhythm. A normal sinus rhythm, in fact. But then when you flip the page in the chart, you see this strip. Now, the QRS appears to be much wider, and it seems to be really quite irregular when you look at the forest, starting out at a very slow rate, and then obviously speeding up to the point where it's almost 150 beats per minute. Then it's at slow again, and then it speeds up again, and this is a continuous strip. The first thing you absolutely need to do is look at the patient identifier. Look at the sticker and make sure that it's the same patient, because many times when I'm making rounds, I find that someone just simply filed the strips in the wrong chart. Because this looks so very different from the previous strip. Here, I'll show you. This is the previous strip. The QRS is quite narrow. The T waves look fine. Everything looks okay. And then you look at this and you say, my goodness, what happened? Well, I think if you just had this to go by, you would look at it and say, well, this is grossly irregularly irregular. And the QRS looks wide, but it's consistent with every beat. So it's not like there are ectopic beats occurring. And this is what atrial fibrillation would look like if someone had an underlying bundle branch block or interventricular conduction disturbance. So a lot of people would just simply call this AFib with aberrancy. And in fact, you can see that's exactly what they put. Run rapid AFib. And here about 25 seconds worth of rapid atrial fibrillation. So most people would look at this and just say, oh, okay, I guess the patient had atrial fibrillation. Now the patient had come in with a little TIA, and this patient very well may have been put on Coumadin for stroke prevention and atrial fibrillation. That would be an appropriate intervention, depending, of course, on whether he had other risk factors for stroke. But the recurring theme that I keep trying to stress to you subscribers of the Ecg Academy is that you need to be an ECG expert, and sometimes you have to dig deeper. You can't just accept what someone writes on a strip. You have to try to figure it out yourself. Now, how do you figure it out? How do you figure out what this is? Well, sometimes you can't, given the strip. But you know what? Sometimes whoever put the strip in the chart didn't do you any favors. They take a slice of the middle, a representative portion of it, and they say, okay, here's all you got. That's it. Knock yourself out. But what struck me as odd and what made me dig deeper is the fact that I don't really see P waves here, which would lead you to think it might be atrial fibrillation, but I don't see fibrillatory activity either. It really just looks like a little baseline noise. And most of the QRS complexes look the same, but I looked at this and I said, what's this little bump? And then I looked over here and I said, well, what's that little bump? And then I picked myself up and I walked over to the telemetry monitoring station and I logged into the full disclosure. And let me show you what I found. Now, this is actually the strip, and I had to enlarge it dramatically, but this is what you're seeing over here is this slow, wide QRS tachycardia that speeds up and gets slower and speeds up, and that's just exactly what this strip is. But what happened before? How did it start? Well, if I drag this window over a little bit, you'll see how it started. It started as a normal sinus rhythm here. Look, there's PQRS and PQRS and PQRS, and what happened? Now that you see the whole strip, this is actually that little bump that I told you that I couldn't figure out what it was. It's right here. But now we see what it is. It's a P wave. It's a P wave that occurs on time. And the wide QRS, now that you see the whole strip, is clearly ventricular. So this, in fact, is a run of ventricular tachycardia. It's most likely an automatic focus because it's so grossly irregular. So there's a focus that starts to fire and then it warms up. and speeds up and gives you this wide complex tachycardia that you think is atrial fibrillation. But then what else do you see is how does it end? And here it is after 13 or 15 seconds or so. Look, the sinus rhythm resumes because it was there all the time. In fact, if you look closely, I think you'll see a dissociated sinus P waves right here and here. And that, I think, if you took calipers, corresponds with this sinus rate. So what you have is a run of automatic, grossly irregular ventricular tachycardia that's easily mistaken for atrial fibrillation with aberrant conduction. But if you see how the rhythm begins and you see how it ends, you can clearly make the right diagnosis. So be a Sherlock Holmes and tell your telemetry techs to make sure they put the beginning of the arrhythmia on the chart, because if you just see it in the middle, sometimes it's just not enough information. So I hope that was really helpful to you guys. I appreciate your subscribing to the Ecg Academy. Until next time, this is Dr. Nick. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and we're going to do this week's Chalk Talk on a rhythm strip that I came across. And it's another one of those don't believe anything you read unless you wrote it yourself. So let's quickly kind of scan across here, because you should always look for the forest before concentrating on the trees. And you can see there is some irregularity. I see a little pause here and then scan across, and it seems to be pretty regular. And then there's another pause here. So let's try to figure out what this is. The best place to look for P waves when you have an irregular rhythm like this is in the pause. That's right, because now you have lots of space in between the QRS complexes to look for P waves. And if you look in front of this one, you see that there seems to be a P wave right here. That's pretty clear. The PR interval here is a little bit long. It's probably about 240 milliseconds. And then when you look across to the next QRS complex, it appears that there's another P here. And in fact, if you look in front of each QRS complex, the P's seem to be in the right position, preceding each QRS complex. And then there's a P here that appears to not conduct. And if you look at the beginning of this pause, you see a similar appearance with a T wave and then a P. And just like here, there's a T wave and a P. And you wonder to yourself, well, some of the P waves appear to be conducting, but some don't. And so could this be some kind of a second degree AV block? And I think it's fair to say that there is some AV block, because some of the P's are clearly not followed by a QRS complex. So let's try to figure out what this is. The first thing you want to ask yourself is, are the P's regular? Because in order to call second degree AV block, one of the requirements is that you're not dealing with non-conducted PACs. And so that's where our calipers come in really handy, because what you want to do is make sure that the P to P interval is regular. So let's take the peak of the P waves, because they're pretty clear. And if you measure them out, you can measure out 300, 150, 100, and this would be 75, so it's closer to 100, probably 88 beats per minute or thereabouts. So you have upright P waves at 88 beats per minute, and if you march these calipers from one P to another, you see that it seems to be quite regular, even all the way to the end. And then the question is, well, what about that non-conducted P wave? And it turns out that the non-conducted P wave is really pretty much on time. Maybe it's 40 milliseconds off or so, but it's certainly not significantly premature. And let's go back to this one, and you can see that this one actually was on time as well. And so all the P's appear to be perfectly regular at a rate of around 88 beats per minute. So at this point, we've established that these P's that fail to conduct are not premature atrial contractions. They appear to be regular. They're sinus P's, and so the AV node, for some reason, just didn't let them down. So now the question is this type 1 or is this type 2? It's obviously not high grade, because you don't see two P waves in a row that don't conduct, so this is not one of the possibilities. So the question is, how do you distinguish between these two? And that has to do with the PR, and whether the PR is getting longer or whether it's fixed. Now, when you first scan across here, you don't see much difference, but the best thing to do is compare this PR interval with this PR interval. And I think you can just see with your eyes that this PR is clearly longer. And let's take our calipers and resize them. So they're about the size of the PR interval. Here I measured a PR interval, as I said, about 240 or 260 or so. Now let's go all the way to the end, and you can see the PRs are clearly longer, and they look to be, consistently longer here. So far, it looks like type 1 is the most likely cause, but you have to look for one thing. You have to make sure that this beat isn't a junctional escape. That's right, because sometimes what happens is that you have such a long interval in here that the AV node will fire as an escape focus, and that will artificially shorten that first PR interval. And you can have type 2 second degree AV block, but the PR at the end of the pause is artificially shortened and it may throw you off. What'll then happen, of course, is the P's will begin conducting following the second P wave, and all these PR intervals will be fixed. But that PR following the pause may be artificially short if this QRS complex arose from the AV junction as an escape beat. So you can't just look at the difference between the first PR and the last PR, because you might miss that. What you need to do is see if there's a difference between the first PR and the second PR. Now here was the first one, and now let's look at the second one. And look, the second one is in fact longer. In fact, it's often the case that during an atypical Winky back cycle like this, which, let's see, how many QRS complexes are there? 1, 2, 3, 4, 5, 6, 7, 8, and 1 P doesn't block, so this is really 9 to 8 Winky back. Okay, so that's known as atypical because it's got such a large number of QRS complexes before a P wave gets blocked. But during atypical Winky back, what usually happens is the PR interval gets longer initially, and then it remains fairly stable until the very end, where it may get a little bit longer before it blocks. But see, this is the key right here, is that the PR of the second beat is indeed longer than the PR of the first beat, and then it continues to get gradually longer, and at the very end, it gets even longer still. So we've now proven that this is consistent with type 1 second degree AV block. We'll resize these calipers one more time, and we'll get it to the R to R interval preceding the pause. And if we map it out, we'll see indeed, if we make a little mark here, that the pause is less than 2 times the previous R to R interval. So it all fits. This is known as atypical Winky back because it's got such a high number of P waves before you block one. And it's an example of type 1 second degree AV block. So let's see what they said. Show me the answer. All right, it says frequent runs blocked PACs. Oh, sorry. We already proved that that's incorrect, but I want you guys to know how to prove it. And if you understand the physiology, you'll be able to tackle these more difficult tracings and say definitively whether something is right or wrong. Well, until next week, this is Dr. Nick from the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this Chalk Talk is going to be a little bit different because it deals with a subject that I only touched on in the intermediate course, but I thought you should all be familiar with this particular subject. We're looking at a 12-lead ECG, and when you scan across the rhythm strip looking at the forest, first you see it's quite regular, but the QRS is clearly pretty wide. In fact, the QRS duration looks to be almost 200 milliseconds. So in the back of your mind, you're thinking, what's making it so wide? Some kind of interventricular conduction delay, right? Well, let's concentrate on that IVCD, because when you look at the QRS complex, you have to look at it very carefully. Because sure, you can have things like bundle branch blocks, you can have nonspecific IVCD, but you can also have other odd things like pre-excitation, otherwise known as WPW syndrome. So the thing to do is look very carefully at the QRS complex. So I'm going to enlarge this area up, V3 and V6 here. And what you see here in V3 is a wide QRS complex that's very consistent and very regular. But what you need to recognize is this very sharp spiky signal right there. And that's a pacemaker spike. And you can see it here in V6 as well. So these QRS complexes are wide because of the presence of a pacemaker. It's a pacemaker in the ventricle, and it causes this little tiny spike. For those of you who have taken my intermediate course, you'll recall that pacemaker wires are generally inserted into the right ventricle, and they're attached to the inside of the right ventricular myocardium, and they produce an electrical signal that then spreads slowly across both ventricles, not generally using the His-Purkinje system. So you have slow cell-to-cell connections that dipsy-doodle around the heart, and that causes the QRS complex to be wide. So coming back to the 12-lead here, these pacemaker spikes can be seen in some of the leads, but not all. If you look in V1, you won't be able to see much, and even in V1, you can barely see a spike. But recognize that these QRS complexes are wide, and so you have ventricular pacing, electronic ventricular pacing. Now, the thing is that I see a lot of cardiologists who read for the hospital, look at an EKG like this and say, okay, ventricular pacing, that's the answer. And they say, well, you can't tell if there's an infarction. You can't tell if there's anything wrong with the ventricle because you're pacing. And pacing basically disturbs the QRS complex and the sequence of depolarization, so you can't draw any other conclusions. And they go on to the next tracing. They get distracted by the fact that you have ventricular pacing here, and they forget to look to see what is the atrium doing. And that's a very important question, and I'll show you why. Let's take a close look at leads 2 and 3 here. And what I want you to do is notice, yes, indeed, there are little tiny V spikes here. This is the pacemaker, and we're looking at the QRS complex. But now it's time to look in between the QRS complexes. What is happening in the atrium? Look at this period of diastole and try to figure out what the atrium is doing. And you might say to yourself, well, kind of that looks like a P wave here, and so does this. But it would have to be consistent in front of every QRS complex. And when you look at this QRS, you don't see a P wave. But you might notice that there's a signal here. And if you look at this P wave and scan back, what I hope you'll notice is there's a sort of a slanty appearance to it. And then there's another signal here. And I hope you can appreciate how subtle this is, but it's there. Because if you look carefully enough, you'll see these flutter waves that are marching on through. There would be one here, there would be one here, and then you have this one. And then you'd have another one somewhere in here, and another one somewhere in here, and here's the next one. And the next one you can just see it at the front end of this QRS complex. So the interval between flutter waves is 6 small boxes or 240 milliseconds. That gives you about 250 beats per minute, and that goes along with flutter. And the sawtooth appearance in the inferior lead suggests common atrial flutter. And sure enough, if you come down to the rhythm strip, it's really quite striking how these flutter waves, they're small in amplitude, but they're clearly there. Now, what does that mean for the patient? Well, if this patient has atrial flutter and they have risk factors for stroke, they might need to be on anticoagulation. Anticoagulation is proven to reduce risk of stroke in people with atrial flutter and fibrillation. And so it's vitally important that you recognize the presence of atrial flutter here, because if you don't, if you just simply read this as ventricular pacing and ignore the rest, you might send the patient home with an increased risk of stroke. And that's why it's important to look at the tiny details and try to establish clearly that in a paced patient, someone with a permanent pacemaker, what is the atrium doing? So with this little bit of clinical insight, I hope this Chalk Talk was helpful to you. And until next week, this is Dr. Nick for the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and we're going to do this week's Chalk Talk on a rhythm strip that I found on the cardiac telemetry unit. It looks like a million other strips you've probably seen, but I think it serves a purpose, and we'll get right to it. So as you look at the forest, scan across, and you should be able to notice that the QRS complexes here seem to be pretty regular until you get to this point right here where there seems to be kind of a fast, irregularly irregular rhythm. And then you've got your regular beats back again. Now let's first analyze these regular beats. There happens to be quite a bit of baseline artifact. This is a high-frequency noise that can come from electromagnetic interference originating from equipment in the room. It could be noisy wires. It can even be from muscular artifact. But you have to kind of try to look past that noise and try to look at the intervals between the QRS complexes and see if anything kind of jumps out at you. You should be able to see that there does appear to be a consistent P wave in front of every QRS complex. And this first QRS lands on a heavy line, so if you measure back, it's about 140 milliseconds, and that's the PR interval. The QRS looks to be about 100 milliseconds in duration, but we're going to take a look at an enlarged version in a minute. Now let's take a look at this strip here. We see that the QRS complex seems to change slightly. Now these QRS complexes are almost isoelectric. Now, these QRSs are primarily up. So first we'll take a pair of calipers and measure the PR interval. So this is the beginning of the P wave to the beginning of the QRS complex. We'll bring it down to a heavy line and we see it's about 140 milliseconds. Now let's take a look at the QRS duration. And if we come down and measure, we see it's maybe 110 milliseconds. So now let's come over to these wide beats. And if you take the beginning of the QRS complex and you see the end of the QRS lands about midway between the heavy line and the first row of dots, you can see it actually looks more narrow. Let's try another one here. It actually looks like the QRS is more narrow. It certainly appears to be about the same duration, 100 to 110 milliseconds. So that's interesting. The QRS changes direction, but if anything, it might get a little bit more narrow. The question remains, what is this? It's irregularly irregular. The QRS looks different than the underlying conducted QRS complex, but it's not exactly wide. In fact, if anything, it might be a little bit more narrow than the underlying QRS complex. Well, unfortunately, the temptation is that when you see something that's irregularly irregular, you need to assume that it's atrial fibrillation. And when you see atrial fibrillation with a change in the QRS complex, then the answer must be atrial fibrillation with aberrant conduction. And certainly that's what the technician wrote, although she hedged her bet by saying patient had possible run of AFib. But if you want to be an ECG expert, you have to be able to prove whether this is atrial fibrillation or not. So let's take another close look. You need to be able to compare this PR interval with the PR interval of this first beat of this strange-looking tachycardia. It certainly appears that this P wave occurred on time when you compare the timing to the previous two. Well, if the P wave occurred on time, why does this QRS complex look different? That's really the key question. One cool trick you can do with calipers is if you establish what the R to R interval is, and you can do that with corresponding points on the QRS complex like this R wave or this S wave, or even the onset of the QRS complex, and then move over to this beat, it appears that there's nearly an imperceptible shortening of the PR interval, that the QRS is starting just a little bit early. Now, if this was aberrantly conducted because of a bundle branch block or some other phenomenon within the conduction system related to refractoriness, the PR interval would be normal or a little long, but it's short. What we learned in the basic course, in the section on ectopic beats, is that if an ectopic beat has a short PR interval, then chances are this P wave did not conduct to the ventricles and that this beat was ventricular in origin. Remember? Now these beats are quite a bit different than this first beat, and they do appear somewhat wider than the first beat. The first beat is a little bit closer to the conducted beat. And what I want you to appreciate is that this is actually a fusion beat. It's a fusion beat that came partly from this P wave conducting down the AV node, but at the same time a ventricular ectopic beat from this focus fired and deformed the QRS complex. It also resulted in a very slight shortening of the PR interval. Notice there's no P wave in front of this beat. There is a P here, but the PR is way too short. It's less than 120 milliseconds. And I really doubt that there's a P here. So then if we drag this over, we see the last of the beats, again, has no P wave in front of it. But following a compensatory pause, you have the next P wave and a conducted QRS complex with a PR interval that's, again, about 140 milliseconds. The key here is to understand that this QRS complex has no reason to conduct aberrantly. It has a normally timed P wave in front of it, and if you understand the idea behind refractoriness of the bundle branches and the conduction system, you know that aberrancy occurs because of a rapid rate or a premature beat that encounters refractoriness in part of the conduction system. There's absolutely no reason for this beat to be aberrantly conducted. And so you have to start thinking that it looks different because it didn't come from the conduction system, it came from somewhere else. Now, once you look at these beats, you can convince yourself that these are ventricular, and then it becomes clear that this indeed is a fusion beat. It has a P in front of it. That P wave was responsible for part of the QRS complex, which made it look like a combination of the underlying beat and the ventricular beat. So in essence, what we have is a 5-beat run of irregular, non-sustained ventricular tachycardia that begins with a fusion beat. Yes, it's irregular, but it clearly came from the ventricles. And being able to rationally decide that this change in the QRS complex could not be due to aberrancy is really the best lesson I can teach you in this Chalk Talk. Well, I hope that was helpful to all of you. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy. And this week's Chalk Talk, which is a rhythm strip I got off a patient's chart in the telemetry unit. Every week I scrounge around looking for good EKGs for these Chalk Talks. I call it my strip search. Anyway, this is just a chance for you guys to look at the forest and then the trees. That's the best way to try to figure out what's going on with the rhythm. Anyway, when we look at this forest, we can see that it does look to be quite irregular. In the beginning, at least, there's a premature beat here, and then a couple of regular beats, and then it seems to become irregular. And if you notice, the baseline all of a sudden becomes very wobbly here, and this irregular rhythm ensues. And you can see P waves in front of each beat here, so this looks like a sinus rhythm with a rate that's about 300, 150, 175, around 70 beats per minute. Now this beat clearly comes early, but it has a P wave in front of it with a PR interval that's about the same as the usual beat. So this is an atrial premature contraction, or APC, or PAC, however you want to call it. And there's a typical compensatory pause that follows this PAC. Then you have a couple of sinus beats, and then you seem to have this very rapid disturbance in the baseline. Now, if you took my basic course and you've seen some of my Chalk Talks, you can say that this really does have a flavor of atrial flutter. The problem is that it kind of doesn't look as consistent as it should be for atrial flutter. And in fact, a lot of people would look at this and think that perhaps atrial fibrillation is going on. And in fact, the telemetry tech who read this strip specifically wrote that the patient goes into short runs of AFib flutter. I guess she couldn't make up her mind. But when you see this kind of irregular rhythm, that's one of the things you have to consider is atrial flutter or fibrillation. But here's where it gets tricky, and the good news is that you have not just one, but you have two rhythm strips going on. Now down here you can see some of that same irregularity, some of that high-frequency baseline signal that makes you think of atrial fibrillation. But the important part is to look at the P waves, and as you can see, there's a sinus rhythm, and this one comes a little bit early, but wait a minute. If that's a P wave that looks very much like this P wave, I thought we said that the atrial signal started here. I thought that this was the beginning of some kind of atrial flutter business. You can see those flutter waves. Well then, how is it that you have a P wave in the middle of atrial flutter or fibrillation? And if you go along here, notice that this is a very low frequency signal, but you have a very high frequency jiggle right there. And as I've discussed, P waves generally have high frequency components to them, so that they tend to be much sharper than other signals like ST segments and T waves, where the change in the voltage is much slower, as opposed to here where the change in voltage is much faster and the frequency is much higher. So if that sharp signal right there means anything, it occurs right in front of this QRS complex with the same interval as all the other beats. So let's keep looking. And sure enough, you see a sharp spike right there that's a lot sharper than any of these other flutter waves. And then, of course, there's one here and one here. So what you're seeing here is sinus rhythm with PACs. That's all it is. It's sinus rhythm, PACs, and what we thought was atrial flutter and fibrillation was in fact artifact. The patient was shaking around or moving the wires, but at the same time the patient was having PACs. So it looked like an irregular arrhythmia, but it wasn't atrial fibrillation. They're just PACs. So I hope I fooled some of you out there, but if you've subscribed to Ecg Academy for a while, I hope you'd be able to pick up this kind of artifact by now. Always ask yourself, is it real? And what else could it be? Challenge yourself when you read rhythm strips and try to prove that your answer is the correct one. Consider other possibilities and then rule those out. And that's really the best way to be an ECG expert. Well, until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk teaches a lesson that I always stress to the residents that I give lectures to. It's an important lesson that you won't find out until later, so stay tuned. I'm going to present a little clinical scenario. So the nurse is monitoring lead 2, and suddenly in the middle of the night, the patient develops tachycardia. Now, the patient's awake and alert, and they feel some palpitations. The blood pressure is about, say, 95/70, so it's kind of low. But the question is, what is this? So if we use the typical rules, look at the forest first, and you can see that it really does look regular. These QRS complexes seem to be marching through. Let's figure out a rate. Now, let's find a QRS that lands on a heavy line. Here's one. Now, it's a little bit difficult to tell the rate when you have such a fast arrhythmia, but if you count 2 QRSs, it's a little bit easier to interpolate. So let's take this as 300, 150, 100, and so this a little less than that, say 90, and since it's 2 QRS complexes, that means 180 beats per minute. It seems like there might be a P wave in front of each QRS complex. I mean, it certainly looks that way. The QRS would measure maybe about 110 milliseconds in duration, and the PR interval seems a little bit short. Quite short now, maybe along the lines of 90 to 100 milliseconds. Well, that's actually shorter than normal. But yet the rate is really fast, 180 beats per minute. So this should raise a big red flag in your head. And you say to yourself, well, wait a minute. If we're talking 180 beats per minute, wait a minute, that's way faster than a sinus tachycardia ought to be, especially when a patient is lying in bed. So this has to be some kind of tachyarrhythmia. Well, remember, the AV node, when presented with rapid heart rates, does not generally conduct very well at all. And you usually have some degree of AV block at very rapid rates. At least a first-degree AV block, but how could the PR interval be this short? Only 90 or 100 milliseconds with a rate of 180? That's practically not physiologic. At least those are the questions that should be running through your mind when you look at a strip like this. How could this be sinus tachycardia with a short PR interval at this rate? Well, what's the first thing that I always say is, if you think you know the answer, challenge yourself. What else could it be? Are you sure that's what it is? And what I teach the residents to do is when they're faced with this kind of a rhythm strip and you're not sure what the rhythm strip is, what's the first thing you should order? Is it lidocaine? Is it procainamide? Is it cardizem? No. The first thing you should order is a 12-lead ECG, right? Well, I think you're going to be surprised when you see the 12-lead. This is it. Take a close look now. Look at how bizarre this looks. Look at how wide the QRS is. In fact, this is lead 2. We already saw that. Here's the rhythm strip that I just showed you. But look at the rest of it. Every other lead looks really wide and bizarre. Let me just enlarge this a little bit. Okay, now let's look at these QRS complexes. Here's lead 2, but if you look at lead 3, what you see is that the QRS complex here lands on this heavy line. But if you follow this line up, you can see that that's that first bump. What we thought might have been a P wave. It turns out that that's not a P wave, but in fact it's part of the QRS complex. The QRS in lead 2 has an RS R prime pattern to it. And the total QRS duration, if you measure it in any other lead, is about 200 milliseconds. If you go back to the 12 lead, you have to admit that these very bizarre-looking, almost sinusoidal complexes, they look like sine waves, is unmistakably ventricular tachycardia. Just remember that blood pressure is determined more by the heart rate than it is by the origin of the arrhythmia. And so you can have hemodynamically stable ventricular tachycardia at 180 beats per minute, but you could have supraventricular tachycardia at 200 beats per minute and the patient has syncope. So never use blood pressure as a diagnostic litmus test to decide whether this is VT versus SVT. That's generally a bad idea because many people get taught that if the patient has a good blood pressure, then it can't be ventricular tachycardia. But that's an absolute falsehood. That's a misconception, and don't use blood pressure to decide what the diagnosis is. So the lesson here is always get the 12 lead, because a single lead can be very misleading. And when you have a rapid tachycardia like this, the PR should be long, if anything, not short. I think that was the first clue that this was not a supraventricular tachycardia. Well, until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy with another Chalk Talk. This rhythm strip I found in the telemetry unit, and it's an interesting exercise in how to figure out what's causing pauses. Yes, indeed, you can see there's a fairly regular rhythm here, but every now and then you see a pause. Now, what's this pause due to? Because here's another one, and you have to figure out the cause of the pause. Now that we've looked at the forest, we can start taking a look at some of the trees. You can see there is a QRS complex that looks fairly narrow. There's a P wave in front of this one, and it looks like there's one in front of this one, and so it looks fairly consistent. The P waves are pretty tall on this lead, so they're pretty unmistakable. And when you look at the PR interval, it's rather long. Well, here's a QRS that lands on a heavy line, and this PR is about 240 milliseconds. Well, if you glance across at all of the PR intervals, they look to be fairly constant, just about 6 boxes across. Following the pause, it's a little bit shorter, maybe 5.5 boxes. So this is about 220 milliseconds, but then it's back up to about 6 boxes here, and that's fairly consistent. So there's a slight variation in the PR interval here, and the ventricular rate is 300, 150, 100. It's a little bit less than that, probably about 95 beats per minute. And the question is, what's causing the pause? Well, the best way to approach this is if you take out a pair of calipers. Now, what I've done is I've set the calipers up to be 2 times the R to R interval, just to kind of see if things map out, because that's kind of a cool little trick that you can move it from one pair to another and catch any little abnormalities in regularity. So here, this P to P interval looks to be pretty good, and so does this one. Now, if we take 2 times the previous R to R interval and we look at this pause, we see it's less than 2 times the previous R to R interval. So could we be dealing with Wanky back? Well, possibly. So let's figure it out. In Wanky back, which is type 1 second degree AV block, the P to P interval should be regular. And if we map out this P to P interval, and we've already said that this PR interval is a little bit shorter than the previous PR, and it gets longer again. So what should we expect when we move this over? We should expect a P wave that occurs on time. So now we compare this one, and here's one, and the next one should occur here. But if you look carefully, these P waves are enormous, and I dare say that there is no P wave there. So, that's interesting. So we don't have Wanky back, because in order to say Wanky back is present, the P to P interval should be regular, then the PR gets longer, and then the pause is less than 2 times the previous R to R. But that's not what we have. There's no P wave here. Okay, so could it be something like a missing P wave, like a dropped P wave? Well, what do we call it when a P wave just doesn't appear? We call it sinoatrial exit block. That was in the sinus node dysfunction discussion in the basic level. Okay, well, if that were the case, if this was indeed SA exit block, then the next P wave should occur on time, and it does not. It comes a little bit early. So it doesn't look like this is classic SA exit block. So then what is it? Well, here's the trick. You really have to concentrate on this area looking for a P wave. Where is the P wave? It's like, where's Waldo? And really the key is to concentrate your energy on this T wave. Can you see if there's a P wave on this T? That's really the key. If you could find a P wave on this T, then what would it be? Well, that would be a premature atrial contraction, or a PAC, that maybe didn't conduct. Well, if you look at this T wave and compare it with this T wave, you see that they are not the same. In fact, the T's are very smooth and very consistent, and then this T has a big thing on top of it. Here, let me blow that up a little bit. Okay, so here we have a nice smooth T wave, and if we were to look at that same T wave, it should look like this. But what you have is a high frequency little jiggle on top of the T wave, and I've been teaching you that P waves tend to have very sharp components to them. They have high-frequency deflections because of rapid changes in voltage that are characteristic of atrial signals. See how sharp this is? But T waves are very smooth and they have very low-frequency signals. And so when you see a sharp notch or a bite taken out of a T wave, well, that's good evidence that this is, in fact, a P wave superimposed on the T. And if we move this over to the second pause, we can see it's a little bit harder to see this time. But again, remember, you have this very smooth T wave here and fairly smooth T wave here. And now what you have is sort of a first bump right there that, okay, this time it's a little bit harder to sell, but really we're dealing with the same phenomenon. And that is a non-conducted PAC that doesn't get to the ventricle. Now, how do we explain away the rest of these findings? Well, first of all, if you have a PAC, you're going to wind up with a compensatory pause, but the P wave that follows the compensatory pause has no obligation to be exactly on time because you can get overdrive suppression of the sinus node by this PAC. So the sinus node can come in any time it wants, and that explains why this P wave does not occur on time. Now, why is this PR interval shorter? Well, what you have here is more time for AV nodal conduction to improve. Here you have a rate of 95 beats per minute, so the AV node may be just barely keeping up with this faster atrial rate, and you have a little bit of a first-degree AV block that's going on. But now what you have is the pause that refreshes. The AV node perhaps is able to conduct a little bit better following this longer interval. And that's why the PR interval is shortest following this long P2P interval. And then when the next P2P interval shortens considerably, well, then the PR gets longer, but stays fairly constant after that until this PAC blocks. And the same thing happens with the PR interval shortening up following this pause and then getting longer again. So this is a great example of non-conducted or blocked PACs. I prefer the term non-conducted because the word blocked implies that there's something wrong with the AV node. In this case, there is a little bit of a first degree, and there may be some mild AV nodal delay. But if you take the P2P interval from the sinus P to the PAC, measure back, it's 300, 150, it's about 120 beats per minute. So it's a pretty fast P wave with an interval that's just too close for the AV node to conduct. But in general, the word block implies there's something wrong with the AV node. In this case, the disturbance is only mild at best. So there you have it. Frequent blocked PACs causing pauses, but being able to prove that that's the mechanism of the pause, that's where you need to be able to analyze these rhythm strips and find all the little subtle details that give you the answer. On that note, we'll conclude this Chalk Talk. This is Dr. Nick with the Ecg Academy. Thanks for watching. This is Dr. Nick with the Ecg Academy, and this week's Chalk Talk features a 12-lead ECG with a wide complex tachycardia. Patients like this will often present to the emergency room with either syncope, palpitations, shortness of breath, or lightheadedness. And at first glance, you can see it's very fast, and the QRS complexes are rather wide. Well, the first thing you should do is look at the forest, and as you look at the rhythm strip, you see that there is a slight irregularity. Clearly, it's faster in some areas and slower in others. Most people will look at this and immediately decide that it's atrial fibrillation with a rapid ventricular response. But then the question is, why is the QRS so wide? Well, let's see if we can prove whether you're right or wrong by looking at the trees. Indeed, the QRS is very wide. This one happens to fall on a heavy line, and if you look carefully, you can see that QRS is 4 small boxes wide, or about 160 milliseconds. Now, at this rapid rate, if you want to look at the average R to R interval and figure it's about maybe 150, 160 beats per minute, but there are better ways of measuring it. My favorite way is to look for 3-second marks and count off how many R to R intervals there are in 6 seconds. If you don't have 3-second marks readily available, find a QRS complex that lands on a heavy line. Count off 6 seconds, just like this, and then count the number of R to R intervals in those 6 seconds. So you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, and another half, so 175 beats per minute. You can see it's even faster than I thought when I first glanced at it. So it's an irregularly irregular rhythm at 175 beats per minute, no apparent pattern to it, and I can't really say that I definitely see flutter waves, because one of the things you might think about is a rapid flutter with variable conduction, or perhaps an atrial attack where it's 1-to-1 over here, None of those seem to ring true. And I think if you look carefully at the baseline between some of these beats, it's fair to say that you do have atrial fibrillation. But now, why is the QRS wide? Well, the first thing you should look at is the axis. The axis is isoelectric and AVR. If you recall, lead 1 goes straight across, and AVR is 30 degrees above the horizontal. So perpendicular to that would be minus 60 degrees. Well, that's a marked left axis deviation. But let's now look at the precordial leads. V1 looks like a classic left bundle branch block pattern, with a QS or maybe a tiny micro R wave here, with a small R that progresses across. But by the time you get out to V6, it's a classic rabbit ear RSR pattern, which is also seen in the lateral leads 1 and AVL. So as far as I can tell, this is a classic left bundle branch block pattern with a marked left axis that we often see with a left bundle branch block pattern. I'm sure many of you consider the diagnosis of ventricular tachycardia. Although ventricular tachycardia can sometimes be irregular, this kind of sustained irregularity would be very unusual. It's generally non-sustained ventricular tachycardia that can be very irregular due to an automatic or triggered mechanism. Also, the vast majority of ventricular tachycardia will not have a QRS morphology that's typical for a bundle branch block. There's usually either a bizarre axis or some abnormality in the R wave progression that makes it very atypical for a bundle branch block. Overall, I think this is pretty straightforward. It really shouldn't take you more than 10 or 15 seconds to decide that this is atrial fibrillation with a rapid ventricular response and a left bundle branch block. Once you know the physiology and get practice reading ECGs, you should be able to pick this up and know what's happening almost immediately. Well, that's it for this week's Chalk Talk. This is Dr. Nick for the Ecg Academy. Thanks for watching. Hey, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a bit more basic, but I wanted to make a point about different arrhythmia mechanisms, so hopefully you can start to think a little bit past just the basics. Well, as we look at the forest, we can see that this ECG is somewhat irregular because it's very slow in the beginning, and then it speeds up and then kind of slows down a little bit towards the end. If we look at the first couple of beats, there seems to be a variation in the P-wave morphology. Look at this one is upright, but this one has a bump in it. And when you look in lead 3, you can see it's upright here, but this one looks kind of inverted. And then suddenly what happens is you have right here a premature beat, and then the heart rate is much, much faster. Well, let's make a few basic measurements here. If we want to measure heart rate, we can see this QRS lands on a heavy line, so we can count off 300, 150, 100, 75, 60, 50. So the heart rate initially is about 56 beats per minute or so. But down here, when it speeds up, it's about 3 small boxes, which corresponds to a rate of 100 beats per minute. The P-wave morphology clearly varies. This looks like a complex sort of up and down squiggle, whereas this beat that follows a pause is probably the sinus beat, because it's a nice smooth P-wave that's upright in 1, 2, and 3. So what exactly is happening here? Well, we'll nail it down a little bit, but notice that it is a little irregular. If I take a pair of calipers and resize it to this R to R interval, you can see it actually starts out a little bit faster at a rate of somewhere around 115 beats per minute. Then it's a little faster still, about 120, and then it settles down to that 100, but it remains a little bit irregular, perhaps a little bit faster than 100, maybe 105 beats per minute. And then what happens is you have sudden slowing with a change in the P-wave morphology that makes it look more like that sinus beat, but not quite. And then you have another 2 beats of this strange morphology. So if you had to classify this arrhythmia, the easiest thing would be to call it a supraventricular tachycardia. It's not coming from the ventricles, so it must be supraventricular. Well, that's the very basic generic term for something like this, and an ECG expert should be able to do better. So clearly the P waves are driving the QRS complexes. The P wave precedes the QRS with a pretty physiologic PR interval, maybe 170 or 180 milliseconds. And the variation in the PP interval is followed by variations in the R to R. So this P to P is a little bit shorter, and therefore this R to R winds up being shorter. Then the atrial rate slows down, and the ventricular rate follows suit. So the arrhythmia is up in the atrium someplace, and the AV node is just passively conducting the impulses down to the ventricles. So let's come up with a better idea for this. We're going to call this atrial tachycardia, and the AV node is known as a bystander, meaning that it's not participating in the arrhythmia directly as it would in other kinds of supraventricular tachycardias. Well, let's see if we can do a little bit better than this. Because remember that tachycardias come in two different flavors in terms of electrophysiologic mechanisms. There are disorders of impulse conduction, and there are disorders of impulse generation. These are mechanisms that we'll cover in the advanced course. But think of disorders of impulse conduction as being due to re-entry, where the electrical signal is stuck going round and round in a circle because of an abnormal pathway within the heart. It's being conducted around and round in a circle. That's why it's a disturbance of impulse conduction. Whereas disorders of impulse generation mean that one little area in the heart is generating rapid signals, and these are sort of spreading in a radial fashion across the rest of the heart. Well, the one clue that goes against reentry is that it is a bit irregular. Normally what happens with reentry is a premature beat occurs, and it gets into a reentry circuit, and then it goes around and round in a fairly regular fashion in an organized way, such that the arrhythmia is generally quite regular, but the first beat might be premature, and often that first beat has a different morphology than the rest of the beats. Well, I suppose if this is the PAC that initiates the tachycardia, that might make sense, but what doesn't make sense is the first interval is faster, and then it begins to slow down, and then it gets faster again, and then it slows down again. So there is a certain irregularity. Not to mention here, where it looks like you probably have a fusion beat with a sinus P wave that's trying to sneak out and perhaps fusing with a beat coming from the region of this focus, and then it kind of speeds up again with what's often referred to as a warm-up phenomenon, where this rate is slower and then it speeds up again. So you have a spontaneous variation in heart rates that would seem to suggest a disorder of impulse generation. And so the most correct arrhythmia diagnosis is automatic atrial tachycardia. The rest of the cardiogram is notable for just borderline LVH. The QT is definitely prolonged here. If you remember how to calculate the QTC, you can put your calipers down, measure the QT, which is just about 400 milliseconds, but the R to R is about 600 milliseconds. So if you remember, QTC is equal to the QT divided by the square root of the R to R in seconds. So if we take the QT as being 400 divided by the square root of 0.6, because the R to R interval is 0.6 seconds, it's 0.6, take the square root of that, and then divide, and you get 516. Remember, even for women, the upper limit of normal is 440. So to sum this up, it's not just SVT. You have to try to define the arrhythmia mechanism, both in terms of AV nodal participation in the arrhythmia and also the electrophysiologic mechanism, either reentry or an automatic focus, and then put it all together to give you the complete interpretation. Well, that's it for this week. This is Dr. Nick for the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and we have this week's Chalk Talk on a single rhythm strip, so it's pretty basic, but let's get to it. When you glance at the forest, you can see the strip is irregular, but it starts out fairly slow, and it looks like you have a couple of normal beats in the beginning with PQRST at a rate somewhere around, let's count this off, 300, 150, 100, 75, 60, a rate of just around 60 beats per minute. We can see the next P wave comes in a little bit sooner, though. Counting from this P wave, 300, 150, 175, maybe about 80 beats per minute. So there's a slight increase in heart rate from 60 to 80. And then all of a sudden we have this rapid sort of irregular heartbeat. Well, where does the next beat start? And here's the next QRS complex. And it's very similar to this one. But the rate here is a little under 150, probably 140 beats per minute. Well, it looks a little bit different than the first one, but is it a premature atrial or a premature ventricular beat? Well, you have to look for a P wave that might precede it. We don't see a P wave right here, but there is a bump on top of this T wave. If you compare this T wave with this T wave, you can see there's a bump. So that's a premature beat. It's a premature atrial contraction that conducts with a bit of a first degree AV block. The PR there is about maybe 260 milliseconds. And then when you look at this ST segment, you can see there's another bump that looks just like this one. You see the next P wave is occurring here at a rate that's even faster than 150. Well, now you're starting to see a rapid atrial rhythm with discrete P waves at a rate somewhat faster than 150 beats per minute. But what's happening to the ventricles? You can see this P wave conducts to this QRS, this P wave conducts to here, this one conducts to here, but then this P wave is not followed by a QRS complex. It is blocked. And the PR interval here is 280 milliseconds. And what happens following this blocked beat is that you have another P wave that's pretty much on time at a rate of about 150, and it conducts with a shorter PR. So far, we have discrete P waves at a rate of 150 beats per minute, and you have progressive PR prolongation before a beat fails to conduct. So if we had to give this a diagnosis, we'd call it atrial tachycardia with block or with type 1 second degree AV block. Some people call it PAT with block. And the mechanism here is that you've got an atrial arrhythmia that's either a focus firing rapidly, and the AV node is just not able to keep up with it. So you get progressive prolongation of the AV conduction time because of delay in the AV node, and then finally you get block. Sometimes it's not an automatic focus, but rather a reentry circuit. So there could be two different potential mechanisms for the atrial tachycardia, but the AV block occurs when your atrial rate is faster than the AV node can handle. But let's see what happens after that. Yes, it conducts, but look at this beat. This is a very interesting beat right here because it looks distinctly different than all the other beats. It's preceded by a P wave here. The PR is a little bit longer than the previous PR. And following this wide QRS complex, you have the same atrial tachycardia going on, except the PR is a little bit more stable. And if you look at the atrial rate, it's a little bit slower than 150 beats per minute now. So the AV node is conducting 1-to-1 because the atrial rate is slower. So it looks like this particular AV node is able to conduct 1-to-1 up to a rate of maybe 150. Here at 140, it's conducting 1-to-1. Here at 160, we get block. Well, let's see what happens after that. This P wave conducts to the QRS complex, and then when you notice the following ST segment and T wave, there's no P. And so your atrial arrhythmia stopped, and as you would expect, there's no QRS complex. Instead, you now are back in sinus rhythm with a much shorter PR because this is the pause that refreshes and allows your AV node conduction to improve to the point where it was in the beginning, with a PR interval that's less than 200 milliseconds. So the question remains, why is this beat wide? And the answer is Ashman's phenomenon. Because what you had here from this beat to this beat was a long interval because of this non-conducted P wave. And then when this P wave comes in early, you get a short interval. So with that long-short pattern, this beat conducts aberrantly. So you have this Ashman type aberrancy because of the long-short timing due to the blocked P wave during atrial tachycardia. If you need to, you can go back to my basic course and watch the videos on interventricular conduction, because we talk about why Ashman's phenomenon occurs and how you can easily recognize it. Well, that's it for this week. This is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the first Chalk Talk of 2013. Happy New Year to all my subscribers. This was a rhythm strip that I got off of the telemetry unit, and I thought it was unusual enough and basic enough to bring up as a Chalk Talk. So as you look at the forest, you see that things change over time, and there seem to be two different QRS complex patterns. There's this sort of narrow up-down morphology, and then you have these very wide positive beats, and it seems to go back and forth between the narrow here and the wide. They're at similar rates, and you should be able to recognize a P wave in front of each of these narrow beats, with a PR interval of about 160 or 170 milliseconds. That seems to be pretty constant. If we pull out a pair of calipers and bring it down to this heart rate, you can measure the PP or you can measure the R to R interval. Put the point of the caliper on a heavy line and you can measure 300, 150, 175. So the heart rate here is about 85 beats per minute. But when you come to these beats, it's only slightly faster. It's maybe 90 beats per minute here. I'll park the calipers over here for a bit and then look for some other observations. If we look to see how this rhythm starts, that's usually the best place to decide whether this is atrial with aberrancy or ventricular. And although there's some noise in the baseline here, and one could perhaps make an argument that this little jiggle could be a P wave, when we look down at some of the other beats, there does not seem to be a consistent atrial event in front of these wide complex beats. So the assumption is that these came from the ventricles. Well, with a rate of about 90 beats per minute, the best diagnosis we can give this is accelerated idioventricular rhythm. Usually, AIVR can start one of two ways. If we bring our calipers down to these P waves and see where the next P wave is supposed to land, I think you can see that there is a little tiny P wave there because that little bump is absent on this beat. So this QRS complex started simultaneously with the P wave. This P obviously couldn't have conducted, and that pretty much clinches it that these are ventricular events, and this is one of the ways that AIVR gets started. It simply overtakes the sinus rate because it's going a little bit faster than the sinus rhythm. Sometimes you'll see AIVR start as a premature beat, like a PVC, that may then suppress the sinus rhythm and give the opportunity for additional ventricular beats to follow. In this case, I found something interesting. The atrial and ventricular rates are nearly the same, but let's just say if we were to use these calipers and figure out what the atrium is doing, because that's the interesting part of this. What do you think the atrium is doing during this ventricular arrhythmia? Well, if this is the next P wave, where would the following one occur? We can map it, and it would probably occur just at the onset of this QRS complex. Well, where would the next one be? Well, probably in the middle of the QRS, assuming the atrial rate is constant. The next one should have occurred here. We don't see it yet. But what I'm starting to see is that the last part of the QRS complex is beginning to have a kind of a downward deflection. It's not here. We don't see it on this beat. But now it's downward, and we can definitely see a downward deflection here. Is that a sinus beat? Well, where would the sinus beat have fallen? Would actually have fallen out here someplace. So I think the atrial signal came a little early, and the reason it came early is that this could be a retrograde P wave. Because if we now look at the next beat that occurs and measure back from this P wave, it seems to coincide with this one. Now what happens with retrograde P waves is the P is able to enter the sinus node, and the sinus node gets reset. And then after the AIVR stops, because this focus in the ventricle stops firing, this retrograde P has to enter the sinus node, reset it, and then the next sinus beat has to come out. And that takes a split second, related to the time it takes to get in and out of the sinus node. That's actually part of our discussion in the advanced course, is the sinoatrial conduction time. But that helps to explain why this P wave came just a fraction of a second later than it would have if we went ahead and put the calipers on the beginning of this retrograde P wave. So this is a pretty interesting example of accelerated idioventricular rhythm, but next time you see this unusual arrhythmia, I want you to try to figure out what the atrium is doing, because just like during ventricular tachycardia, you can usually see some evidence of AV dissociation. Well, that's it for this week's Chalk Talk. I hope you enjoyed it. Until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is kind of a 2-for-1 because I have 2 strips here that I'm going to show you, and they're both similar, so I want to discuss what you should be looking for. Now, you can see right here that we have a wide complex tachycardia, and if you look at the underlying rhythm, it's irregularly irregular, and you've got a little jiggle to the baseline, and so what we have here is atrial fibrillation. Okay, that's easy. See you next week. I'm just kidding. You see, one of the most difficult problems that I come across is being able to tell the nature of a wide complex tachycardia during atrial fibrillation. Why is that? Well, wide complex tachycardias, you're generally trying to figure out whether it's ventricular tachycardia or some kind of supraventricular tachycardia with aberrant conduction. And it's much, much easier to tell which one of these it is when you have an underlying sinus rhythm, because the P waves are an important clue to figure out whether a wide complex tachycardia is atrial or ventricular. So when you have no P waves, such as here during atrial fibrillation, it becomes a lot more difficult. Well, I want to give you a couple of clues, and you can use these clues to help analyze ECGs in your own experience. Now, what should you be looking for? You have to remember the physiology. Well, during atrial fibrillation, what actually controls the heart rate? Of course, it's the AV node. The atria are beating at 350 beats per minute or thereabouts in a very rapid, disorganized fashion, and it's the AV node that's like the gatekeeper. That's what determines how many signals get to the ventricles. So ultimately, the AV node determines the heart rate. Now, the AV node is a team player, meaning that it takes orders from the rest of the body, including the autonomic nervous system. Sympathetic and parasympathetic inputs to the AV node will have a profound effect on AV conduction, but these take some time. Parasympathetic at least a few seconds, and sympathetic may take much longer. So you don't see sudden changes in AV conduction over the course of 1 or 2 beats. It's certainly not radical changes in AV conduction rates. So that's the first clue, and that if you have atrial fibrillation that's conducting fairly slowly here, and then all of a sudden the heart rate speeds up, that would not be physiologic. That would not be expected. And so that makes it much less likely that this was conducted down the AV node, and therefore it's more likely ventricular. The second important clue is the regularity. Of course, during atrial fibrillation, the hallmark is that it's irregularly irregular. Now, granted, when atrial fibrillation conducts rapidly, or particularly when atrial fibrillation becomes organized to an atrial flutter, you can get regularization of the ventricular rate, and that can lead to a regular tachycardia. But it's a bit of a stretch to say a regular wide complex tachycardia is not ventricular in origin unless you have other clues around it, like other narrow complex tachycardias at a similar rate. In other words, although atrial fibrillation can become rapid and regular, it's much more likely ventricular when you have a sudden change in heart rate and you have a regular pattern such as you see here. The third clue has to do with the nature of aberrant conduction. Remember, it has a lot to do with the action potentials and the fact that part of the conduction system may take a little bit longer to repolarize than other parts of the conduction system. So that if the AV node lets an impulse down right at this moment, then one part of the conduction system may be able to fire, but the part that's refractory will not. And you'll have heterogeneous conduction where one of the bundles can conduct and the other will block. And if this doesn't look familiar to you, I cover all of this in my basic course on the Ecg Academy. And you can go back to that video and watch it over again. Aberrant conduction, number one, is more likely to occur at faster rates, such as you see here. And it's also more likely to occur when it's preceded by a pause, such as you see with Ashman's phenomenon, because the long pause causes this beat here to have a longer refractory period and the bundles repolarize with more heterogeneity. Now this fits Ashman to some degree because there is a longer interval here and this is somewhat short, but it's not that short. The rate here is about maybe 130 or 140 beats per minute. And unless one of the bundles is very unhealthy, I wouldn't necessarily expect that to conduct aberrantly, but it could be. But that's why I want to show you the second strip. Now, this is a classic example of Tulow's law. Never believe anything that you read on a rhythm strip unless you wrote it yourself. So here's a patient who has atrial fibrillation. This is sort of the full disclosure, and you can see there's an irregularly irregular rhythm here, and there's no real visible P waves, although right in this moment there's a lot of artifact. Don't pay much attention to that. But here you've got this wide complex tachycardia. And the first beat certainly starts very prematurely. And you say to yourself, look at the average heart rate over here, just before this arrhythmia. The average heart rate is maybe 60 beats per minute, maybe 70. So now we have an idea of what the AV node is doing. So it's highly unlikely that the AV node is going to suddenly conduct such a short interval. I mean, that's like 200 beats per minute, making it more likely that this first beat was ventricular. Now, although you can say that, yes, there's a little bit of a long, short pattern, which might explain how this first beat could have been aberrant. But the second beat is certainly not nearly as rapid. Or this next beat, which is going down at about 100 beats per minute, that's not much different than this interval here, where it's around 90. So how is it that this beat got conducted in a narrow fashion, whereas this beat is wide? If you're saying that this run is aberrant, then there's no real explanation for why they're aberrant. You have to think, why are they aberrant? Is it premature? Is it preceded by a pause? Is there a reason for the bundle branches to heterogeneously repolarize? You have to tell me why you think this is a functional bundle branch block. Otherwise, you really haven't proven that it's aberrant, other than the fact that you don't want to call it VTAC because then you'll maybe have to make a phone call or address it or deal with it. What's really astounding is that this interval is so enormously long, and yet this beat is still wide, and yet they're still calling it aberrant conduction. This couldn't possibly be aberrant after the pause that refreshes right over here. So it's making no sense to call these aberrancy. There's no reason for it to be functionally aberrant. It goes against the rules of physiology, and therefore it must be ventricular. Yes, it's relatively slow, and yes, it's very irregularly irregular, but it's ventricular nonetheless. And you can be sure that anyone who knows ECGs is going to look at this reading and know it's wrong. Well, anyway, I hope this was another educational pearl that I shared with you. And I just want to thank you for being a subscriber to the Ecg Academy. And until next week, this is Dr. Nick. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk comes from a Holter monitor from my office. We're going to get down to some basic arrhythmia analysis. These 2 pages are continuous strips. So if you just look at the forest, you can see that there's a fairly regular rhythm here. And then down the road, it seems to pick up in speed. And then at the very end here, and then slows down and then speeds up again. So it's somewhat irregular, but what you're trying to figure out, what's the atrium doing and what's the ventricle doing? So we'll look at the first strip first. If we want to try to figure out what the heart rate is, this QRS lands close to a heavy line, so let's count off 300, 150, 100. This would be 75. So we're talking somewhere between 85 and 90 beats per minute. Where is the P wave? Well, I see a pretty prominent P wave right there, but if you measure that PR interval, it's really very long, 360 to 400 milliseconds. There are 2 things that you have to keep in mind. When the P wave lands right in between 2 QRS complexes, you have to wonder if maybe you're seeing an arrhythmia with 2-to-1 AV conduction, because on occasion, there'll be a P wave hidden in the QRS complex that would land right in between these 2 P waves that are in the middle of the R to R interval. So that's the first thing you should keep in mind. The second thing is, with such a long PR interval, either this patient has fairly substantial AV nodal disease, or there's some other explanation for poor AV conduction, namely a rapid atrial rate. So that's 2 reasons to look for a P wave in the middle of the QRS complex. So here's the next P, and we're assuming that this is conducting, and we wonder if there's a P there. And let's go on and see what happens. There seems to be a very consistent rhythm with this rate of about 85 beats per minute that conducts with a long first degree. Now, if you ask me, this P wave looks very wide and quite large, and frankly, I don't see how a P wave could be hiding there without us seeing at least a piece of it in the beginning or the end of the QRS complex. But let's keep on going. So you've got this rhythm with a long first degree, and then let's see what happens now. Now this QRS comes on early. If you measure from this QRS complex, the rate now is 300, 150, 100. So the rate suddenly increased from 85 to about 100 beats per minute. Where did this QRS come from? Where's the P wave that belongs to this QRS complex? That's what you have to be looking for. A lot of people would look at this rhythm right now, here, from here to here, and say, oh, okay, that must be a junctional tachycardia here, because I don't see a P wave in front of the QRS complex. But remember, this PR interval at a slower rate was really very long. So when the rate increases, you'd expect the PR interval to get even longer. So where's the P wave? It's right on top of this T. Remember, when you're looking for P waves, you have to look carefully for T wave changes. And if you examine these T waves, they're all very nice and smooth, and then this one has a double bump. So the P wave is on top of here. Well, that's where this QRS complex came from. But it's really a PAC, and then it starts this change in heart rate, where now there's a P on top of this T wave, and you can see a distinct double bump here. But remember, the T wave is peaking about 300 milliseconds after the QRS. So this here is the T wave, and the P wave is actually the first bump. And this is the next P wave, and it's conducting with a very long first degree. And the rate here now is a pretty steady 120 beats per minute. And so what you have to call this is atrial tachycardia, because you have discrete P waves in front of every QRS complex. They're conducting 1-to-1. It just so happens that there's a very long first degree AV block. But remember, these three lines are all going simultaneously, so you can see these P's, and it seems like this P wave was the first beat of tachycardia, and these just happen to be sinus beats, and I really don't see 2-to-1 conduction here. I think what you have is just a sinus rhythm with a very long first degree, and then you have a PAC that starts this run of atrial tachycardia. Now, let's go to the second strip and see what happens to it. Okay, we're still seeing double bumps. Remember, the second bump is the T. The first bump is the P wave that's part of this atrial tach, and it's conducting with a very long PR interval, and here's the next one. And so you've got this regular tachycardia that's going on, and as I said, a lot of people would not notice that double bump here. It would call this a junctional tachycardia, but that would not be correct. And we'll see what happens now as this tachycardia ends. This is the last of the Mohicans. It's the last P wave of the tachycardia. If you notice that this T wave does not have a double bump, and so there's no P there. This last P wave of the tachycardia conducted passively down the AV node, and then the tachycardia stops. You've got a little bit of a pause, and the sinus rhythm resumes, again with a long PR interval, but back to a rate in the range of about 80 beats per minute. And now look what happens. There's another PAC here that conducts, and looks like it starts another run of tachycardia. So what you have is recurrent runs of atrial tachycardia with a long first degree AV block, but in between there's a sinus rhythm with a long first degree as well. But you have to be sure that you can identify where those P waves fall and associate every P wave with every QRS, trying your very best to figure out where did the QRS come from. It's very rare that a QRS just comes out of nowhere unless it's a PVC. So if you use this technique to map every P wave to every QRS, you'll find that you can almost always come up with the right answer. Now, we did establish that there was a first degree AV block, but there's no second degree block, and there's certainly no junctional rhythms here. This is all sinus and atrial tach, and likely there's an automatic focus up near the high right atrium, because if you notice, the P wave during this tachycardia does not look substantially different than the P wave during sinus rhythm. It looks a little bit different, but they're all kind of going in the same direction. None of them are inverted. And so chances are, if this is the sinus node, then the ectopic focus is nearby, takes over the heartbeat, but the P waves only change slightly. There's a sudden change in heart rate, so you know it's not sinus tachycardia. And that's key, because some telemetry techs would be tempted to call this a sinus tachycardia, but it's not, because the rate changed so suddenly. Well, these are some basic concepts, but I hope it refreshes your memory that you should be thinking in terms of the physiology in the heart. Because you won't see rhythm strips like this in a textbook, you have to be able to figure it out. That's why I like to talk about ECG analysis, using your knowledge of physiology to analyze what's going on and decipher what the heart is actually doing. Well, that's it for this week's Chalk Talk. This is Dr. Nick for the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a bit of a 12-lead challenge. If we glance at the rhythm strip, we can see that it is irregular, but if we try to distinguish if there's a regular pattern to it, we should be able to see that, in fact, there are groups of two. So there's group beating going on, and we'll have to figure out why. The group starts with a P wave, and then there are two QRS complexes that follow, then a P wave, followed by two QRS complexes. So let's take a look at the rest of the ECG. That PR interval looks to be normal, maybe 160 to 180 milliseconds. The QRS duration also appears to be normal, maybe about 110. And when we look at the QRS axis, we can see that it is isoelectric in lead 2. So what's the axis in degrees? Well, remember that lead 1 goes straight across, and since in English we read down and to the left, we know that the next lead to draw is lead 2, and that is 60 degrees above the horizontal, because lead 3 splits the circle into 3 equal parts, each of these angles being 60 degrees apart. So if the axis is isoelectric in lead 2, and it being negative in the inferior leads, 3 and AVF, it must be going away from the feet. So the angle that's perpendicular to lead 2 going away from the feet would be minus 30. So the axis is minus 30 degrees, and that is a left axis deviation. So let's figure out why there's a left axis deviation. Some of the more common causes include an old inferior MI, but you do not have Q waves in the inferior leads, you have R waves. But what you do see is a very tall R wave in AVL. It's about 13 or 14 millimeters, which goes along with LVH, left ventricular hypertrophy. You can also see ST segment sagging here, which is a secondary change going in the opposite direction from the QRS complex, and that's a repolarization abnormality that we see in LVH, which is known as a strain pattern. So most people would say that there's moderate criteria for LVH in this cardiogram. Well, let's look for LVH in the precordia leads. We do have a nice deep S wave with an interesting alternans pattern with deep and not so deep and deep and not so deep. We do see these alternans patterns commonly in electrocardiograms. But this is more likely related to the fact that you do have a bigeminal rhythm. And there may be very, very subtle interventricular conduction abnormalities resulting in subtle changes in the axis. Well, you would look for a tall R wave in V6 that would go along with LVH, but what you see is actually a deep S wave. And in fact, the R wave progression across the precordium is not so great. Look at these reasonable R waves, 3 to 4 millimeters, but they're persistently small, even out to V6, and you have a persistent deep S wave in all these leads. Now, some people would say, well, a deep S wave in V6, doesn't that go along with RVH? Well, in that case, you would have a right axis deviation and positive forces in the anterior precordial leads going towards the right ventricle with tall R waves in V1 and V2. So RVH is not present, and instead what we call this is late transition. Now, some people refer to this as clockwise rotation. If you look at the chest wall from below with the sternum here and the spine over here, the heart is in the chest pointing over to the left side, and you're monitoring V1, V2, 3, 4, 5, and 6. And you expect to see a transition point between V3 and V4, where the R wave then becomes larger than the S wave. But when the R wave stays small all the way out to V6, it kind of implies that electrically speaking, the heart is rotated in the chest in a clockwise direction. So that's why we call this clockwise rotation. It is an electrical abnormality and doesn't necessarily correspond with any myocardial problems. Okay, so we have a bigeminal rhythm with left axis deviation due to LVH with some repolarization abnormalities or strain, and we have late transition, otherwise known as clockwise rotation. So much for the 12-lead interpretation, but let's get down to the rhythm strip and we'll take a closer look. So indeed we have this bigeminal pattern, and when you see bigeminy like this, when you see groups of 2, you have to rule out whether there's 3 to 2, winky back conduction, or something else. If we take out a pair of calipers, we can see that these groups of 2 are in this repeating pattern, and the patterns are quite regular. And you can even measure the R to R intervals here. So what's the overall pattern? Cycle length, and that turns out to be about 1,000 milliseconds. So if it's 60 beats per minute for 2 beats, then the average rate for this rhythm strip is 120 beats per minute. It's 1 second for each cycle, but the actual rate is twice that. If this is a P wave and this is a P wave, we have to figure out, are there 3 P waves in this span of time or not? And we can figure that out by just taking our calipers and resizing it to 1/3 of that time interval. So let's reset our calipers for about 330 milliseconds. Now if we bring that over to the beginning of the P wave, so let's see if we're pretty close to the cycle length that we're looking for. We'll put the 1 point on the beginning of the P wave, we'll make a little mark here, we'll move the calipers over 1, we'll make a little mark here, and then move the calipers over 1 last time, and that times out very nicely with the next P wave. So what should we expect to see at these marks? Well, if we have 3 to 2, then we would expect to see the beginning of a very chunky P wave right over here, which might be masked by this T wave. But then we would expect to see another P wave right at this location. So if we imagine that 3 to 2 conduction is going on, you have a P wave here, you have a P wave here, you would have a P wave here, and then the next one would occur on time. Now, for those of you who've seen these chalk talks and have watched my lessons, you should have already noticed that this T wave is a lot taller than this T wave. And sure enough, the T wave following the first beat is consistently taller than the T wave following the second beat. See how this is tall, and this is shorter, and this is taller, and this is shorter. So what you have here is, in fact, a P wave superimposed on the T. But where is the P wave here? And you'd expect to see a very chunky P in this location, and you don't. In fact, this ST segment looks extremely smooth and identical to this one. And you can see that the ST segments are very consistent. So the third P wave doesn't exist. Instead, what you're seeing are premature atrial contractions landing on the previous T wave, and then just a bit of a pause following the premature beat, and then you have a sinus beat here, and then a PAC, and then a sinus beat, and a PAC, and that pattern of bigeminy persists throughout the tracing. So sinus beat, PAC, sinus beat, and PAC. It's atrial bigeminy. Now, because the PAC hits the AV node prematurely, this PR interval looks to be a little bit longer than this PR. This one's about 160. This one's about 200. And the QRS morphology looks very slightly different as well, probably because of a very, very subtle bit of aberrancy, as a very small branch of the cardiac conduction system might be refractory at that point. So from a physiologic standpoint, it all makes a lot of sense that you have a sinus rhythm here at a relatively rapid rate, considering when you take this PAC and you compare it with the timing of this P wave, the sinus node fires at somewhere around 90 or even close to 100 beats per minute. It's still a sinus rhythm, just a bit fast, with atrial bigeminy associated with all the other abnormalities that we identified in the beginning of this chalk talk. So I hope this helps you decipher more complex tracings in the future, if you just keep in mind the physiology and remember that a bigeminal rhythm could be 3 to 2, but not always. And Wanky back requires that the P to P intervals be regular. And in this case, those P waves were clearly not there. Well, that's it for this week's Chalk Talk. This is Dr. Nick with the Ecg Academy. Thanks for watching.
Hi, this is Dr. Nick with the Ecg Academy. And you can see my voice still hasn't recovered, but I wanted to get another Chalk Talk out to you guys. Anyway, this is called Back to Basics. But even though it's a basic strip, a lot of people might get it wrong because it's one of the most common misconceptions in electrocardiography. Anyway, let's get started. If you look and see what the heart rhythm is doing, there is an irregular rhythm here. There's an isolated QRS complex here. And if you pay attention to the circle signs, which the telemetry nurse was kind enough to provide for us, we can see that there are P waves that are marching through, and some of the P waves do not appear to be conducting. Then it seems like you have one-to-one conduction here, and then some other P waves do not appear to conduct. In the bottom strip, it looks like there might be a period of 2-to-1 conduction, and then you have groups of 2 here. So you've got some group beating. So there's a little bit of everything for you guys. Well, the first question, is this AV block? And you might say, well, what do you mean? Of course it's AV block. There are some P waves that don't conduct. But one of the most common mistakes that people make is they're quick to call AV block when in fact what you're dealing with are non-conducted PACs. So you first have to determine if the P to P interval is regular, because if this happens to be a PAC, then you have a physiologic reason why it might not conduct. So let's pull out a pair of calipers first. We can look at our atrial rate. I set the caliper tips to the larger initial deflection of the P waves, and we can come down here, put one point on a heavy line and count off 300, 150, 100, 75, 60. So it's a little less than that, or 56 to 58 beats per minute. So the atrial rate is somewhat slowed, but let's see if it's regular. So here's this, and let's compare it with the next P to P interval. And yes, indeed, it does appear to be quite regular. I'm looking at the initial large deflection because this P wave looks a little like an M. It has a bifid appearance to it. And when you're measuring P to P intervals, always pick the same part of the P wave to measure, either the onset or one of the more prominent deflections. And sure enough, the P to P interval is regular. We can come down here. This was probably a different time. See, this is 1:34 a.m. This is 45 minutes or so later, so the atrial rate is a little bit faster, but indeed this looks regular as well. So you have a regular atrial rhythm. Here it's a little bit faster than 60 beats per minute. And you have P waves that fail to conduct. Well, you should immediately run through in your mind how to classify AV block. So you have first degree, you have second degree, and you have third degree. And by definition, it's second degree AV block. In third degree AV block, of course, none of the P waves conduct, and you just simply have a regular QRS complex because you're dealing with an escape rhythm. All right, so if we say that this is second degree AV block, then there are 3 different kinds, not 2. Remember, there are 3. There's type 1, where the PR interval gets longer before the blocked beat. There's type 2, where the PR interval is fixed. And then there's high grade or advanced, which means 2 to 1, 3 to 1, 4 to 1, and so forth. But these are not classified as either type 1 or type 2. Well, let's see what the telemetry tech put down. Okay, it says heart rate down to 41 beats per minute with 2 to 1 second degree AV block. And then here it says occasional second degree AV block, 2 to 1 Mobitz 2 at times. 2 important concepts that you need to remember is that number 1, Tulow's law is never believe anything you read on an ECG strip unless you wrote it yourself. And the second thing that I've taught you is that 2 to 1 block is not Mobitz 2. It belongs in a separate category. I'm going to zoom in on these 2 groups here. Okay, so of course we said your P2P interval is regular. So this is not a PAC, this one here. And you have group beating, there's 3 to 2 conduction going on here. And the question is, does the PR change? And when you first glance at it, you don't notice much change, but here's where you have to take out a pair of calipers. That's when it's really important. But I'll take my caliper and resize it for the PR interval. Okay, so I've taken the first point at the very beginning of the upward deflection, the first upward deflection of the P wave, and the second point on the very onset of the QRS complex. We can move this over and measure the PR interval. Starts out at 260 milliseconds. Now let's take our point and put it at the very onset of the next P wave, and look at that. The PR interval did get longer by a good 30 or 40 milliseconds. But it is subtle, and you have to sometimes use calipers to measure it. But if you just look at the distance from the bump in the P wave to the QRS, it just looks longer. And the same thing here. This is shorter, and this is longer. So we're looking at type 1 second degree AV block, otherwise known as winky back. Now, to confirm that winky back periodicity, sometimes it's useful to take your calipers again, and we'll resize them back to the R to R interval. And when we look at the pause, we set our calipers here, make a little mark, but I think you can visually see that the pause is less than 2 times the previous R to R interval. So I move it over, and sure enough, that's the case. And the reason the pause is shorter than the 2 times the previous R to R interval is because the shortening of this PR interval brings this QRS complex to the left, thereby shortening the pause and lengthening the interval between beats because this PR is getting longer. So this QRS shifts to the right, and this QRS shifts relatively to the left, and that throws the intervals off enough that you can measure it. And that's sometimes the best way to look for subtle changes in the PR interval, assuming that the PP is regular. Going back to our original strip, I agree that there are periods of 2 to 1 conduction. This blocks, this conducts, this blocks, this conducts, this blocks. And so you have periods of high-grade AV block. And you obviously have periods of type 1. But type 2 AV block is not present. And what's the bottom line? Well, you have to ask yourself, where is the block? Anatomically, at what level is the atrial signal failing to get through? And it would be in the AV node, known as intranodal block, because the AV node has that property of decremental conduction where you get slowing of the signal with prolongation of AV conduction time prior to the blocked beat. And when you see this kind of winky back periodicity, 99% of the time block is in the AV node. But here the AV node is really not behaving and every other beat blocks. But that doesn't make it Mobitz 2. It makes it high grade, and perhaps the AV node is sicker than we think, but this is also in the middle of the night, and maybe the patient's on medications. You have to interpret the whole thing in the face of the clinical situation. But as far as the electrocardiographic diagnosis, it's type 1, progressing to high grade AV block, but understanding the physiology, you have to say that the block is most likely AV nodal, and therefore stopping medications might actually help, as opposed to infranodal block down in the bundle branches and the Purkinje system, where you'll usually have a wider QRS complex, and type 2 AV block, And those patients usually don't get better when you stop their beta blockers or calcium channel blockers. Well, that's the end of this quick review. Hopefully next time I'll have my voice back. In the meantime, this is Dr. Nick for the Ecg Academy. Thanks for watching.
Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is fairly basic. It's very common to be faced with a wide complex tachycardia, and I want to remind you all what the basic rules are in trying to decide whether this is ventricular or supraventricular with aberrant conduction. After all, these Chalk Talks are for people who know the basics, but they want practice in reading more difficult tracings. And this is a great forum for me to remind you of the physiology that goes into interpreting these strips. So we can see there are 3 simultaneous leads here, and there's a normal sinus rhythm that's going on here with a rate of about 70 beats per minute. It slows down a little bit here to around 60, maybe 58. So it's slowing down a tad, but you have very nice discrete P waves, a QRS complex, and a T wave, very consistent. And then you have this last sinus beat followed by this wide complex tachycardia. The tachycardia is pretty regular, not perfectly, but pretty regular, and you can see that 2 beats are just over 100 beats per minute, so 1 beat would be about 200, maybe 205 beats per minute, and V1 has a right bundle branch block morphology. Well, the key is to figure out how does it start. Does it appear to start in the atrium or does it start in the ventricles? And that's where looking for a P wave in front of this arrhythmia is key. So where do we look for P waves? Most often, the P wave for this beat would be superimposed on the T wave. So we have to make a very careful comparison of this T wave with the previous T wave in all 3 leads, looking for either a bump or a bite taken out of it, because remember, P waves are fairly sharp deflections with relatively rapid changes in voltage. The slope of this signal is quite high, so you have high frequency components in a P wave, whereas T waves and ST segments change voltage very slowly, and the slope of that signal is much lower. So when you're looking for a P wave on top of a T wave, you're going to look for a sharp deflection either up, or you're going to look for a little bite taken out of it, or it's going to look like a double bump. And that's what we're looking for here, except for one thing. I don't see any. This T wave looks exactly the same as the previous T wave. So as far as we can tell, this wide complex tachycardia did not appear to start with a P wave. Okay, well, that's a clue. It's not absolute. But what is absolute? What is the cornerstone of diagnosing ventricular tachycardia? What's the most important thing that we look for? Is AV dissociation. So where are we going to look for AV dissociation? Do we look for it on the QRS complex? No, because P waves are very sharp and we'll never see one on top of the QRS complex. Where we will see the P waves is on the ST segments and on the T waves. So we have to very, very carefully scan across this arrhythmia and compare the T waves and the ST segments with each other. Now what I notice, and let me erase this, is that the T wave seems to be getting a little deeper right here, and then all of a sudden it's back up again. And then it sort of gets a little bit deeper, and then up again, and now I see something very important right here. That ST segment has a bump in it. And if we look at the other leads, you can see it's very clear. That is a dissociated P wave. And I think if you look back here, this one is as well. Now, if we want to get into some advanced topics, what about the morphology of the QRS complex? We said that V1 looks like a right bundle branch block pattern. But notice that the R is taller than the R prime. If we think of a right bundle branch block pattern that looks like rabbit ears, think of the word ear. EAR? Well, the general guideline is if the first signal or the R wave is taller, then it's more likely ectopic. And if the second bump or the R prime is taller, then it's more likely aberrant. In other words, in V1, if you have a right bundle branch morphology, ventricular tachycardia is going to look more like that, whereas a right bundle branch block aberrancy is going to look more like that. Now, that's not 100%, but that data was published decades ago, and we can still use it to help decide where this arrhythmia is coming from. So I would feel quite comfortable calling this monomorphic ventricular tachycardia and not supraventricular tachycardia with aberrant conduction. Well, that's it for this week's Chalk Talk. I hope I did my job in reminding you what you should be looking at when trying to diagnose a wide complex tachycardia. Well, for the Ecg Academy, this is Dr. Nick. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is somewhat similar to last week's. since it's a wide QRS tachycardia, and we'll approach it the same way, but let's see if we come up with a different answer. This is a single lead rhythm strip that was recorded from an event monitor. We can see that the QRS is narrow and somewhat irregular, starting out at about 100 to 110 beats per minute. Then there's a little bit of a pause, and you can see a very clear P wave with a normal PR interval at a rate of 75 beats per minute. And the next P wave is a little bit faster, perhaps 80 or 85. And then what you have are two somewhat narrow beats and then this wide complex tachycardia. Let's take a pair of calipers and measure the rate of the tachycardia. And we can see that the tachycardia is actually quite regular. And if we take our calipers and bring it to the timing grid on the ECG, we can see that it measures 340 milliseconds. Now you can figure out the rate by taking 6 and dividing that by the cycle length and just shifting the decimal point over, you get 176 beats per minute. So we'll round it off and say 175. And it's quite regular and goes on for actually several minutes. So how do we figure out if this is more likely ventricular or supraventricular with aberrant conduction? Well, the key is always going to be in how it starts. The onset of the tachycardia gives us some major clues to figure out where this is coming from. So if we take a closer look at these initial complexes, I mentioned that there are two somewhat narrow QRS complexes, but at a significantly slower rate. This first one is coupled with the previous QRS at about 140 to 145 beats per minute. The next one is even slower at about 135. And then this one comes in at 340 milliseconds, which is at 175 beats per minute, just like the rest. So from a physiologic standpoint, you want to ask yourself, where do these QRS complexes come from? Well, we know that this one came from the previous P wave. But where did this one come from? Do you think this is ventricular in origin, or is it atrial? Well, first of all, it's not terribly wide, and it certainly doesn't look like these guys. It looks somewhat in between the normal beat and the wide beats. So the first thing you should wonder, is it a fusion beat? Well, a fusion beat occurs when a PVC lands in front of a normal sinus P wave, and the QRS complex looks distorted because this QRS was made up partly of the normal conduction system, the Purkinje fibers, and partly from this ectopic beat. But generally, we expect to see the P wave occur on time and the PR interval to be somewhat short. Did this QRS occur on time? No, it came early. So where did it come from? Well, if we examine the T waves, we get our second clue, and that is the fact that this T wave is a lot taller than all the previous T waves. So when you have a very tall spiky T wave in a QRS that looks very similar, most likely there is a P wave superimposed on that T wave. So what makes sense is that this is a premature atrial contraction, a PAC, that conducts to this QRS complex. And since this QRS looks the same, it also makes sense that there is a P wave somewhere buried in this T wave. Maybe it's this little crook here in the T wave that conducts to this QRS. But then you have to ask yourself, well, why is this QRS look a little bit different? It happens to be significantly deeper than all the previous QRS complexes. The likely explanation is that this PAC was so early that although the AV node was able to pass it with somewhat of a longer PR interval than normal, it conducted with a slight aberrancy, which deformed the QRS complex and made it appear to be significantly deeper than the normally conducted QRS complexes. And I would say the same is true about this QRS. It has a deeper S wave because of a slight aberrancy. But now what happens is this QRS is at an increased rate, a shorter coupling interval. And now it has this similar appearance of the previous QRS, but it's just a lot wider and even deeper. And now it has secondary T wave abnormalities as well. So I'm starting to believe that this is an atrial tachyarrhythmia that's conducting aberrantly. At this rate, it could be an atrial tachycardia conducting 1-to-1, or conceivably it's an atypical atrial flutter with an atrial rate of 350 that's conducting 2-to-1. Well, before you put your nickel down, I think it's important that you carefully examine all these QRS complexes down here to see if you see evidence of AV dissociation. AV dissociation is going to take the form of a bump on the T wave, or a notch, or something that really stands out as being a P wave that's out of place with the rest of it. And I've examined this strip fairly closely, and I cannot see definite AV dissociation. The rate is kind of fast, and sometimes it's hard to pick it up. So I'm not saying that it's definitely not VT. And that's kind of what electrophysiologic studies are all about. They're sometimes needed to diagnose the mechanism of wide complex tachycardia. But I would say that this is likely supraventricular with aberrancy because of the way it starts. It starts with a PAC, and there's some intermediate degrees of aberrant conduction at rates in the 130s and 140s. And then when the rate jumps up to 175, the QRS widens out and the tachycardia remains very stable without any clear evidence of AV dissociation. So am I 100% sure? No, not without an EP study. But the idea here is that if you analyze the way the tachycardia starts, you might get some important clues as to what the mechanism actually is. So on that note, I'll get started on my next Chalk Talk. And until then, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a 12-lead challenge. That's right, there are many things wrong with this 12 lead, but we'll try to pick it apart and get you guys used to looking for subtle abnormalities. That's the key to being an ECG expert, is to look for little things once you've sort of analyzed the big picture. Remember, that's the first thing to do, is look at the forest. And what we see here is a regular rhythm, and we can figure out the rate pretty easily. If we find a QRS that lands on a heavy line, we can count off 300, 150, 100, 75, 60. It's a little less than 60, and we can see that it marches to the right of that heavy line. I would say it's like 59 or 58 even. So we say 58 beats per minute. Let's figure out what the atrium is doing. So look in front of each QRS, and we can see a P wave. It's upright in 2, and it's also upright in 1 and AVF. And the PR interval looks to be fairly normal, less than 200, probably 180 milliseconds. And so most people would refer to this as sinus bradycardia, 58 beats per minute. Well, let's look at the axis now. Which lead is most isoelectric? It looks like lead 2. So the axis, remember, lead 1 heads straight across, lead 2, since we read from top down and from left to right in English, that becomes lead 2. Kind of remind you which one comes next. And since we're perpendicular to lead 2, and we're going away from the feet, see AVF is negative, so that means our axis is minus 30. Well, that means there's some left axis deviation. We'll come back to that and figure out why there's left axis deviation. Let's turn our attention to the precordial leads so they don't feel left out. So what you see is a kind of a QS pattern, but there's a little R wave, and the R wave does not grow very much. So there is poor R wave progression, but by the time you get to V6, there's a nice big R wave and just a very small S. The QRS duration, meanwhile, is a little bit widened, by the way. I don't know if you saw it, but it's maybe about 110 milliseconds. So some people would call this a non-specific IVCD, but there may be more to it. So let's keep looking. Why would there be poor R wave progression? It's possible that the patient has had an old anterior MI, and that's one of the things you have to consider. But the other thing to consider is look at the voltage in V2. It's huge. And if you add up the S wave in V2 plus the R wave in V6, it looks like you do have LVH. Plus, I think AVL just makes it about 11 small boxes. So that might explain the left axis deviation to say that this patient has LVH. There are other criteria to look at. One of them is looking at the R wave in lead 1 plus the S wave in lead 3, and if it reaches 25, and you just about have it. This is about 12, this is about 13. So I'd say that LVH is present. You have voltage criteria for LVH. And sometimes LVH will cause this poor R wave progression, so it's conceivable that LVH is the cause. Now let's get down to the nitty-gritty of the QRS and the STs and the T waves, because at this point I start to look at anatomical regions and see if I see any patterns. Anatomical region, we look at the lateral leads 1 AVL, V5, V6, and what I see is some ST segment depression. It's about a millimeter when you measure it 80 milliseconds past the J point, maybe even exceeding a millimeter, but it's got an interesting pattern to it. It kind of goes down gradually, and then the T wave has a very rapid resolution. And in some ways, it sort of resembles a digeffect. Now, I always warn people to try to avoid the diagnosis of digeffect, because if the patient is not on digoxin, well, then you kind of have to eat your words. But there's another possibility. And that keep in mind that 1 and AVL, they're both upright because you have a left axis deviation and it's pointing up towards 1 and AVL. And the STs are deviating downward. But look at V1 and V2, and even V3 to some degree. You have STs that are deviating upwards. See that? You have 1 to 2 millimeter ST elevation in these leads and a little bit of depression in V6, about a half a millimeter. And even in lead 3, if you take this as the baseline, you have some ST segment elevation in lead 3 and perhaps some in AVF. So what is that telling you? That most likely what you have are secondary repolarization abnormalities from the LVH. What do we call that? It's a strain pattern. Okay, so we have left axis deviation, voltage criteria for LVH with repolarization abnormalities, and the QRS is widened, which also goes along with LVH. What else do we see? Well, here's something interesting, and I don't know, this is one of those Steve Jobs quotable moments. There's one more thing. And that is, when you look at V1 and you see that P wave right in front of V1 there, did anybody measure the PR interval here? Because after all, when you look at the forest first, but then you should look at all the trees. And I just happened to notice that this PR interval appears to be very short. Now remember, the rhythm strip is a continuous recording of the same lead 2. And what's happening over here? I don't really see much of a P wave, but there certainly was a big P wave here. So what's happening? Well, let's see how that P wave evolves. It kind of gets to be a little notched here, and then it begins to flatten out, and the P wave and the PR interval seems to be shortening. And then the P wave kind of flattens out. So I see a very flat P wave and a short PR segment. And then what happens is PR becomes more physiologic toward the end of the recording. But here it's flattening out again. So what is this rhythm disturbance? The fact that the P wave is changing in morphology and flattening out indicates that the P wave is not coming from one area in the right atrium, that the site of origin of the P wave is drifting. It's moving around. And here, remember, lead 2 is pointing down and to the right, and it's becoming flatter in lead 2. So what's happening is the P wave is starting in the high right atrium, but it's starting to drift downward, probably down the crista terminalis on the lateral wall of the right atrium. And we can see that in sinus arrhythmia, but some people would actually go as far as to call this wandering atrial pacemaker, because the P wave is clearly moving to a different location. Now, it kind of depends. If I saw an inverted P wave, then I would definitely call it wandering atrial pacemaker, but you can see flattening and you can see changes in the P wave axis just from sinus arrhythmia. But how do you explain the short PR? Now that's the important part, because the time interval it takes to get from the high right atrium to the low right atrium is only maybe about 10 to 20 milliseconds. So you really can't have a significant shortening of the PR interval. It might go from 180 to 160 or maybe 140, but it's not going to get this short. This looks like maybe 120. So what's happening here? Well, it might help to take a pair of calipers to see if the P to P interval is perfectly regular and if the R to R interval is as well. And we'll resize them to the initial R to R interval. Okay, that's pretty close. Then let's see what happens as we march on through. This R to R is a tiny bit shorter, this a little less so, and now it's getting a little shorter. Ventricular rate changed ever so slightly, and this one came quite a bit earlier, and so did this one. So I think this P wave clearly captured the ventricle and went down the AV node, but this is the one I'm wondering about. And I really think that these couple of beats in here, because the PR is so short, that you might actually be looking at junctional escape beats at a rate here of about 58 beats per minute, competing with this sinus bradycardia in a pattern that we might consider as isoarrhythmic AV dissociation, because it's clear to me that this PR is too short to have conducted. So where did the QRS come from? It came from the AV node, but it's firing at the same rate as the sinus rhythm. And so the PR interval appears to be fixed, but in fact the two rates are similar, and that the P is not conducting because the PR is too short for it to have conducted. Only here what happens is this P wave comes in a little bit early, conducts down the AV node, and this QRS is advanced in time. Now, if we continue to map out the P to P interval, we see that this P wave comes in early because the sinus node decided to fire. It's now coming from the high right atrium at a faster rate and managed to get down the AV node and cause this QRS complex to occur a little bit sooner. Now, those are very subtle details that you're not going to pick up unless you dissect these cardiograms the way I do, looking for very subtle changes in P-wave morphology and PR interval, and keeping in mind the physiology that goes on when the sinus node slows down and you remove the overdrive suppression from the AV node. Now, one last thought is that normally the AV junction would fire at more like 40 or 45 beats per minute. So what's it doing firing at 58? Well, that would lead you to call this an accelerated junctional rhythm. And what kinds of things cause the AV junction to accelerate? Well, one of them happens to be digoxin. So I'd be real curious to see if this person is on digoxin, because that might explain the unstable nature of this atrial rhythm and the fact that the AV junction is starting to compete with the sinus bradycardia. And of course, that might have something to do with some of these ST segment abnormalities. These kinds of questions face cardiologists every day when we sit on the ECG panel and have hundreds of ECGs to interpret every day. And sometimes you don't have a definitive answer because the findings are subtle and they may be nonspecific. But what I'm trying to do here is get you used to reading more difficult tracings and train your eyes to pick up these little subtle findings, and then get you to think about the physiology and consider what are the possibilities, what could this be? And as long as you know what it could be, it's less likely that you're going to miss something important. Well, until next week, this is Dr. Nick with the ECG Academy. Thanks for watching. Hey, this is Dr. Nick with the ECG Academy, and this week's Chalk Talk is a Holter monitor that was obtained from a fellow who likes to check his pulse, and he notices that every now and then his heart rate gets very slow. Now, this was recorded at about 4:45 in the morning, but you can see that it is incredibly slow. In fact, if you take these 1 second marks, and you can see the QRS is timed about the same, and they're about 2 seconds apart. So this gives you a heart rate of 30. The computer read it as 32. So this is an extreme case of bradycardia. And the question is, why? No, it's not enough to just say, okay, it's bradycardic. You have to think of the physiology and what's happening here. And so let's take a closer look at these QRS complexes. Well, each one seems to be preceded by a P wave, and the PR interval is just a little bit less than 200, probably about 180 milliseconds. And that PR interval seems to be constant throughout the recording. It's kind of easy to see that PR segment stays the same, and that's a good clue that the PR is not really changing that much. So the PR segment, which is about, 60 or 80 milliseconds, doesn't change. Okay, so the question is, well, what's making it very slow? Well, when you have a bradycardia, the first thing you have to ask yourself is it sinus bradycardia or is it some kind of AV block? And so here's where it's important that you hunt for P waves and see if you have any that are blocked. Now, most people will assume that this is just sinus bradycardia. In particular, when you look in between the QRS complexes, there's no P wave here. Of course, if there was a P right in between these complexes, you can say that 2-to-1 AV block was present. And that would give you a regular bradycardia at 32 beats per minute, assuming that the sinus rate was 64. So we don't see that. Can we say it's SA exit block? Well, you can't really say that unless you have more of a recording. If you saw a sudden change in heart rate, let's say that earlier in this recording, like seconds ago, you had a rate of 64, and then suddenly the heart rate drops to 32. The idea being that the sinus node is firing, and it's firing at a regular rate, but every other sinus impulse fails to escape, and you don't get a P wave. So that would be known as type 2 SA exit block. Well, you can't really diagnose that in this recording because you didn't see what came before, but it is something to consider when you're looking at this extreme bradycardia. By the way, I'll have a detailed discussion of SA exit block in the advanced course this summer. But anyway, one last thing you have to think about is high-grade AV block, in other words, 3-to-1 conduction. So if we take this P to P interval and divide it by thirds, we would have seen P waves here, and just every third P wave was conducting, but we don't see that either. So a lot of you would just opt to call this severe sinus bradycardia. But you have to look for P waves a little bit more carefully than that. And you have to remember something about P waves is they tend to be more spiky than T waves because they have higher frequency electrical components than T waves. In other words, T waves, the voltage changes very slowly, and the slope of the T wave is rather low with frequencies somewhere like that look like this, whereas P waves have a much more rapid voltage change. They have higher frequency components, which make them look spikier. So when you're looking for P waves, you always have to look at the T waves to see if you have any. Well, I guess I just gave it away. If you look at this ST segment and this T wave and compare it to this ST segment and T wave, you'd say they'd look different. Now this one back here looks a lot like the second one. But what makes this one different is that there's a premature atrial beat right there, that P wave landing on top of the ST segment before the peak of the T wave. You can't really see it here because it looks like it's part of the beginning of the T wave. You can't see it much here either. But when you look at this beat, you see that there is a P wave here. Indeed, that looks very convincingly P wave-ish because it's so sharp on top of this otherwise very smooth T wave. But if you time this out with up here, you see that the tail end of the T wave corresponds with the P wave in this lead. And so you have another PAC here. So what you're seeing are PACs that are so early. Well, if you count the rate off from this P wave, you get 300, 150, maybe about 120 beats per minute, which isn't terribly fast. But remember, it's 4 o'clock in the morning, the guy's sound asleep, his vagal tone is likely very high, and so his AV node just failed to conduct this beat as well as this one, as well as this one. And so this is an arrhythmia that I've shown you before. These P waves are non-conducted. Remember, try not to use the word blocked, although some people do. But block implies there's something wrong with the AV node, but they're non-conducted. And every other beat is premature, so it's atrial bigeminy. So this is a common cause of slow pulse rates. It doesn't necessarily mean that the sinus node is affected, although if you measure the rate between this P wave and the sinus nodal firing here, it is pretty long. We'll just count off. This is 1 second, 12, 14, about 1500 milliseconds, which works out to be just about 40 beats per minute. But 40 beats per minute doesn't bother me so much in the middle of the night because it's a perfectly adequate heart rate for someone who's sleeping. And keep in mind that these PACs may in fact be suppressing the sinus node because of overdrive suppression, another concept that we'll cover in the advanced course, but that might be what's keeping the sinus rate so slow. Anyway, these kinds of bigeminal rhythms are a common cause of bradycardia. In fact, PVCs in a bigeminal pattern can make the patient think his heart rate is much slower than it really is because the ventricular premature beat doesn't push as much blood, and there's what we call a pulse deficit, meaning the actual heart rate is 80, but the patient only feels a pulse of 40 beats per minute because every other beat doesn't really provide enough of a pressure wave to be felt at the wrist. So anyway, the message to take home is always look for P waves to try to figure out why something is so bradycardic, because there are many reasons other than just old sick sinus syndrome that can lead to bradycardia, and something like this would not necessarily require any kind of intervention like a pacemaker or something like that. Anyway, that's it for this week's Chalk Talk. I want to thank you guys for subscribing to the Ecg Academy. And until next week, this is Dr. Nick. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk was inspired by a question that I received from an emergency room physician, and he had a question about compensatory pauses. So let's first take a look at this 12-lead ECG. Remember to look at the forest first, and if you see down the rhythm strip, you see some normal-looking beats, and then a wide, funky beat, and a normal beat, and a wide, funky beat, and then a couple of normal ones, and then it's wide, normal, wide, and so towards the end, it looks like a bigeminal rhythm. So the first thing you should do is start by ignoring the wide beats, because when you do your 12-lead interpretation, you really have to base it on the normally conducted beats. So the normally conducted beats seem to be sinus beats because the P wave is up in AVF, PR interval is normal, the QRS duration looks fine, the axis is about 45 degrees. Remember, we calculate that by taking the perpendicular of the most isoelectric leads. Here it's AVL and lead 3 are most isoelectric. So AVL, which is 30 degrees above the horizontal, would give you plus 60, and lead 3, which is 60 degrees above the horizontal, would give you plus 30. And so the axis is right in between at plus 45. The QT looks fine. Now, if we turn our attention to the precordial leads, remember, ignore the wide beats for the time being. The R wave progression looks pretty normal. So I would say that the underlying QRS morphology is fine. So then what are these wide-looking beats? In V1, there is an RS, R prime pattern, which is consistent with the right bundle branch block morphology. But the real question is, are they ventricular or are they atrial? And the key is to look in front of the beats to see if you see evidence of a P wave. You have to look at several leads and you have to pay attention to the T wave just prior to the wide beat. But the reason I picked this really terrific cardiogram is because of this. You have two normal beats in a row, and that allows you to compare the T wave of the normal beat that does not have a premature beat in front of it and the normal beat that does have a premature beat in front of it. And I think you can see that right there is in fact a P wave, and you can see this P wave in almost all the leads. And so we're dealing with premature atrial contractions with aberrancy. This is a rate-related or a functional right bundle branch block that's occurring because part of the conduction system has not recovered from the previous beat, and so the premature beats go down the left bundle like so, but then have to get to the right side through slow intramyocardial pathways, and that results in the R prime in V1 and the S wave in the lateral leads here, V5, V6, and you can even see a wide S wave in lead 1 and AVL. So it's a classic functional right bundle branch block. But the question of compensatory pauses came up. In my course, I use the word compensatory pause rather generically. In the broadest sense of the term, it simply refers to a pause that occurs after a premature beat. So here you have a short interval, and then you have a pause that kind of sort of compensates for the fact that you have a premature beat. And it takes a little time for the next normal beat to kick in. But there is a distinction between a fully compensatory pause and a non-compensatory pause or a partially compensatory pause. And it has to do with whether the sinus node gets reset by the premature beat. We will actually be covering this in the advanced course, but think of it this way. This premature atrial beat, which is coming from somewhere other than the sinus node, is able to travel to the sinus node and reset the sinus node. So the next sinus beat occurs sooner than you would expect. Let's take an example here. The sinus node fired here, and then it fired here, and the next one should have occurred here, but what happened was this PAC didn't have far to travel to reset the sinus node, and once the sinus node gets reset, the next beat will generally come sooner than you'd expect. The best way to judge that is with a pair of calipers. So these calipers is set for the P to P interval. The next one would have occurred right here, and the next P wave, but instead of occurring out here where the calipers fall, instead the P wave came early. So this is known as a non-compensatory pause because the P wave does not occur on time. Now let's take a look at a ventricular premature beat and see what happens to the P wave timing. Now the problem is that these P waves are a little bit irregular, but this is about where the P to P interval is at. And theoretically, when this PVC occurs, the sinus node doesn't realize it. And so the sinus node fires right on time, right here someplace. As a result, the next P wave occurs on time, and this is known as fully compensatory. Now, it's fine if you understand the distinction between non-compensatory or partially compensatory and fully compensatory, but don't use it as a litmus test to decide if a premature beat is atrial or ventricular in origin. First of all, sinus arrhythmia may throw you off, and the second reason is this. Here's the same patient, although it's a little later in the day and the sinus rate is a little bit slower. But watch what happens with this PVC. The sinus P wave should have landed here, but instead what you have behind it is a retrograde P wave. And so if a PVC is early enough, that beat can retrogradely penetrate the AV node. If that retrograde P wave is early enough, it can reset the sinus node and cause the next P wave to occur sooner than it normally would have, thus giving you a non-compensatory pause even though it's a PVC. One last exception to the rule that I'm going to discuss is the fact that in people who have sinus node dysfunction, a premature atrial beat like this one can result in overdrive suppression of the sinus node, thus causing an exaggerated post-PAC pause, stretching the time interval to the next P wave to the point where it is fully compensatory and would make you incorrectly assume that this was a ventricular premature beat. So understand the difference in the different types of compensatory pauses, but only use it as part of the equation to decide whether beats are atrial or ventricular. It's much more reliable to look for that P wave, and you may only see it in one lead, and then understand the physiology so that you can analyze what you're seeing instead of relying on pattern recognition and hard and fast rules. Well, that's it for this week's Chalk Talk. This is Dr. Nick from the Ecg Academy. Thanks for watching. Hey, it's Dr. Nick with this week's Chalk Talk, and this one has a bit of a lesson in it, so let's get started. When you look at the rhythm strip, remember to look at the forest first and get a sense of whether you have a regular or an irregular rhythm. And I think it becomes pretty clear that it's irregular. You have a short and a long and a short and a long and another long, a couple of shorts, a long, short. And there's really kind of no pattern to it. And so we would consider this to be irregularly irregular. And when you kind of look for P waves, you don't really get a good sense that there's a great P wave in front of these beats. So we'll get back to that in a moment. Let's start looking at the QRS complexes. They are narrow. The QRS duration is only about 100 milliseconds. And when you look at the QT interval, this first QT interval seems a little bit long. The general rule is if you take half the R to R interval, that the T wave should not go across that point. Well, the exception to that rule is in atrial fibrillation, when you have irregularly irregular intervals, and the QT is constantly changing based on the previous R to R. So here you had a very long R to R interval prior, so this QT will tend to be longer. Whereas now with this short R to R, this QT will be considerably shorter. And if you take this as the QT interval, it looks perfectly fine, certainly less than half the R to R interval. Well, is that a consistent finding? Well, I think it is. Look, here's a short R to R interval, and this QT looks really quite normal. In fact, if you take halfway through, it looks fine. And this one, in fact, looks really quite short because you had two short ones in a row. This QT interval is only about 360 milliseconds. Very normal. So you have to keep that in mind. So here's a very long R to R interval, and now this QT looks to be a little bit longer than the previous one, but still not bad. So I think the QT is fine, and it just appears to be long in some beats like this one, where you have basically a long interval preceding a short one. Okay, so much for the QT. The QRS axis looks fairly normal. It's way up in 1 and it's positive in AVF, so it's in a normal quadrant. The most isoelectric is AVF, but it's a little bit positive, which makes the axis just a little bit more positive than 0, probably plus 10 or plus 15 degrees. When we look at the morphology of the QRS complex, it looks fairly normal, except there's a little bit of ST sagging. In lead 1, the T wave is flat in AVL. Those are the lateral leads. And out here in V5 and V6, there's a little bit of ST depression. If you look at it, two small boxes are 80 milliseconds after the J point. It's less than a millimeter depressed, but there is a downsloping depression and an inverted T wave in those two leads as well. The rest of it looks okay. The voltage is fine. The R wave progression is good. So how do we sum this up? I would say that you have this irregularly irregular rhythm. The QT is falsely increased. I think it's normal, and just these STs are a little funny, but they're kind of non-specific, barely a millimeter. But some ECG readers would say that this is possibly related to ischemia. Before I go any further, I just want to show you the official reading. This is the final interpretation, read by the attending cardiologist. As you can see, this is an 88-year-old gentleman. The computer read a QT interval of 394 and a corrected QT of 462. Remember, in males, 420 is the upper limited normal, but I think that might be perhaps overestimating the true QTC. I think the computer was thrown off by the fact that it's irregularly irregular. But as you can see, this is confirmed by the attending cardiologist, and he read it as atrial fibrillation. He read it as ST wave abnormality, consider lateral ischemia or digitalis effect. And then he called a prolonged QT interval, which I don't frankly agree with. Well, it turns out the patient is not on digoxin, so for you guys who read EKGs, you might want to avoid this diagnosis unless you're fairly certain that the patient is on dig. At any rate, so far, how many people disagree with this? Well, like Steve Jobs used to say, there's just one more thing. You see, what bothers me is that some of these intervals look fairly consistent. If you look at this interval, it's equal to this interval, and it's equal to this interval. and it's kind of equal to this interval. And if you look very, very carefully in front of the QRS complex, you'll actually see a deformity in the baseline right there that is consistent in front of each of these beats. So I immediately looked at this and said, this is not atrial fibrillation. And the question is whether maybe there's some kind of atrial tachycardia or flutter that might be marching through. But that's where these irregular beats can help you. Because if you take a look at this STT segment and you compare it with this one, it seems obvious to me, at least, that there's an inverted P wave superimposed on the ST segment. So I would call this a PAC, and that's why this QRS came early. And I would say that the tail end of this T wave is a lot sharper than the tail end of this T wave, so that's another PAC, which gave rise to this QRS. And so I think what you can find are consistent P waves in front of every QRS, and what you're dealing with is a sinus rhythm with the sinus rate around 65 or 70 beats per minute. But there are just frequent PACs that give the impression of an irregular rhythm. Now, those P waves are so small that in some leads, you just don't see them. But if you look at another lead, you can see a broad notched P wave right there, and you can see a normal-looking negative P wave right here in V1. Now, the problem is that automatic ECG reading stations will miss something as subtle as this. But considering that the cardiologist might have 150 ECGs to read, sometimes they'll take the computer's word for it without looking carefully enough to confirm the arrhythmia. But you guys are supposed to be ECG experts, and so I don't want you to make this mistake of assuming that the official reading is the correct one. Always look for yourself. And if you disagree, have the knowledge and physiology and expertise to be able to defend your position. And that's my clinical pearl for this week. This is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a bit of a challenge because it doesn't happen very often. But I've seen it many times, and I actually took this trip around to a bunch of medical and surgical residents, and nobody got it right. So I thought, this would make a great Chalk Talk. Anyway, this is a patient in the ICU, and they've been in atrial fibrillation for several days. The patient is on intravenous cardizem, and they're getting some beta blockers. And here it is right about midnight. And the patient suddenly has this profound bradycardia, but it only lasts for a few seconds. Okay, now, let me explain how this strip is put together. These are 3-second marks, but this gray hashed area is exactly the same as the first part of this strip. It's just kind of showing you what came next. And you can see 2 profound pauses here. We can count up milliseconds. It measures just about 3.9 seconds here, and this pause is about 1.6 seconds. And then as you can see, there's another pause here of 1.4 seconds, and then suddenly the rate picks up again. And so what would be the reason for this sudden bradycardia? Now remember, when you're thinking of bradycardia, you have to think 2 different levels and 2 different mechanisms. You've got a sinus node problem, and you've got an AV node problem. And of course, you have intrinsic and you have extrinsic. Extrinsic would be something like a metabolic problem or hypoxemia or drugs or autonomic influences like a vasovagal attack. And you have to put it all together. So let's take a look. On the left-hand side of the strip, if we look at the QRS complexes, the average here is just about maybe a little bit faster than 100 beats per minute, maybe 105. Do we see P waves? Well, there's a big bump here, and that could be a P, but when you look to see if it's consistent, it doesn't look like it. In fact, you have an inverted atrial signal there, and then you have an upright signal, but it's right on top of the QRS complex. Then you have a little jiggle here and more jiggles there, a little bump there, and all of the atrial vents look kind of different. So even though it's kind of regular, my first guess is that it's probably atrial fibrillation, all right? And then you have this pause here, actually 3 pauses, and then the rhythm picks up again and it becomes rapid, and again you have an average rate of maybe 100 beats per minute, but it's much more irregular here. And again, I think you can see a lot of baseline junk here that suggests that it indeed is atrial fibrillation. So you have atrial fibrillation, and then it suddenly becomes very slow, and then it goes right back again. And this change in heart rate gives food for thought. What actually happened physiologically? What was the heart doing? What's the atria doing? What are the ventricles doing? Well, the ventricles aren't doing much. What's the AV node doing? And this is the kind of approach you have to have. So when I showed it to the residents, they were guessing. Oh, Mobitz 2, AV block. Oh, sleep apnea syndrome. All sorts of things came out. Okay, but the key is that the patient is in atrial fibrillation, right? And what determines the heart rate during atrial fibrillation? It's the AV node. The AV node is the gateway to the ventricles. So the AV node determines how fast the heart goes. And so you've got this rate of 100 on this side of the pauses, and you have a rate of about 100 on this side of the pauses. And so when you suddenly see slowing, you have to think, well, could the AV nodes suddenly stop functioning, suddenly become completely blocked to the point where you have, some kind of escape beat here? There's certainly no P wave in front of it or in front of this one. And so is it likely that the AV node just stopped passing signals down to the ventricles? Well, if you had a very wide QRS complex and maybe had trifascicular conduction system disease, then I might buy that. But what you would expect, at least if that were the case, is that you would continue to see evidence of atrial fibrillation at the point where the AV node blocks. It's almost like you gave the patient adenosine and blocked the AV node, and then you saw, what the atrium was doing underneath. And you've done that in the emergency room, perhaps, and you'll see like flutter waves or fibrillatory waves. I don't see any of that. What is that? I see some electrical noise, but I don't really see any atrial activity. What happened, in fact, here is that somewhere right around here, the AFib stopped. That's right, it just terminated. And what do we say about overdrive suppression of the sinus node, right? When you have this rapid atrial signal, it suppresses the automaticity of the sinus node, then add to that a little bit of calcium blocker in the way of IV cardizem and a little beta blocker, and basically there's no sinus rhythm, not even a single sinus P wave. What you have here is a junctional escape, and in fact, these 3 beats are all junctional escape beats, but right at this moment somewhere, the AFib starts again, and then it picks right back up where it left off before. So the AV node is still conducting the same as it was before, except what you see here is a very, very long sinus pause, or most people over 3 seconds would call it sinus arrest, and this is an example of what we call a post-tachycardia pause, and it's seen in patients with tachybrady syndrome because their sinus node isn't working right. So they have this atrial tachyarrhythmia, namely atrial fibrillation, but when the AFib stops, the sinus node is nowhere to be found. What makes this unusual is that most of the time when AFib stops, it stops for a while, and eventually you get some sinus P waves that peak out, and you're back in a normal sinus rhythm, at least for a while. In this case, however, the AFib started up again without so much as a single sinus beat, and that's what makes this so unusual. But when you approach this with the physiologic knowledge, you can easily figure this out. And I do talk about post-tachycardia pauses in my section on sinus node dysfunction. So if you don't remember that stuff, go back and re-watch those videos. Repetition is the key to learning, but I designed these Chalk Talks to keep you thinking and show you stuff you've never seen before, because you're not going to see this in the textbooks, and that's why the Chalk Talks are one of the most valuable parts of Ecg Academy. And on that note, this is Dr. Nick. Until next week, thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is again back to basics. This was a rhythm strip I came across in the telemetry unit, and let's go over it together. Now remember, don't pay attention to the individual QRS complexes. Look at the forest. Scan across the whole entire thing and see if it's regular or if it's irregular, or if you see any patterns. These QRS complexes look somewhat fast, but they're also irregular, and there's no apparent pattern to it. So let's first try to figure out the heart rate. We can kind of guesstimate that maybe this is sort of an average R to R, but maybe this is, or whatever. Well, there are a couple different ways to be more accurate in your heart rate determination, and we went over these during the basic ECG course. What we'll do is we'll find a QRS complex that lands on a heavy line like this one here, and then we want to count off 6 seconds if we can. Let's see. Well, this is exactly 6 seconds right here. Then measure how many R to R intervals are there in those 6 seconds. Just about 14. Well, then that means in 60 seconds there must be about 140 R to R intervals. So the heart rate here is 140 beats per minute. The QRS looks rather wide, and if you find one that starts on a heavy line, you can see that it's about 120 and maybe even 140 milliseconds wide. But it clearly is irregularly irregular. Now, we want to try to look for P waves, and we can see that there's something that looks like it might be a P wave here, but it's certainly not consistent. And in fact, this looks like it's inverted, and the fact that it's irregularly irregular with no distinct P waves in front of each beat makes you suspect that there may be perhaps atrial fibrillation, with a rapid ventricular response, of course. And the wide QRS complex would allow you to make the diagnosis of an IVCD, interventricular conduction disturbance of some sort. If you had a 12 lead, you could determine whether this was a bundle branch block, and it kind of looks like it might be a left bundle branch block, but if not, then it's a nonspecific IVCD. All right, well, the only problem with this is that this is only a little tiny slice of life here. It's a snapshot. And I always say, how does it start? How does it end? Can we see if it changes over time? And that's where the biggest clues come in. What I'm going to show you now is the entire strip. Okay, now this is what I took off of the chart. And you can see that here is that rapid rhythm at 140 beats per minute. But if you look to the left of it, you can see that it was much slower in the beginning. These QRS complexes look very similar to the QRS complexes in the strip I showed you, except for one thing. These are a little shorter. These are a little bit deeper. And then what you see is at the end of this rapid rhythm, you have a bit of a pause here after it ends, and then the QRS complexes kind of get a little bit shorter again. What's the rhythm underlying it? I mean, what are the atria doing? And I think if you see during this pause, there is a disorganized electrical signal underlying there. And you can see the same thing in the beginning here. And it certainly looks like atrial fibrillation. So we were right. You have atrial fibrillation and some kind of IVCD. But you might ask, well, why are those QRSs deeper during the rapid part? And I would say, well, maybe the sudden increase in heart rate worsened that interventricular conduction delay and made the aberrancy more prominent. Except, as Steve Jobs would say, there's just one more thing. Remember from our last Chalk Talk, I made a point of saying that the AV node is the gatekeeper of the ventricles, and that determines the ventricular response to atrial fibrillation. So why would the AV node conduct so slowly on this side and over here, where you have heart rates in the 50s, and up here it was in the 70s? Why would the AV node suddenly speed up like this? Why would the ventricular response go from 70s to 140, literally doubling the heart rate for somewhere around 10 seconds, and then suddenly get slow again? Well, in reality, there's no good explanation, and so you have to question the physiology. It's highly unlikely that the AV node would suddenly switch gears and suddenly go 1,000,000 miles an hour, only to stop and then resume an even slower heart rate at the end. So what's happening? Well, the clue is that these QRS complexes, although they look similar to these complexes, are different. They are longer and they are wider. And so the answer is that this is non-sustained ventricular tachycardia. That's right, it's VTAC. Now, you'd say, wait a minute, but it's irregular. It looks like rapid atrial fibrillation. The truth is that ventricular tachycardia can be irregular, particularly if it's coming from an automatic focus inside the heart, where you have some area there that's firing rapidly and sending off QRS complexes from some ectopic focus. Those can certainly be irregular, and so don't let the irregularity throw you off. Consider where these QRSs originate from. Granted, there looks like there is an underlying bundle branch block, and let's assume that there is a left bundle branch block. That means that the left bundle is not conducting well, so the signal goes down the right side of the heart and then goes across the left side very slowly through intramyocardial pathways. Well, what happens if this ectopic focus is arising from somewhere near the apex? Well, it's going to very quickly conduct through the functioning right bundle branch system, but it will still travel slowly through the left ventricle, and so it will give you a QRS morphology that's similar, but obviously not identical, to the conducted beats. So keep that AV node physiology in mind, because that's what really is the clue to understanding how to diagnose these kinds of intermittent changes in heart rate. And as far as that theory that I told you with the rapid rate, the aberrant conduction got worse, and that's why the QRSs got longer and deeper, well, that might have made sense except for one thing. This first beat had a very long interval before it, so the bundle branches would have had plenty of time to kind of reach their steady state, and there's no reason why this first beat should be deep. In other words, that idea would have held water if the first beat was shorter and then the second faster beat was the first beat that got deeper. And if you need to, you should go back to my section on interventricular conduction disturbances and refractory periods and review that material so this all makes sense. And on that note, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk takes a bit of a clinical turn because I'm going to describe a case report that I came across, but it helps to give insights into the physiology of the cardiac conduction system. Anyway, this was a patient who is 68 years old, and he has a history of coronary disease, having had bypass surgery about 12 years ago. He had a couple of stents put in about 4 years ago, but he's been perfectly fine ever since. He was sitting at a restaurant getting ready to eat dinner when he suddenly lost consciousness for about 10 or 15 seconds. When he woke up, he barely remembered feeling anything beforehand, and there were no associated symptoms whatsoever. His friends convinced him to come to the emergency room, and this was his ECG. So as we look at the forest down here in the rhythm strip, we can see that it really looks quite regular. The rate is just about 50 beats per minute. Now, if we look for P waves in front of every beat, we can see that they are present and they appear to be consistent. The PR is at the upper limits of normal at about 200 milliseconds. The QRS complex looks fairly narrow, maybe about 100 milliseconds in duration, and the QT interval looks normal, except it does look like a bit of a double bump here. The QRS axis is normal, and looking for abnormal Q waves or ST segments, there don't appear to be any. But let's turn our attention to V1 now. We can see that the voltage in V1 and V2 is very generous, and it borders on LVH. And you also have ST segment elevation in V1 and V2, which would suggest a strain pattern. But let's carefully look at V1 for the rhythm, because you can see that there's a P and a QRS complex and a T wave. But remember I pointed out that double bump on the T wave here? Well, you guys need to be able to recognize that there's actually a second P wave here. And it is easy to recognize in the precordial leads. But this P wave looks exactly the same as this P wave. There's a little bit of left atrial abnormality there because you have a small upgoing and a very large downgoing signal in the P wave. But now that I pointed that out to you, you can see that this is 2-to-1 AV block. So the atrial rate is more like 100 beats per minute. Now, remember the classification for AV block. You have first degree, you have second degree, and then you have third degree. Well, this is obviously second degree AV block because some of the P waves appear to be conducting, and some of the P waves fail to conduct. So you have conduction, and then you have block, and then you have conduction, and then block. So in second degree, remember there's a type 1 where the PR gets longer, and that suggests block within the AV node, otherwise known as intranodal. And then you have type 2 where the PR is fixed, and generally the QRS is wide because the all or none characteristic of the infranodal tissues, such as the His bundle and the bundle branches, gives rise to sudden failure of conduction of the P wave without any PR prolongation. And then, of course, you have the last category, which is high grade, and that's what we have here. High grade being 2-to-1, 3-to-1, and so forth. So when you have 2-to-1 AV block, it's really difficult to tell whether the block is within the AV node or below the AV node. Now, one part of the clinical scenario that I failed to mention is that the patient has a history of atrial fibrillation in the past and was on a combination of amiodarone and metoprolol. So when he got admitted, these medications were held, and the next morning, this was his ECG. The heart rate is now 60 beats per minute, with a PR interval that's still about 200 milliseconds. But looking carefully at V1, we see that there is no second P wave any longer. So you now have 1-to-1 conduction. So the question is, what do you do with the guy? And the answer has to do with where you think the level of the block was. Remember that the reason that type 1 is associated with an increased PR interval is that the level of the block is in the AV node somewhere, where progressive prolongation of conduction time occurs before an impulse is blocked. That's a so-called winky back type of block. Whereas type 2 is more often encountered with trifascicular conduction system disease below the AV node because you have sudden failure due to the all or none properties of these sodium-dependent tissues. Well, where does amiodarone and metoprolol affect? Metoprolol is a beta blocker, and that affects AV nodal tissue, whereas amiodarone blocks virtually every ion channel and can affect AV node conduction as well as the bundle branches. But remember that amiodarone has a very long half-life, and so stopping it for 12 hours probably wouldn't make a big difference. The reason this whole discussion is important is because if the block is in the AV node and was due to medication effects, then now that the block is resolved, the patient should be fine. And even if it came back again, there would usually be some kind of junctional escape focus that would take over. On the other hand, if the block is down here someplace, then the metoprolol had nothing to do with it, and it represents severe conduction system disease, and if that comes back or gets worse, there may not be an adequate escape rhythm. So depending upon the level of the block will determine whether this AV conduction system problem was perhaps responsible for his syncopal episode, because if he had a long pause, like say 6 or 8 or 10 seconds, because of the absence of an escape rhythm, then that would easily explain a syncopal episode, whereas a heart rate of 50, as he presented with, is not going to result in syncope. It's also important that his left ventricular function was normal, so ventricular tachycardia is highly unlikely. So how do you determine the level of the block? Well, that's what His bundle studies are for. So I recommended that we do a His bundle study to settle the question of where is the level of the block. So let me show you what this is. These are the surface leads, 1AVF and V1, and I'm actually pacing the heart at about 120 beats per minute. So these are pacing spikes from a temporary wire inserted up through the femoral vein, and we're pacing in the atrium, so what you can see here is a very small and very wide P wave because the paper is going by so quickly, but here's another one, and here's a P, and here's a P, and here's a P. And you can see that the QRSs are going at half the rate. So this P is conducting to this QRS, but this P is blocked. And this P is conducting, and this P is blocked. So what we have done, essentially, is reproduce this 2-to-1 block. Now let's go down to the His bundle electrogram, and remember that normally in the His bundle electrogram, and we'll cover this in the advanced level, is that you'll have an atrial signal followed by a His spike, and then a ventricular signal if everything is working properly. And the His bundle spike represents local activation of the bundle of His. What we see here in the His catheter is the pacing spike, an atrial signal, a His deflection, and then a ventricular signal. But in the next beat, an atrial signal, a His bundle deflection, and then no V. So since we can clearly see a His bundle deflection, we can tell that the block is below the His bundle, and therefore it has the same prognostic implications as type 2 second-degree AV block, meaning that it is indeed infranodal, or blocking below the AV node. And so you can see here's AHV, and again AH, no V. So this infranodal level of the block places him at very high risk of recurrent syncope due to recurrent AV block, and therefore we recommended that the patient receive a permanent pacemaker. Well, I hope this whets your appetite for the advanced level. Well, until then, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a real-life patient who came to me with complaints of palpitations. She came to the emergency room because she felt her heart was beating out of her chest, and here's the ECG that we obtained in the emergency room. Let's take a look at the forest down here in the rhythm strip. As you glance along, you can see there are 4 wide-looking strange beats, and the rest of the EKG looks much more normal, with a P and a QRS and a T wave, and those normal beats seem to be progressing along. Now, there is a degree of sinus arrhythmia if you look really carefully. The P to P interval gets a little bit longer right here, and I think that's going to become a little bit more important later. Well, these wide beats do not have P waves in front of them, except when you look at this beat, there does appear to be a bump in front of the QRS complex that is not present on these other beats. And that bump looks a lot like this P wave, so that may be a P wave and the QRS complex fusing right here. In order to read this 12 lead, we need to be able to see leads 1, 2, and 3, and all we have are these funny looking beats. So we don't really know what the underlying QRS complex looks like in those three leads, but we do hear AVR, L, and F. Now look at that. AVL is isoelectric, so that tells us that our axis is perpendicular to AVL, which is 30 degrees above the horizontal, so at least we can get a QRS axis of plus 60. When we look at the precordial leads, there's not much R wave here in V1, V2, V3, but there's a huge R wave in V4, which very often goes along with just inappropriate lead positioning. So I don't think there's much going on with the R waves, and the ST segments and T waves all look fine. This, in fact, is a young woman about 55 years old with no history of any cardiac problems in the past at all. Now, my advanced students would look at this and say, well, the QRS is wide, so what are the possibilities? Well, it could be some kind of IVCD. Of course, pre-excitation is an interesting idea, like WPW. But to look at this very bizarre-looking QRS complex, you wonder if the patient has a pacemaker. Now, when you're reading EKGs, sometimes you don't have that information available. It doesn't necessarily say on the history, patient has pacemaker. So you kind of have to maybe look very carefully for pacemaker spikes. Well, looking very carefully, and I can tell you even blowing this up, there are no pacemaker spikes. But if you suspect it might be a pacemaker, let's say if it was a different patient, I'm telling you that this patient does not have a pacemaker. But in a different patient, you might want to take out a pair of calipers. Calipers are handy because pacemakers come in different varieties, and we're going to get into this in the advanced course. But you can have single chamber and you can have dual chamber pacemakers. And assuming a pacemaker is functioning properly, a dual chamber pacemaker would try to maintain AV synchrony at all times. And so you should see some kind of a P wave in front of these QRS complexes if you thought that these were paced QRS complexes from a dual chamber pacemaker. And so that kind of sort of rules that out unless you're going to make three assumptions and say the pacemaker's not working right. But at any rate, if this was a pacemaker, it's behaving as a single chamber pacemaker, kind of sort of ignoring this P wave. But the thing about single chamber pacemakers is they work like a clock. They are very, very stable in terms of heart rate. The R to R interval is rock steady from one beat to the next, and it will only change over a period of several beats if rate adaptive pacing is going on. But I'm getting ahead of myself. Maybe you guys are really looking forward to the advanced course. Take these calipers over to the QRS complexes that are wide, and I have it set here. And so we can tell the rate pretty easily if we put that one pin on a heavy line and count off 300, 150, 175, 60. So it's in between there. It's about 68, which is kind of a funny rate. It's not on the fives as most pacemakers would be programmed for, but let's see if it's regular. From this R to R interval, we move over and see that the next one is pretty close, is close as well. We can even go to the peak of the QRS complex and see if that maps out. And sure enough, it does. So this certainly behaves like a pacemaker, but yet there's no spike, and we know in this patient she doesn't have one. So where are these beats coming from? Well, they're wide and bizarre, and so they're not following the normal conduction system. They're acting like a pacemaker. Well, what is a pacemaker anyway? Well, a pacemaker is an electronic gadget, and a wire is inserted into the right ventricle generally, and that wire makes electrical contact with the endocardium so that when an electrical signal comes down that wire from the pacemaker, it initiates a heartbeat. But the reason that paced beats look so funny is because they're not following the normal conduction system. They're traveling through slower intramyocardial pathways, and that's why the QRS is so wide. Well, what you're looking at here is almost like a biological pacemaker. Somewhere in the patient's ventricle down here, there is a focus that is firing fast enough to take over the patient's heart rate. So that means there's this ventricular focus, what we often refer to as an idioventricular rhythm. But as you know from our discussion of escape rhythms and AV block, idioventricular rhythms usually occur at somewhere between 20 and 40 beats per minute. So what's this one doing going at 68 beats per minute? Because it's accelerated for some strange reason. So this arrhythmia, which does not occur very often, is known as accelerated idioventricular rhythm, or AIVR. And it's a disturbance of impulse generation down in the ventricles. Some crazy Purkinje fiber is firing at a rate that's faster than the sinus rate, and it's causing the heart to beat upside down, basically, with the ventricles contracting before the atria. And so the atria then contract against a closed AV valve, and the atrial contraction results in a very uncomfortable feeling for the patient. Now, the one last thing I want to point out is when you compare the rate of this ventricular focus to the sinus rate, you can see that the sinus rate was able to overtake this AIVR because it suddenly went faster. This P to P interval is shorter than the R to R interval, so this P wave managed to get down the AV node, resulting in a narrow QRS complex, and that kind of suppressed this ectopic focus. But if you notice that the P to P interval does get a little bit slower again. And so what may have triggered this AIVR to start is either marked sinus arrhythmia or a pause, or sometimes a PVC will do this and trigger AIVR to occur in patients who have this funny focus here. So we're talking about how does it get started, and unfortunately in this EKG we don't see how it got started, but we can see that it had been going on for some time. But recognizing AIVR is fairly simple. It's a wide complex rhythm with AV dissociation at a rate somewhere above 40 or 50 beats per minute. Rates above 100, however, are no longer considered AIVR, but more of a slow ventricular tachycardia. But that's kind of semantics. It's probably the same electrophysiologic mechanism of an ectopic focus that's firing faster than the sinus rate and kind of becomes the predominant pacemaker rhythm. One last thing I want to point out, if any of you hadn't noticed, is that this beat and this beat are actually both fusion beats. Notice that this QRS complex is not as tall as the three first QRSs, and this QRS complex is a little taller than the rest of them. And so they're both fusion beats in that this one is probably 90% from the pacemaker, but 10% from this P wave actually managing to get down a very rapid Purkinje system. And then this beat is probably 90% conducted, but yet it's a little taller because just a little tiny portion of the ventricle came from this ectopic focus here. And one of the rules is that fusion, just like AV dissociation and capture beats, are the hallmark of an ectopic ventricular focus. It tells you that the QRS came from two different places in the heart, one from the atria and one from the ventricles. Well, I hope that was helpful to you. I try to get the weird stuff that you don't see every day, just to get you used to analyzing these ECGs based on physiology. And on that note, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week we have another edition of In the Trenches. This is what I call a chalk talk that's kind of like a 12-lead challenge on steroids. Now on your computer's screen, it's an ECG reader's worst nightmare. Okay, anyway, let's get started. We'll look at the rhythm strip down here, and you can see that it's irregular. And what you're trying to do is get a sense of it's irregularly irregular or whether there's some kind of a pattern to it. And you have to be very careful in looking at this, but it doesn't take long before a pattern should jump out at you. It's a pattern of group beating. It's a pattern of bigeminy. It's a pattern of 2 and then a pause and 2 and then a pause. And you can see 2 and 2 and 2. And there's this bigeminal pattern all the way through. So, what kinds of things cause bigeminy? Well, you should have that list in your head. We've gone over this before in previous chalk talks. Let's get a sense of whether there are any P waves that we can see. Well, that's the problem here, is that in lead 2, you have a lot of artifact. There's a lot of noise, a lot of jiggly stuff. But it almost makes you want to think that there could be atrial fibrillation going on. But if you look very carefully at the second beat in every pair, there seems to be a similar signal in front of each of those beats. And we might assume that that's a P wave here. But when we look for something similar in front of the beats that come first, we don't really see anything that looks similar. So we could be dealing with, let's see, the rate here is about 100. So we could call this sinus rhythm with atrial bigeminy, but we have to look further. And the best place to look for P waves, of course, is in V1. So here, if we look at the second beat in the pair, we can see what looks like it could be a P wave pretty consistently. But in front of these other beats, we don't see a P wave that looks like that. Well, keep in mind what you're looking for in a bigeminal rhythm is either disturbance of impulse conduction or disturbance of impulse generation. These are the two electrophysiologic mechanisms that we deal with. In disorders of impulse conduction, most often we would be dealing with some kind of 3 to 2 wanky back. Now you can have this in the AV node, or you can even have this in the sinus node, so-called 3 to 2 sinoatrial exit block. Now, these are advanced topics, but I did cover them to some degree in the basic course. When it comes to disorders of impulse generation, then we're dealing with ectopic beats, and that's where this sinus rhythm with atrial bigeminy comes into place. So you'd have a sinus beat and a PAC, a sinus beat and a PAC. So these PACs are being generated by an ectopic focus, and that's what makes them disorders of impulse generation. Well, we haven't figured out which it is yet, have we? Well, first of all, does anybody believe this is atrial fibrillation? I should be hearing a resounding no coming from the audience out there. This has a pattern to it, and atrial fibrillation, by its very nature, is irregularly irregular and has no specific patterns that you can pick out, so this would not be considered atrial fibrillation. Well, when you look at all these leads and try to figure out if there's a P wave there, it's awfully hard except in one lead. And I want you to come down here and look at lead 3. What do we see? We see what looked like an atrial event in front of this QRS complex. So the second QRS complex of the pair seems to have an atrial event, but look at the shape of that atrial event. Remember, P waves should come off of the isoelectric segment, be discrete, and there should be some sort of a PR segment before you have your QRS complex. But there's no PR segment here. If anything, the PR interval is a little bit short, and if I had to draw it, it kind of goes up and then comes down like that. What does that look like? Well, come and look over here. This goes up and then down, and then up and then down, with a rapid upstroke and a slower downstroke. And these are flutter waves. That's right, this is atrial flutter. You say atrial flutter, wait a minute, doesn't atrial flutter have to be 2-to-1, 3-to-1, or sometimes variable? Well, this is a variety of variable, but because the AV node will sometimes fall into certain patterns, depending upon refractory periods in conduction and so forth, what you're seeing here are alternating AV ratios, where here you have 3-to-1, and then here you have 2-to-1, and then 3-to-1, and then 2-to-1. You can say, wait a minute, are you sure? Let's take a look at the atrial rate. And I think if you look carefully in V1, you can see upright flutter waves here and here. And if you measure those two flutter waves, they're exactly 400 milliseconds apart, which corresponds with a rate of 150 beats per minute. And since there's got to be one more in between, then the atrial rate is just about 300 beats per minute. If we come down to these flutter waves, you can see the flutter wave lands somewhere in between the two heavy lines. And if we come over here, it's still between the two heavy lines. And over here, you have this consistent location. And so that means that the atrial rate is very close to 300. Well, what would be the rate between these two QRS complexes? It's 400 milliseconds. Well, that corresponds with two P-to-P intervals. Then if you look at the interval between these two beats, it's 600 milliseconds, or 100 beats per minute. So you have 600, and then 400, and 600, and then 400. So it shows you that these QRS complexes actually map out with the flutter waves in this kind of a 3-to-1 to 2-to-1 to 3-to-1 to 2-to-1 alternating ratio. Isn't that cool? Now, as far as the rest of the ECG is concerned, it's isoelectric in AVF and it's positive in lead 1. So what's the axis? It means it's pointing this way at 0 degrees. If you check out the voltage in AVL, it's just about 11 millimeters. So you kind of have a borderline case of LVH. But what's more important is that the QRS is a bit wide, about 110 to 120 milliseconds, and you have these discordant T waves. So that everywhere the QRS complex is upright, the ST segment goes down and the T wave is inverted. So these are secondary T wave abnormalities with widening of the QRS complex. So you have a nonspecific IVCD with secondary T wave abnormalities. Most people would read these as nonspecific T wave abnormalities, and just borderline LVH. The two subtle findings are that the transition point in V2 is a little bit early. You have a negative QRS complex in V1, and then V2 becomes positive. So that's known as early transition, and it could be simply due to lead placement, or it may be due to the conduction disturbance. And it's really not a specific finding for anything in particular, but I would read this as early transition. Now, how many people would look at these STs and say, oh, rule out ischemia? Yes, ischemia in the anterolateral leads. Well, because the QRS is wide and because there's a fairly diffuse pattern of distribution, I personally would not read this as ischemia, but rather nonspecific STT abnormalities. But you'd be surprised. A lot of automatic ECG machines will label this as ischemia, and a lot of cardiologists will just shrug their shoulders and say, well, okay, maybe. So there is an art to the interpretation of STT abnormalities here, and I admit that it is subjective at times. But I think this was a really cool arrhythmia, and it's really the most challenging part of most ECGs. Well, on that note, this is Dr. Nick with the ECG Academy. Thanks for watching. Hi, this is Dr. Nick with the ECG Academy, and this week's Chalk Talk is going back to basics. It's a 12-lead ECG of a patient who came to the emergency room. He complained of shortness of breath over the last week or so, especially walking upstairs. There were no palpitations or chest pain. And here's the ECG. So how do you approach this kind of a tracing? Remember, look at the forest first, come down here to the rhythm strip, which is lead 2, and you can see that the heart rate is rather rapid. And you can just pick a QRS that lands on a heavy line, and you can see the next QRS lands 2 boxes away, which is 150 beats per minute, and it looks fairly regular, perhaps a little bit slower because the QRSs are marching to the right of the heavy line, getting further and further away from the heavy line. So that means the R to R interval is a little bit longer than 400 milliseconds. But as you look at these R to R intervals, they do seem to be kind of regular. And many people will glance at this and call it SVT. Sure, you go to the emergency room and they're going to look at this and say, oh, that's supraventricular tachycardia. It's kind of regular. It's got a rate of 150 beats per minute. The QRS is narrow. Speaking of the QRS, if we kind of look at the QRS complexes in more detail, we can see the axis is plus 60 because it's most isoelectric in AVL, which is 30 degrees above the horizontal, and it's positive in the inferior leads. So we're talking a perpendicular, which would give you plus 60. So the axis is normal. The R wave progression is a little funny. You have a kind of a tall R wave in V1 and a persistently tall R wave all the way across the precordium. So your S waves are missing. So one of the two things you might want to think about is right ventricular hypertrophy, which would normally give you a right axis deviation, so that's less likely. And also RVH will give you a very large S wave in V6, which is missing. So the other diagnosis you have to entertain is a possible posterior MI of unknown age, or age indeterminate. Now, isolated posterior MIs are kind of unusual. They most often occur in the setting of an old inferior MI, and we don't see Q waves in 2-3 and AVF. And so then I usually look at the patient's age. If they're young, this may be related to lead placement or what you would call early transition, because the R wave has grown taller much sooner than it should. But most electrocardiographers would actually go ahead and diagnose an old posterior MI, or at the very least they would put cannot rule out or consider posterior MI of indeterminate age. The rest of the QRS complexes look okay. There's a little bit of ST segment sagging in some of the leads, but given the heart rate, at the very most you'd simply call it nonspecific ST abnormalities. Well, let's now turn our attention back to the rhythm because we still have to settle what's happening here. The fact is it's rapid, it's somewhat regular, and you notice I've been very non-committal about that because now it's time to look at the trees. Remember, you look at the forest first, but now when you start to look at the trees, you see, for example, this R to R interval is significantly longer than most of the others. And actually, if you took a pair of calipers, you could see that this R to R interval is a little tiny bit less than 2 big boxes, but this R to R interval is a little bit more than 2 big boxes. And this one is exactly 2 big, and this is a little bit more than 2. And when you get down over here, this one looks really quite short, and then it gets longer again. So you have to wonder, well, what's causing this irregularity? So it could be a couple of different things. You could be dealing with some kind of atrial-based arrhythmia like sinus tachycardia or perhaps an atrial tachycardia, and you're having premature atrial beats that are throwing the rhythm off. Generally, what you'll see in that case is a fairly regular rhythm, but then every now and then you get a short one and then a compensatory long one. And so then it'll be regular and regular and regular, and then you'll get a short interval and then a little bit longer one. So with every short interval, you have a longer one compensating. And that's sort of what you'd expect if you had some kind of regular atrial mechanism with slight disturbances due to premature beats. You really don't see that pattern here. It's much more sort of random and kind of chaotic, and maybe you're getting the clues that I'm dropping now. But of course, you should be looking for something like atrial tach or atrial flutter, searching these long R to R intervals for something that looks like an organized atrial event, like a P wave or a flutter wave or something along the lines of a sawtooth or a discrete bump that you can say is a recurring signal that you can kind of map through the tracing. V1 is always a great place to look for that. and you see a bump here, and you see the same bump over here, and then you see the same one here. And could that be mapping out? Could there be another one here? Well, in this particular example, there's a relationship between the bump and the QRS complex, but the relationship is with the previous QRS complex. You see, this interval stays the same with each beat, and so that tells you that it's actually the T wave. Can you see that the bump to the following QRS varies? This one's shorter, this one's much longer, this one's shorter again. And so there's no relationship between the bump and the next QRS, but there is a fixed relationship with the previous QRS. That tells us that that's actually a T wave. So there really aren't any discrete atrial signals that we can map out. And so we're left with a very basic diagnosis of atrial fibrillation with a rapid ventricular response. What's unusual about this, and why I brought it up in this Chalk Talk, is that most of the time atrial fibrillation is irregularly irregular, and it's obviously so. The irregularity is usually easy to notice, but in this case, most of the RR intervals fall in that 150 beat per minute range, and that makes this atrial fibrillation somewhat unusual because it's mostly regular. It's just every now and then you get a shorter, and then you have a much shorter, and then a little bit longer, and it does vary. You can see it when you carefully examine these R to R intervals, but at first glance, that subtle irregularity might be missed. Of course, you can always pull out a pair of calipers, but it's good if you can train your eyes and use the heavy lines as a reference and compare each R to R interval with the next one and analyze the trees to see what kind of forest you're dealing with. Well, I hope that was helpful for you beginners. I try to mix up the basic with the advanced. And so until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is one of those warning, Will Robinson, danger, danger. It's a strip that I got from the telemetry unit at the hospital, and it had a lot of people running around, alarms going off. So let's try to figure out what's happening here. Now, these are actually two continuous strips, so one leads right into the other. And you seem to have this wide QRS tachycardia, 3 runs of it. And when you first look at it, you can see that the QRS complexes seem to get bigger and then smaller and then bigger again. And so there's some polymorphism to these signals. And the first thing you want to think about is, oh wow, is this torsade de pointe? Is this long QT syndrome? And of course, it may be worthwhile to run into the patient's room and see if they're okay, but these 3 runs of a wide complex signal happen one right after the other. And it's interesting because the underlying rhythm seems to be a normal sinus rhythm with a rate of, let's say, if we start with a QRS on a heavy line, it's 300, 150, 100, a little less than 100, maybe 85 beats per minute. And if we grab a pair of calipers, we can see that the QRS complexes are rather regular and they march on through. And just out of curiosity, if we come up here, we can see that the rate in the beginning of the strip is identical to the rate at the end of the strip. Is that important? Well, it's good because you know that you have this regular sinus rhythm and you can kind of figure out what's going on without having to worry that sinus arrhythmia is going to muck up your measurements. But the crazy thing is, why should someone have these runs of torsade de pointe and not have any impact in the sinus rate? I mean, after all, if you had, this run lasting about 3 seconds and then this one about 4 seconds and this about 2.5 seconds, you would think that the major drop in blood pressure that occurs with a ventricular rate of nearly 300 beats per minute would activate some kind of sympathetic response, right? With drop in blood pressure, the brain doesn't get as much blood flow and it looks to increase blood pressure. And so very quickly, adrenaline is released at the nerve endings and causes the heart rate to accelerate. But, that didn't seem to happen. And so when you analyze a wide complex tachycardia like this, the first thing you have to think is not, is it SVT with aberrancy versus VTAC? You have to think, is it real? That's the one question that struck me as soon as I saw this part of it. And I'll tell you why I thought that. Is because I saw that these little signals here, these very rapid double bump signals, were similar to this signal up here. And I wondered if maybe this was artifact. Because what happens is when you have a smooth signal like this, and then you also add to that a QRS complex, which is very sharp, when you add those together, you get this kind of an appearance. So let's try to figure this out. Now here's the third run that's at the bottom, and I blew it up so we can look at it more carefully. And we take our pair of calipers, and if we put it on the S waves down here, we can see that the QRSs are fairly regular. And if we measure back, we can see the tip of the calipers fall right in line with this double bumped signal. And if we move the calipers back from there, we can see that this little sharp signal occurs right on time. And if we move back once more, we can actually extend this down to right here and see that this very sharp spike occurs on time. And finally, when we come out the other side, we can see that it corresponds exactly with this QRS complex. So essentially what we have is the QRSs are marching through, and that essentially proves that this is artifact. Now this one strip down here was easy to map that out. And so down here in this bottom strip, the QRSs are clearly marching through. So what does that tell you about these two up here? Well, pretty much you can assume that these are artifact as well. It's a little bit harder to prove, but if you take your calipers, you should be able to find that the QRSs do indeed march through it, that this wide signal does not interfere with this sinus rhythm, and all of it, as impressive as it looks, is nothing more than artifact. Some other clues that you're dealing with artifact is when you see a QRS complex immediately after the end of the run that is exactly on time. I mean, this in and of itself tells you that this is most likely artifact, because it's nearly impossible for a sinus beat to conduct so soon after a ventricular event. Other clues can be found at the onset of a strip. When you have such a wide, bizarre-looking signal here, this does not look like a QRS complex. It's just way too wide and bizarre, and the same thing here. You can see that if this was VTAC, then these are QRS complexes, right? But then where did this signal come from? This seems to occur before the QRS, and actually starts with a down dip, and then what's very slowly changing in voltage, something that looks like a T wave, but where did it come from? So the appearance of the signal is also very atypical for a true ventricular tachycardia. At any rate, I hope this gives you some ammunition for those times when you see something crazy come out of the recorder and you're not sure of whether to call for help in the middle of the night because you don't know if this is real or not. Well, I hope this was helpful. And until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy. And as we start this week's Chalk Talk, you come down here to the rhythm strip, and the first thing you should notice is that there are these big giant pacemaker spikes. And I know a lot of people will look at a paced rhythm and think, oh no, not that. I can't do it. But I'm going to try to show you how paced rhythms aren't that bad. The first thing is let's look at the rate. And we can see the spike falls very close to a heavy line, and when we count off to the next spike, 300, 150, 100, 75, 60, it's exactly 60 beats per minute. So the spike and the heavy line falling right exactly on top of each other, indicating that this pacemaker is operating exactly 60 beats per minute. That is the programmed lower rate limit of the pacemaker. But the first thing you should do is try to figure out what kind of pacemaker this is. Well, first of all, these big giant spikes, these are like spikes from outer space. They're huge. And so, do you think this is a unipolar pacemaker or a bipolar pacemaker? Well, what's the difference, you ask? Okay, well, in a unipolar pacemaker, there's a single electrode at the tip of the pacing lead and one conductor that runs through the lead body itself. The electrode in contact with the endocardium is the cathode or negative electrode, and the pacemaker can actually serves as the positive electrode or anode. When the pacing spike is released, the electrical energy exits the tip of the lead, and so the electrons actually return to the can, and therefore this electrical field is set up between the lead and the can, and since it's over such a large area, the ECG machines can usually pick it up very easily. And so what happens is you see a big giant spike followed by whatever signal is being generated, either a QRS complex if it's a ventricular pacing lead, or a P wave if we're talking about an atrial pacemaker. The second kind of pacemaker system is a bipolar system, where there's actually a ring electrode on the outside of the body of the lead and a second conductor so that the electrical energy flows between the tip of the electrode and this ring, which now serves as the anode. The electrical energy travels between the ring and the tip over a much smaller distance. And pacemaker systems sometimes have a very difficult time picking up a spike like that. Sometimes you can barely see it, and in some leads you may not see it at all. So when we come back to this ECG, we can see these big giant spikes, and almost always this means it's a unipolar pacing system. So we have a fixed rate of 60 beats per minute, we have unipolar spikes, and many cardiologists would simply read this as ventricular pacing, or electronic ventricular pacemaker, or a ventricular paced rhythm. When you see a ventricular paced rhythm, you have to ask yourself a very, very important question. What's the atrium doing? Because that'll help you determine if this is a single chamber or a dual chamber pacemaker, and if the pacemaker is working properly. As we scan these leads up here, you may not see any P waves. Your initial impression may be that there are no P waves, in which case you have to at least entertain the possibility that there may be underlying atrial fibrillation. But if you're careful with your scanning, comparing one segment to another, you see that right here, in this interval between QRS complexes, there appears to be a deflection. At least in V1, it sure does look like a P wave. Now, if you only see it once, it could very well be artifact. Maybe the patient bumped the wire at that moment. But if it is a true P wave, then it can't be atrial fibrillation. So now your job is to look for others. And again, it's the old game of where's Waldo? Looking at the whole QRS complex, ST segment, and T wave, look for differences between them. And you should pick up a little bump right here in front of the pacing spike. And in this lead, this T wave has a little bite taken out of it. And when you keep on looking, you can see this T wave also has a bite taken out of it, but this one does not. So now is where you have to pull out your trusty pair of calipers. What we can do is set the calipers to measure one P to P interval right about here, and see if the P to P interval is consistent. Well, it does appear to be pretty consistent here, but when you bring it over here, this P wave seems to occur a little bit late, and this P wave over here, which causes a bump on the T wave, appears to be a little bit early. Now, if we measure the interval between P waves on the average, that's 1400 milliseconds, and you get a rate of somewhere just above 40 beats per minute, but it certainly does not look consistent. And there's no relationship between the QRSs and the P waves. The pacemaker is essentially ignoring them. So I think we've established that we do not have atrial fibrillation going on, but rather there's evidence of sick sinus syndrome with profoundly slowed sinus rhythm and a certain degree of sinus arrhythmia. The other finding is that none of these P waves conduct, even this one that lands right in the middle of the R to R interval. And so there must be some degree of AV block present as well. Now, I must say in the United States, if they don't have permanent atrial fibrillation, the inclination is to implant a dual-chamber pacemaker. But this is what an ECG would look like in a patient with sick sinus syndrome with AV block who receives a single-chamber unipolar pacemaker. Well, I hope that was helpful. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a little bit advanced, but it'll be a fun experience to go over this rhythm and try to figure it out with you. So let's get started. If we look at the forest down here in the rhythm strip of lead 2, we can see it looks pretty slow. If we try to count off the QRS complexes here on this heavy line, let's count 300, 150, 100, 75, 60, and then 50, and 40 is over here, so it's about 42 beats per minute. The other way you can do it is if you want to count the interval. We have 2, 4, 6, 8. That's 1 second, so 1,460 milliseconds. The easiest way to just take your calculator and do 6 divided by 1460 gives you a heart rate of 41 beats per minute. Pretty close. Well, let's look for P waves in front of the QRS complexes and try to figure out what the rhythm is doing. Well, I see what looks like a P wave in front of this QRS complex, and it looks a lot like this one, but there's a little bit of a problem because it looks like the P and the QRS are practically on top of each other in this beat, and this beat as well. And in fact, when you look at this beat, where's the P wave? If you compare this QRS complex with this one, you can see that there is a signal at the bottom end, and I think what's happening is you have a P wave, and the QRS starts just after the P wave begins. So you get that first part of the P wave peeking out from behind the QRS complex. So what's going on here? We have a very slow rhythm. We have P waves, but the PR interval is awfully short. I think the longest one here is this one at 120 milliseconds, and most of them are considerably shorter, with the QRS complex starting even before the P wave is finished. So these P waves couldn't possibly have conducted to the QRS complex because the PR is too short. When you can think about whether this could be pre-excitation with a very short PR because of an accessory pathway, but if you understand anything about pre-excitation, you realize that the PR interval should still remain fixed even when you have WPW, because in that case, the accessory pathway is off on the side and the P wave gets to the ventricle very quickly, but it gets down to the ventricle through that accessory pathway in a very consistent manner. So whatever short PR interval that you have in pre-excitation remains constant, as long as the rate remains constant because there is some fusion with the underlying rhythm. But you won't see changing or variable PR intervals when you have pre-excitation, as long as the rate remains the same. But I would say pre-excitation is not a good guess here. So the idea here is that you have P's marching through at a rate of about 41 beats per minute, but you also have QRSs that are going at roughly the same rate, and it does not appear that the QRSs are coming from the P wave. So this P wave does not conduct, and therefore the QRSs must have come on their own. Well, they're narrow, and they look fairly normal up here, except for the left axis deviation. I mean, when we look at the QRS axis up here, this is the first time we're looking at it. We see it's isoelectric in AVR. That tells us your axis is at minus 60 degrees, and it does appear to be a small R wave in the inferior leads, so we're talking a left anterior hemiblock. But where did the QRS complex actually originate from? It looks fairly narrow, and it's not coming from the P waves. So you have to call this a junctional rhythm. These QRS complexes are arising from the AV node and conducting down the conduction system, although the marked left axis suggests that there is a left anterior hemiblock, but the QRS overall is pretty narrow, so for the most part it is going down the conduction system. But the site of origin has got to be somewhere in the AV node itself. It could be the high AV node or it could be the low AV node. Now, most of the time when you have an AV nodal rhythm, it originates from somewhere in there, goes down the conduction system to give you a narrow QRS complex, but most of the time it's able to go retrogradely up to the atrium and results in a P wave that begins down in the low right atrial septum and spreads upwards. So when we look at junctional rhythms, under normal circumstances, what do we expect to see is a retrograde P wave following the QRS complex. The signal gets up to the atrium, it travels northbound, and so the P waves in the inferior leads should be inverted, but here they're not. Now, in some cases, if the rhythm comes from the high part of the AV junction, it might actually emerge from the low right atrium fairly quickly with some antegrade delay, and you could potentially see inverted P waves with a very short PR interval. Although I tend to try to call these low atrial rhythms, if the PR is very short, it's conceivable that you could get junctional rhythms that look like this. But the point is that P waves would normally be inverted, and here the P waves are upright. So where did these P's come from? Well, these look to be sinus P's because they're upright in one and they're upright in the inferior leads, but they're going at roughly the same rate as this junctional rhythm. So what you have is severe sinus bradycardia that is roughly the same rate as this junctional escape rhythm. And because they are the same rate, the word iso means the same. And so this is an example of isorhythmic AV dissociation. Now, AV dissociation implies that the ventricular rhythm is coming from someplace other than the atrium, and it's beating independently. Most of the time we see this AV dissociation with ventricular rhythms like AIVR or even ventricular tachycardia, and we can also see this when the ventricular rhythm is coming from a pacemaker. In that case, the ventricular rate is faster than the atrial rate, and we can make this diagnosis of AV dissociation, as opposed to the circumstance where the atrial rate is faster than the ventricular rate, and there's no relation between the A's and the V's or the P's and the QRS. What do we call that? As complete heart block. But in AV dissociation, the ventricular rate is faster than the atrial rate. But here's a situation where the ventricular rate is roughly equal to the atrial rate. At times, it looks like they're related to each other. If this PR was a little bit longer, you would even think that maybe this is just sinus bradycardia. But because the rates of the sinus node and the AV junction are roughly the same, they're occurring at more or less the same time, and we call it isorhythmic AV dissociation. And the only reason you can tell that this is isorhythmic AV dissociation is because there is a very subtle difference in the rates over time, and so the PR relationship changes. You can see the PR gets shorter here, and it was a little bit longer here, and then here they occurred virtually simultaneously, And here the P preceded the QRS in such a manner that you might even think it was conducted. Okay, so that's how you recognize isorhythmic AV dissociation. The P's are clearly not conducting. This is a junctional rhythm separate from the atrium, but they're roughly the same rate, and you have this very slight movement back and forth. It's like the P is just sort of migrating back and forth in front of the QRS complex, dancing around, but unrelated because the P's are not conducting. Now, if the sinus node does speed up, it may start to capture the AV node, but then what will happen is the PR will become fixed. With the increase in the sinus rate, the ventricular rate will speed up accordingly. So this is not something you see very often, and you may have heard of this isorhythmic AV dissociation business, but I came across this tracing and I thought you guys would enjoy it. Well, until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching.
Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk came from a Holter monitor on one of my patients. It's a subject that I really enjoy talking about. As you can see, we've got group beating. As you scan across and look at the forest, you can see groups of 2, here and here and here and here, separated by a slight pause. And the question is, how do you approach this? How do you figure out what's actually happening physiologically? The best approach to trying to figure out what's happening is to look at the pause first, because that's when you'll usually see a P wave. And remember, P waves have high frequency content, so they tend to look a lot sharper and spikier than T waves, which contain mostly low frequency signals. So we can easily see a P wave right here in all 3 of these leads, preceding this QRS complex, and the PR looks to be at the upper limits of normal. It's just about 200 milliseconds. When we look at the rest of the beats that follow the pause, we can see there's a very consistent relationship between the P wave and the following QRS complex with a fairly fixed PR interval. Now let's take a look at the second beat. Now we don't see a P right in front of it, but we do see a P wave out here in between the 2 QRSs, and the PR interval has obviously gotten longer. The P conveniently starts on this heavy line, and the QRS starts on the second column of dots, so that gives us about 280 milliseconds for the PR of the second beat. Now what's interesting is when you look at the second beat, in this pair, the PR is a little shorter. It's only maybe about 240 or 260 milliseconds, but it's clearly longer than the first PR interval of this pair of beats. The others are pretty similar, with this last PR being, again, about 260 milliseconds. So what we have are pairs of beats with the second beat having a longer PR. And when you first glance at this, you see paired beating, you see the PRs getting longer. And the first thing that people will think about is whether this is Wenke-Back, otherwise known as type 1 second-degree AV block. And of course, we think about this because we know that in type 1 second-degree AV block, the PR is not fixed and it gets longer prior to a non-conducted P wave. If you draw the PR, it gets longer, and then a P wave occurs on time and fails to conduct until the next cycle when the PR gets shorter again. And this occurs why? Because the AV node, which has cells that fire because of calcium channels, has a particular physiologic characteristic known as decremental conduction. And that means when the atrial rate is too fast for the AV node to conduct one-to-one, you get progressive prolongation of AV conduction time, and that causes the PR interval to get longer. So you have short, and then it gets longer, and then you have a block, and then it gets shorter again, following the pause, because the pause allows the AV node to recover from its relative refractory condition and conduct better. That's the pause that refreshes. Okay, so in other words, this is a manifestation of AV block, and what you need to see is this: a P wave that lands on time and fails to get down the AV node. And that's the mistake most people make, is that they don't make sure that this P wave occurs on time. Most often what will happen is you'll get a premature atrial contraction that blocks, and the block PAC is mistakenly identified as an event of AV block. We've gone over that in Chalk Talks in the past. Well, my question for you here on this trip is, where is the blocked P wave? In other words, if this truly was Wenke-Back, we should be able to find a P wave that lands on time and fails to conduct. I don't see one. Here again,
Here again you have two P waves in a row, and then one should have occurred here, but it's absent. Now if it was a blocked PAC, you can look at this T wave and see some kind of deformity, especially when you look at this P wave, how sharp it is. Look how you've got this double bump, and you can see this is a very sharp, fragmented P wave, but yet this T wave is very smooth, and so there's no blocked PAC, and there's no sinus P wave. So it seems that all the P waves conduct, and AV block is not present. So how do you classify this arrhythmia? And what you have is pairs of atrial beats separated by a pause. And the reason the PR is longer is because this early P wave lands on the AV node's relative refractory period. So this P comes early enough that the AV node conducts it, but it takes a little longer to get down the node because of this decremental conduction characteristic. So really the best thing to call this is simply atrial bigeminy, with these more premature P waves conducting with a first-degree AV block because of the normal behavior of the AV node under these circumstances. But the fact that the P waves look the same is unusual for atrial bigeminy. In atrial bigeminy, the second P wave usually looks a little bit different than the first because it's coming from a different spot in the atrium. If here's the sinus node and the PACs are coming from down here someplace, they're clearly going to look different from the sinus Ps. But if the ectopic focus is in the high right atrium, close to the sinus node, then they'll look the same. Well, I think this was a fairly basic review of how you approach a strip like this, and I tried to review some of the basic physiology that we deal with when we examine changes in the PR interval. So until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is another one at the basic level because I think every now and then it's good to review some concepts that most people don't get in a regular ECG course. So this strip came from my telemetry unit, and when you glance across at the forest before looking at the trees, there seems to be a change in the heart rate here and also a change in the QRS morphology. Looking carefully, it looks like there are a couple of sinus beats here. Then you have an increase in the heart rate to maybe about 150 or 160 beats per minute, and then it slows down again. And then after some pause, you've got a couple of normal beats at the end. So how do you approach this kind of a rhythm problem? Well, most telemetry techs and nurses who look at a strip like this would say it's irregularly irregular, it's rapid, and the QRS changed, so maybe it's some kind of SVT with aberrancy. Yeah, like atrial fibrillation, rapid AFib, with aberrant conduction. Yeah, that must be it. And in fact, that's what the nurse wrote on the strip here. But just remember Tulow's law. That is, don't ever believe anything you read on a rhythm strip unless you wrote it yourself. So let's take a closer look at these QRS complexes. Okay, that's better. Don't you love these high-resolution scans? Well, let's take a look at the normal beat. The P wave looks to be fairly normal. The PR is about 140 milliseconds. The QRS is 90 milliseconds, so that's normal, and the QT interval is about 340 milliseconds. If you divide the R to R interval in half, the QT seems to end before that point. Okay, so now looking at the next beat, you have the same PQRS and T wave, and if we measure the sinus rate here, it's about 85 beats per minute. When we look at the first beat of this funny run here, from here to here, it's about 120 beats per minute, and the QRS morphology changes a little bit. The QRS widens out to about 130 milliseconds or so, and then it changes even further with beat number 2, with a duration again of about 120 to 130 milliseconds. Now when you see a run like this, what's the first thing you should look for? You should look to see how does it start, right? So what we're looking for is a P wave that may have initiated this run. Because if it was atrial fib or atrial flutter or PAT with aberrant conduction, you should see a P wave that kicks it off. Well, some people would look at that and say, whoa, look at that. Is that a P wave? Well, no. Because first of all, compared to these P waves, it's way too small. The PR interval would be way too short for that P wave to have conducted. And besides, if you look at the beat before, you see a bump that's timed about right. It looks about the same, and I think that that's just a U wave. Remember that normal people can have U waves, and it's very small here, but this little signal corresponds with what follows a normal beat. So this is not a P wave. Now you can often see P waves buried in the previous T wave, so you always have to look at this T wave, look at the smoothness of it, and compare it with the previous T wave to see if there might be a P superimposed here someplace. But no, this T wave looks exactly the same as the previous T wave. So I think the conclusion here is that there's no P wave. Remember that P waves have very high frequency components. They tend to be sharper and spikier than T waves. And so if you have a T wave and then you look at the next one and it's got a bump on it, then that tells you that the P wave is present there. Well, I don't see any bumps in front of this QRS complex, but I think it's curious that there's a rather high frequency deflection right here. Now, if this was ventricular, then this would be a retrograde P wave, because in many patients, this ventricular beat can go retrograde up the AV node to give you this funny-looking P wave signal. Looking at the next QRS complex, again, you see a very jiggly-looking signal on the upstroke of the T wave. And this beat, you have the same kind of rapid high-frequency deflection on the upstroke of this T wave. So even though this QRS looks kind of sort of narrow, it's a little bit wider than the underlying QRS complexes, and there seem to be retrograde P waves with nothing in front. So what's driving the rhythm? The ventricle. This is non-sustained ventricular tachycardia. Let's see if we can slide this over. And you can see that each QRS has a retrograde P wave following it. Retrograde P, and retrograde P. It's grossly irregular, but yet everything indicates that this is ventricular in origin. As we slide this over further, we see that after a compensatory pause, there's a normal sinus beat, and the rhythm goes back to the way it was before. So I wanted you to see how we can establish this as a run of non-sustained ventricular tachycardia. Although it's irregular, it would appear that the ventricles are driving the atrium, and you've got retrograde P waves after every beat. But there's one more thing in this strip that supports a ventricular origin for this. And as Steve Jobs used to say, there's just one more thing. It's this first beat. Who can tell me what this first beat is? Now, let's not always see the same hands. Well, it's a fusion beat. Look, there's a P wave in front of it, but the PR interval is shorter than the normal PR, and the QRS complex is different from the underlying QRS complexes that are conducted down the normal conduction system. This QRS is sort of halfway between these ventricular-looking beats and the normal beat. Okay, so that's what a fusion beat looks like. So what you have is two different places where the QRS is coming from. A PVC down here someplace that starts right about the same time as the signal is getting through the AV node and coming down the His-Purkinje system. So part of the QRS is coming from the His-Purkinje system, and part of it is coming from this wave of depolarization that's arising from the PVC. And the QRS complex, it's a combination of the two. It's fused. That's right. Yeah, that's the ticket. So seeing fusion beats definitely supports the idea that you have a ventricular focus, and again, it helps us to prove that this is non-sustained ventricular tachycardia. I hope that was helpful. Until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a 12 lead, but we're going to have some rhythm issues to deal with as well. So let's get to it. If you look very carefully at the rate, you'll find that the QRSs are just a little more than two big boxes apart. As you can see, the heavy line is here, and the QRS is marching away from that heavy line from one beat to the next. Overall, it looks quite regular, but the rate is just a little bit lower than 150 beats per minute. So maybe it's 145. But when you scan across the forest, you can see that the QRS complexes are pretty regular. And if we look in front of the QRS, we can see what looks like some kind of atrial activity here. But what's interesting is it's inverted here in lead 2, which means the electrical signal is going in the opposite direction from a normal sinus rhythm. Well, we'll get back to the rhythm. Let's look at the rest of the ECG. If we look at the limb leads, we can see that there's not one isoelectric lead. AVF is more isoelectric than lead 2, but it's not completely isoelectric. It's a little bit negative. So if AVF was isoelectric, then that means the axis would be just about 0. But because it's negative, it's going away from AVF. It's just a little bit higher than that, like maybe minus 10 degrees. I say that because if lead 2 was most isoelectric, lead 2, remember, is 60 degrees above the horizontal, heading towards the left side of the patient, then the axis would be minus 30. And clearly AVF is more isoelectric than 2. That's why I said minus 10, which is closer to 0 than it is to minus 30. So that's a quick way of estimating the axis when you don't have one single isoelectric lead. Well, one thing that should stand out as you look at these leads and analyze them carefully is that there's quite a bit of voltage in AVL. It's about 13 or 14 millimeters, which gives us voltage criteria for LVH. That's supported by the fact that the R wave in 1 plus the S wave in 3 is nearly 25, and that you do have this leftward axis of minus 10. Looking at the precordial leads, there's nothing much to talk about. You have a little R wave, and it does grow. Transition point is around V4, and although the way it transitions across the precordium is a little bit unusual, there's nothing intrinsically abnormal about it. Okay, well, let's get to the rhythm now. These atrial events are negative in 2, 3, and AVF. And so they're headed in a superior direction. And one would be tempted to call this some kind of atrial tachycardia. But let's take a closer look at it. Okay, so here's lead 2 and here's lead 3. And we have this downgoing atrial event in front of each QRS complex. But you have a ventricular rate of 145 beats per minute. So you need to think about the same few things that we talked about a few weeks ago. Is this sinus tachycardia? Well, no, it's not sinus because the P wave axis is completely wrong. Is it atrial tachycardia coming from somewhere in the lower right atrium? Possibly. Could it be some kind of PSVT that's utilizing the AV node as part of the pathway? Well, that's a possibility too, because it's quite regular and the relationship between the P and the QRS seems to be fixed. But what's the one that's missing here? And that would be atrial flutter with 2-to-1 conduction. And that would generally give you a heart rate of 145 beats per minute. Now, what's important to notice is that there is a kind of a slopey feeling to this atrial event here in lead 3. Instead of there being an isoelectric segment before the P wave, there seems to have a slope to it as if the signal is changing continuously. And that's a clue that you may be dealing with a reentry circuit where the signal never really stops. In most kinds of atrial flutter, you have a reentry circuit that's going round and round, and because the signal never stops, you really don't have much of any kind of isoelectric interval here. Well, okay, let's take another careful look at lead 2. If you notice, you've got these negative deflections, but if you look halfway between them, you'll see that the tail end of the QRS complex has the same negative deflection. And you really kind of have to use your imagination. But this is clearly atrial flutter with 2-to-1 conduction. Most cardiologists would get that, as it's going down and then a rapid upward deflection, and then down and rapid up, and slow down and rapid up, and slow down and rapid up. So you have this sawtooth signal, but because the AV node is conducting every other beat to the ventricles, it's harder to appreciate it. Here, you would think that this downward deflection is part of the QRS complex, but it's actually the other flutter wave. Okay, so once I point that out to you, it's actually pretty easy to see, isn't it? But sometimes you have to use your imagination, and keep in mind that when you see 145 beats per minute, don't forget to look for atrial flutter. One last thing is that if we look at V1, V1's usually a good place to look for flutter waves. And we do see a very discrete, sharp deflection in front of each QRS complex. But when we look in between, we can see that there is a very sharp jiggle right there on the ST segment. And you know that ST segments and T waves are supposed to be very smooth, but when you see high-frequency jiggles like that, it's a good bet that those are atrial signals. And that confirms this to be atrial flutter with 2-to-1 conduction. And so I hope this was helpful. Until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a little bit different, in that it's an ECG abnormality that does not involve an arrhythmia. I guess I gave that one away. But here's the story. This is a 40-year-old gentleman who presented with recurrent SVT, and electrophysiologic testing revealed 2 separate left-sided accessory pathways. So a transeptal puncture was done pretty easily, and the ablation catheter was passed to the left atrium, where the 2 pathways were successfully destroyed with catheter ablation. The patient was in the holding area, and he started to complain of chest pain, and the nurses were monitoring lead 2, as you can see here. And of course, being cath lab nurses, they were very concerned that there was some ST segment elevation. So I thought I would go over this with you. Now, you see what looks like a regular rhythm, and the heart rate here is just about, counted off, 300, 150, 100, just about 100 beats per minute. It's really quite regular, and we can see a P wave in front of every QRS complex. But examining each complex, we see a P, a small Q wave, a tall R, and there's not much of an S, but most people would notice that the ST segment here is elevated indeed. Now, what should we take as the baseline? The baseline is usually considered to be the segment between the T wave and the following P wave. So it turns out that this TP segment and this TP segment are both really on the same line, so it would be very convenient to consider this to be the baseline since you don't have any drift from one beat to the next. So if this is the baseline, we can see that the ST segment is about 1.5 millimeters elevated off of the baseline. So you have 1.5 millimeter ST segment elevation. But the interesting thing that most people wouldn't notice, and this is a major clue, is that the PR segment actually looks to be about 1 to 1.5 millimeters depressed. Now, when you see ST segment elevation, immediately you wonder about transmural ischemia or infarction, and you're wondering if maybe the patient is having an acute MI. Well, consider what he just had done. Here's a drawing of the heart with the normal AV node and his bundle branches, and this particular patient had a left-sided accessory pathway, so there's a connection here between the left atrium and the left ventricle that allows PSVT to occur down the AV node to the ventricle and then back up the pathway to the atrium and then back around again. So if you remember from my SVT talk, that would be orthodromic AV reentry tachycardia using an accessory pathway. You'd see this in WPW syndrome. Well, anyway, to do an ablation, you go up the femoral vein, you get to the right atrium, you pass through the thin membranous septum to gain access to the left atrium, and you get your catheter right on that accessory pathway and you burn it. So you're sitting in the left atrium and you're burning along the left accessory pathway. And so what would cause ST segment elevation like this? Well, you're not in the arterial tree, so it would be very unlikely to develop a coronary occlusion under these circumstances. But what you really want to do is ask for a 12 lead. So here's the 12 lead, and here's lead 2. So here's the 12 lead, and if we look at lead 2, we can see those STs are indeed elevated. And if we look at anatomical regions, we want to look at lead 3 and AVF, and we do see a little bit of ST elevation there too. But let's look at the whole ECG. We have this normal sinus rhythm, but look here in lead 1, you have ST segment elevation as well, and AVL. So that's lateral. So are we talking an infralateral infarction process? But let's look at the anterior leads. There's about a 0.5 millimeter elevation in V1, but V2 is very elevated, probably about 3 millimeters. And here in lead 3 as well, and look at that 4, 5, and 6. So you have ST segment elevation in every single lead except this one, AVR. And there, in fact, you have ST depression. So there's a diffuse process going on. You have ST elevation and you have PR segment depression. And you need to know that this is a picture that's classic for acute pericarditis. And we don't see pericarditis that often, but in this case it's traumatic because we were burning the left atrium, and in fact when we did an echocardiogram there was a small pericardial effusion, which probably represents either a tiny perforation or perhaps a very intense inflammatory reaction. Well, luckily this was self-limited, and with some analgesics and rest, the patient's chest pain went away within a couple of days, and the effusion did not grow. In fact, it got smaller as time went on. But this is one of those ECGs that you don't come across very often, but you need to be able to recognize acute pericarditis with diffuse ST elevation, PR depression, and ST depression in AVR. Well, okay, no tricky rhythms this time, but I hope you enjoyed this Chalk Talk. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is one of those back to basics. I got this strip off of the telemetry unit at my hospital, and I thought I'd share it with you. So I'm not giving you much here, 2 beats and then a 5-beat run of a wide complex tachycardia. So the question is, what is it? But it boils down to 2 things. Is this non-sustained ventricular tachycardia, or is it some kind of supraventricular tachycardia with aberrant conduction? And I mean, that's the debate that most people have on these units when looking at a wide complex tachycardia. So I'm trying to give you an organized, systematic approach based on the physiology of what you would expect if you know anything about the cardiac conduction system. So let's look at these first 2 beats. You should notice that the QRS is pretty wide at about 5 small boxes or 200 milliseconds. So that's already quite wide, and you have kind of an RSR prime here, so there's some kind of bundle branch block present. Now, if we look for P waves, these are a little harder to see, but if you scan across the isoelectric point between these two beats, you should see a similar signal right here with the same relationship to the following QRS complex. So these look to be the P waves, and the rate here, if you count off, this is a little bit left of the heavy line, but 300, 150, 100, 75, 60, and then you have another couple of lines on each side. So the rate is about 56 beats per minute or so. And the PR interval is about 280 milliseconds. So at this point, we can say that it looks like a sinus bradycardia with a first degree AV block because the PR is longer than 200, and an interventricular conduction delay of some sort, perhaps a bundle branch block. And then we see this wide complex tachycardia. Now, people always say, well, it's wide to begin with, and maybe with this rapid rate, the interventricular conduction disturbance got a little worse, especially when you consider that the QRS complex here goes down, and here you have kind of a notching RSR prime, and here it also goes down, and you have sort of a notching RSR prime. So the morphology of this group of 5 is similar to the first two beats. And a lot of people would be tempted to just say, well, this is just some kind of worsening IVCD. So you have maybe a fib with a widening of the QRS, a rate-related bundle branch block that just got worse. Maybe, maybe not. Well, let's try to figure that out. If we look at the width of this QRS, interestingly, it doesn't really change all that much. I mean, here it is, it's about 200 milliseconds across. I think if you look at this top lead very carefully, it looks more like 160 here, and then you have 200 here. So the duration itself maybe doesn't help us much. The morphology doesn't really help us a lot, except clearly it does seem to change. So here the R is small and the R prime is very large. That's the R prime here. Whereas here the R prime is smaller. Well, there's a mnemonic that you can remember, and that's in V1, which is what we seem to have here, is that if you have an RSR prime, sort of typical of a right bundle branch block, the so-called rabbit ear appearance, just remember the word ear, so label the R as an E and the R prime as an A, just like the word ear. And that's a reminder that if the R is taller, it's more likely ectopic, meaning ventricular tachycardia. And if the R prime is taller, then that's more likely aberrant. And that's an easy way to remember it. And if you just go by that rule, you would think that this is more likely to be just an aberrant right bundle branch block. And here where the R is taller than the R prime, it's more likely ventricular tachycardia. But again, we're going by subtle morphology differences, and I want you to prove to me that this is ventricular. Don't just say, because it looks like it. You have to think in terms of AV nodal physiology. How does the AV node behave under normal circumstances? So we've already decided that the PR interval here is 280. And if we take out a pair of calipers, we can put it on the P waves and measure the P to P interval. And notice that this P wave occurs on time. But what can we say about the PR interval? Well, it sort of kind of looks the same. It looks so similar that you wouldn't even think about it. Well, let's take our caliper's little brother here, and if we place it on the beginning of the P wave and the beginning of the QRS complex, we can indeed verify it's about 280 milliseconds. But now if we come to this beat and we place it at the beginning of the P wave, we can now see that the QRS starts a little bit earlier than it should. The PR is about 40 milliseconds shorter. It's about 240 milliseconds here compared with 280 on the normally conducted beats. You see how the QRS starts early? Why would the AV node suddenly conduct faster? Well, in general, that's just not going to happen. And so what that tells you is that this QRS complex right here started earlier than it could have had the AV node conducted it. So if the QRS didn't get down the AV node, it must have come from the ventricles. You get that? In fact, I would be so bold as to call this first beat a fusion beat because it looks a little bit smaller than the other four. And that's because what you have is a P wave may have gotten down just a little bit of the Purkinje system, and this first QRS was a combination of normal conduction plus the ventricular premature beat that starts this run of non-sustained VT. So with this, I've given you the tools to determine without a doubt that this is a run of VTAC, and don't let anybody try to talk you into it being atrial fib with aberrancy. Think in terms of physiology and remember how the AV node behaves, and examine all the little details, because it's those little subtle findings that lets you prove to yourself the answer and removes all doubt. And so until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching.
Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is very basic for those of you who are just starting out reading ECGs. I want to try to give you an organized approach to a rhythm strip like this and give you some tips and tricks to look for hidden signals. So, the first step is always to look at the forest, not the trees. Look at the whole entire strip and get a sense of whether there were any irregularities in the rhythm. And you just kind of have to glance across and see that it looks regular, except right in here you have two beats that seem to be out of place. Some people will go as far as to use calipers, but you can train your eyes to see these kinds of subtle rhythm differences. We can see that the first 5 beats look fairly regular, but none of the R waves land on a heavy line, but we can look at the beginning of the QRS complex. For example, this QRS complex lands on a heavy line, and it makes it a little bit easier for us to measure things. For example, the rate, we can measure back from the beginning of this QRS complex, count off boxes 300, 150, 100, and we can see that the heart rate is just about 100 beats per minute. Now, if we keep on looking back, we can see that this QRS is starting a little to the right of the line, and this one's starting even further to the right of the line. So the QRSs are marching away from the line, which means it's not exactly 100 beats per minute, but the interval is actually a little bit shorter than 600 milliseconds, and so the rate is slightly faster than 100. It could be maybe 101 or 102, but that would be splitting hairs, wouldn't it? So let's just leave it at 100. We can look at the PR interval. If the QRS starts on this heavy line, the P wave seems to start between this heavy line and the next fine line, so that would be 4.5 small boxes. Each one's 40 milliseconds, so you can calculate 180 milliseconds for the PR interval. The QRS looks to be normal in duration. It's less than 3 small boxes, less than 120 milliseconds, but not much less. It's about 110 milliseconds just eyeballing it. Now the QT looks like it might be a little bit long. Now the rule is that if the T wave extends past the midpoint between the two QRS complexes, then the QT is probably prolonged. So let's go back to the basics, Bazette's formula. So I measure a QT interval here of about 400 milliseconds, and the R to R interval will round off to 600. So what's Bazette's formula? It's the corrected QT is equal to the QT over the square root of the R to R interval in seconds. So the R to R interval in seconds is 0.6. It's 0.6 seconds here. Each large box is 0.2, right? So that the QT that we measured is 400 over the square root of 0.6. Get out our trusty calculator, and we measure 516. Now for a normal male, the upper limits of normal are about 420 to 440 milliseconds. And for females, it's a little bit longer than that, 440 to 460. So clearly the QTC of 516 is prolonged. And that needs to be mentioned. But here in lead 2, we do have upright P waves in front of every beat at a rate of 100 beats per minute, so we still have normal sinus rhythm, except what happened here? What about these 2 beats? Where'd they come from? Well, the QRS morphology looks the same as the normal beats, and so it appears to have gone down the normal conduction system, and it must have originated from somewhere above the ventricles. And they're premature, so are they premature atrial contractions? If they are, where's the P wave? And that's what you have to look for. Whenever you see a premature beat, always try to find out where it started. And if it started in the atrium, then it's obviously a PAC. But where's the P wave? How could you even look for it? Well, here's the trick. You have to understand that P waves generally have fairly sharp, spiky appearances because the rate of change of voltage, or the slope of the electrical signal, is relatively high compared with T waves. So you've got a lot of high-frequency components to this signal. The voltage changes rapidly. You have sharp signals when it comes to P waves, whereas T waves generally change much more slowly.
so the slope of the signal is more gradual. You often do not get sharp, pointy bumps or bites out of a T wave unless there's a P wave superimposed. So you have to train your eye to compare T waves. Look at this T wave, see how nice and smooth it is. It looks identical to this second T wave. They all look the same, except look at this T wave. This T wave is clearly larger and a little bit more bumpy looking than the previous T wave. And that's because there's a P wave superimposed on it. That's where most of the answers lie, is in the T waves, because that's where you don't expect to find things. So there's a PAC that's superimposed on this T wave that then conducts to the ventricles. Now, what about this QRS complex? Where did it come from? Well, look at this T wave. You can see that this T wave looks even more pointy and more sharp than the previous one. And compared with the T wave that follows this, it's clearly different. So there's a second PAC that conducts normally to the ventricles. And when you have two premature beats in a row, what do we call it? We call it a couplet. Now, following this second PAC, there's a little bit of a pause because usually the sinus node gets suppressed a little bit, which is kind of a normal physiologic characteristic of the sinus node. But then what you have here emerging is a fairly normal P wave that conducts to the ventricles. But notice one thing. The PR interval of this beat is a little bit shorter than the PR intervals of all these beats. It's about 160 milliseconds. Now, why do you think that's so? Well, that's because the AV node, which is what conducts this P wave to the ventricles, behaves in a dynamic or changeable manner. So at this faster rate of 100 beats per minute, the PR interval will tend to be a little bit longer. But now you have a nice little pause, and that's the pause that refreshes, and the AV node, after a pause like this, will often be able to conduct a little bit more efficiently, a little bit more quickly. We see that kind of variable AV conduction in AV nodal disease, like we see in AV block, but here's an example of how even during a normal rhythm, the AV node can speed up just slightly or slow down just a little bit depending upon the heart rate. And so the final interpretation of this strip would be a normal sinus rhythm at 100 beats per minute with an atrial couplet, and don't forget to report the prolonged QTC of 516. Well, that's it. Overall, just remember to look at the entire forest and then start to pick at the trees and look for subtle details like changes in the T wave shape and size. And keep in mind the physiology behind it all, because that will help you interpret more difficult strips. That's why I put these chalk talks together, to show you how to apply those physiologic principles you learned during the course into analyzing rhythm disturbances and coming up with the right answer. Until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk came off a Holter monitor. It's, again, back to basics because there are a lot of new subscribers, and I want to get you guys tuned into how I think when I look at a strip like this. As a heart rhythm specialist, I'm always thinking about the physiology and how I can explain the appearance of the ECG on physiologic terms and make sure that I know what's going on in every part of the cardiac conduction system. So I always tell people, look at the forest first, and you can see that there's this normal-looking rhythm over most of the cardiogram, but there's this crazy wide complex tachycardia here in the middle. So we'll scan across and make some basic measurements first. This QRS starts very close to a heavy line, and we can count off the rate with that, 300, 150, 100. And so 75 would be here, but it's a little bit faster than that, so it's probably about 78 beats per minute. The PR interval looks fairly normal. If it was 4 small boxes, it would be 160 milliseconds. It's a little less than that, so I'd say 150. The QT interval is about 360, and if we look at the midpoint between the two R to R intervals, it seems like the QT is less than that, so it's probably normal without going through the calculations. And then after the third beat, we see 1 and then 2 wide QRS beats, and then a narrow one that looks kind of like a normal beat. And then it looks like the normal sinus rhythm carries on through. Well, I always tell people, make sure that you're looking at something real, that it's not artifact. In fact, something must have happened, because if you look at this QRS complex, it did not occur on time. If I take a pair of calipers and place it on the QRS complex, the QRS that occurred after the 2 wide beats is clearly not on time. So these are real. Something really happened here, and let's try to figure out what.
Now, the first rule in approaching a wide complex tachycardia, or even a wide complex beat, is how did it start? Where did it come from? Because if it came from the ventricle, then there should be no atrial events prior to the beat. Putting that a different way, if this was an atrial beat with aberrant conduction, then we should be able to see a P wave in front of it. So let's look for Waldo. Where are the P waves? Well, the best place to look for P waves is on top of the previous T wave. And so you should always examine the T waves of the normal beats and then look at the T wave prior to the wide beat. And you can see it's distinctly different. And this one's really easy. Look at that. There is a P wave right there that is not present there. See, the T wave looks different, so there must be a P wave superimposed on it. And you can see that in all three leads. So if there's a P wave here, is it on time? Well, no, it comes right after the previous QRS complex, which means it's premature. So this is a premature atrial contraction, or PAC. Then this QRS complex came from the PAC. It conducted down the conduction system, but because it's a premature atrial contraction, this beat got down the AV node, but encountered some sort of interventricular conduction delay. Okay, so if you recall, the AV node passes the signal down to the His bundle and the bundle branches, but there's a certain refractory period to the bundle branches. There's a certain period of time after they fire when they're not excitable, and this gets back to the action potential of a Purkinje fiber. Now, the thing is that one bundle often recovers sooner than the other bundle. Often the left bundle branch block, in fact, has a shorter refractory period and is excitable sooner than the right bundle. And so if the AV node lets an impulse down right at this moment, when one bundle branch in blue has recovered but the other bundle branch in purple has not, well, the blue one will be able to respond, and you'll get an action potential and a beat conducting down that bundle branch. But the purple will be refractory, and you won't get a response. And as a result, the signal will be able to go down one bundle branch system, but not the other. And then, of course, it has to take slow intramyocardial pathways to get around the rest of the heart, and that's what causes the QRS complex to widen and look bizarre like this. Now, it's not always the right bundle branch that blocks. Sometimes the left will, and sometimes only parts of the conduction system will block. But the bottom line is that premature beats may encounter this heterogeneous refractoriness. That means part of the conduction system has recovered and part of it hasn't. And so this PAC conducts aberrantly with what's known as a functional bundle branch block or functional aberrancy. What does that mean? Well, it means that it really is depending on the function of the electrical circuits, and it's not so much that that part of the conduction system doesn't work, it's just that under certain circumstances, it doesn't function the same. So functional means it comes and goes depending upon the circumstances. And that's just a fancy way of saying that it's rate-related aberrancy, because after all, this PAC is coupled at a relatively rapid rate, and these two beats conducted aberrantly, and so on. Now, can we actually see what's happening here? Well, you have this one PAC. We'll call it number one. And then, where did this second wide complex come from? Well, there must be another PAC in here someplace that distorted the T wave. It's hard to actually see it. But what we can see is the P wave that was responsible for this narrow complex beat. So I would kind of classify this as an atrial triplet, which means there were three PACs in a row, number one, number two in here someplace, and this would be the third one. But the first two beats conducted aberrantly, and the third beat, because of the timing of this P wave, managed to get down both bundles at the same time, and you get a narrow QRS complex, similar to the normally conducted ones. Now, I talk about functional bundle branch block and aberrancy in the basic level of my Ecg Academy course. So if this doesn't sound familiar, go back and watch those videos, because this kind of functional bundle branch block or functional aberrancy happens all the time. And unfortunately, a lot of people working on telemetry units, including nurses and technicians, might mistakenly diagnose this as a ventricular event. And the reason is they're not looking for those P waves superimposed on the previous T. And this was so obvious I had to share it with you. But sometimes they can be very subtle, and that's why you have to be looking for them. Well, I hope this was helpful. And until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching.
Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is one of those in the trenches. It's kind of challenging but it's one of the ECGs I had to read over the weekend, and I thought I would share it with you. So one of the things that makes this ECG a little bit challenging is that there's a fair amount of artifact. Let's look at the forest first. So here's the rhythm strip down here, and it's lead 2. And we can see the QRSs here look fairly regular. That's right, as you march on through, and they're kind of slow. If you ballpark the heart rate, it's 300, 150, 175, 60, 50. So it's about 50 beats per minute. And when we come over here and look for P wave in front of the QRS complex, we clearly see that there's a P wave and it's up in 1, and it seems to be up in AVF. But where's the next P wave? Do we see it in front of this QRS? Well, no, it doesn't look like we do see it. I mean, clearly there's one over here, and as we scan across, there's one over here, and then it's gone, and then it's back again, and then it's gone, and then it's back again. Now, where's the best place to look for P waves is usually V1, and so we can see this P wave very clearly in V1, but if you look very carefully, it looks like there's another P here. It looks the same as this one. They have the same morphology, and you're thinking, well, maybe this is some kind of weird irregular atrial rhythm. But when we scan across and look roughly at the same interval, we can see a downward deflection right there. That looks like a P wave. And then the next one occurs over here that's fairly on time, and then here. And then look at how this ST is flat, but this ST has a bump, so clearly there's a P here. So what's the atrial rate? Well, count off from here, it's 300, 150, 175. If the atrial rate is 75 and the ventricular rate is 50, the P to P interval is regular, and the R to R interval is regular, then the natural assumption is that this must be complete heart block. Or is it? Well, how are we going to go figure out whether this is complete heart block or not? Remember, with complete heart block, you should have regular P waves, you should have regular QRSs, because after all, the ventricular rhythm in complete heart block is what? It's an escape rhythm. And so it should be firing at a perfectly regular rate because it's not being affected by the atrial rhythm. The other thing is that the atrial rate should be faster than the ventricular rate, right? The P waves are marching on through and the ventricular rate is slower. If it was the opposite, if the ventricular rate was faster than the atrial rate, what do we call it? AV dissociation. But in complete heart block, the atrial rate should be faster. And the last thing is that there should be no relationship between the two rhythms. Well, that's the thing that sticks out because, we noticed that there was a P wave in front of this QRS, and there was a P wave in front of this QRS, and in front of this QRS, and in front of this QRS. And the PR intervals of these beats seem to be fairly consistent. So the question is, are these P waves just a coincidence? Because after all, if you take a rate of 50 and a rate of 75 and you're a mathematical genius, you realize that there is a certain common multiple here. What I mean to say is this is an interval of 1200 milliseconds, and this is an interval of 800 milliseconds. So theoretically, every 2400 milliseconds, you'll have a P and a QRS complex that seem to kind of line up with each other. And you've probably heard the term isorhythmic AV dissociation, meaning that you have Ps and QRSs that just happen to be near each other, but they're not exactly related. That it just happens to be a coincidence because the two rhythms are going independently, for example, with an accelerated junctional rhythm. Okay, so how can you tell the difference? How do you know that these Ps aren't somehow conducting? Well, you really have to use a pair of calipers for this, and you have to have a sharp eye. Now, when I looked at this, I saw it with my own two eyeballs. But when you're first starting out, you really need calipers to appreciate this. Now, I'm going to zoom in on lead 2 here. And again, what you're seeing is the first beat has a P in front of it, and then there's a P here, and there's a P on the ST segment that we identified before, and then here's the P that seems to precede the next QRS complex. And the question is, are these Ps being conducted? And really the only way to figure that out is to very, very carefully measure the R to R intervals. So let's pull out a pair of calipers. And what I did was I set this very carefully for the R to R interval here, the calipers on the QRS complexes. And now let's move over and see what happens. And look, this QRS came about 40 milliseconds earlier than it should have. Well, there you go. That's your answer. You say, what? What's my answer? Well, that tells us that this P wave did indeed conduct to the QRS complex because it pulled the QRS a little bit earlier than it should have occurred. You say, really? Well, let's see what happens later in the strip. Let me just drag this over and drag our calipers again. So here we see that this interval is a little bit longer and this interval is a little bit shorter. Notice where the point of the calipers lands. And then we come across and we see that this interval is longer again. So when you go back out and look at the entire strip, the intervals that have a P wave are a little shorter, and the intervals that don't have a P wave are a little bit longer. So this is shorter, and this is longer, and this is shorter, and this is longer. And if you use your eyes very, very carefully, you can actually see that. Even though it's only a 40 millisecond difference, once you train your eyes, you can figure it out. So what's actually happening? Well, first of all, you know right off the bat that this is not complete heart block, because if it was, the R to R intervals would be perfectly regular. So what's actually happening? Well, what's happening is this P wave is conducting with a bit of a first degree AV block. The PR interval here is about 280 milliseconds. And then this P blocks, and the next P is over here, but what happens is you have right here is a what? A junctional escape. The AV node waited long enough, and it said, oh, well, I don't see a P, so I'd better fire. The AV node fired at this point, and because the AV node fired, as a result, this P wave could not get down the AV node because it was busy firing. In other words, it was refractory. And then what happens is the sequence repeats itself with a conducted P wave, and then a blocked P wave, and then a junctional escape. The junctional escape is associated with a longer R to R interval, but when the P wave conducts, it shortens the R to R interval because the QRS occurs sooner than it would have if we were simply relying on the AV node. So the fact is that some of the P waves are conducting, and therefore this is second degree AV block. And because you don't have two conducted P waves in a row, to compare the PR intervals, you cannot say it's type 1 or type 2. We'd simply call it high grade with junctional escape beats, abbreviating the pause that we would have gotten had it been 2-to-1 block, right? So in other words, if we had 2-to-1 block, we'd have these very long pauses because only every other QRS complex would be present. And that's easy to recognize. What you wind up having is a junctional escape here. So this QRS disappears because this P wave cannot conduct. So now we're relying on the third P wave to conduct. But the interval between the junctional rhythm is different from the interval with the conducted beat. You can see that the conducted beat is going to occur a little bit sooner than the junctional escape, giving you a shorter R to R interval where the P's conduct and a longer R to R interval when you have a junctional escape. Well, I hope this is clear to you. It's a very interesting tracing. I don't come across this too often. The key to this is that the R to R intervals are not regular, and so some of the P waves must be conducting, and as a result, it's not complete third degree AV block, but it's second. Well, until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk starts with a rhythm strip, but we're going to get into this a bit because it's kind of interesting and I haven't seen this too often, but let's get to it. This is lead 2 we're monitoring, and as you look at the forest, it seems to be a pretty regular rhythm. The QRSs are marching on through. The QRSs themselves seem to be a little bit wide, close to 160 milliseconds, so the QRS is a bit wide, but there's clearly a P wave in front of it. The PR interval is about 160 milliseconds. And we have a P wave here, and as we look across, there's a P wave here, but what happened here? The P disappeared. So these last 3 beats do not seem to have a P wave in front of them. Or if it's there, it's very, very small. But how do P waves just simply disappear? Well, there are a couple of different possibilities, but I think what you need to do first is start to look at the trees a bit more carefully. So let's pull out a pair of calipers, and if we drag these up to the QRS complexes, we can do it at the onset of the QRSs, and I think that's a spot that's fairly clear here. And if we look at the rate, we'll put 1 point on a heavy line and count off. So that's 2, 4, 6, 8. It's 50 milliseconds less than 1,000, so 950 milliseconds. We'll take our handy-dandy calculator, and the easiest thing is just to plug a 6, because you divide it into 60,000. So 6 divided by 950, and then just sort of like ignore the decimal point, and you get 63 beats per minute. Well, let's take these calipers and move them down the line. Here, this R to R interval is the same. When we look at this one, we can see that the QRS came a little bit early, by about 30 milliseconds. And if we march on down, we can see that this QRS came even earlier, and this one as well. So now let's resize the calipers Okay, we'll bring these down, and we can see it's considerably faster. So about 860. Plugging that in gives us a heart rate of 69, almost 70 beats per minute. So the heart rate went from 63 to 70 beats per minute, and the P waves disappeared. So the rhythm clearly changed. And since the P waves seem to disappear, one possibility that people will think about is an accelerated junctional rhythm. This is an arrhythmia also known as non-paroxysmal junctional tachycardia, because it doesn't start suddenly. It very gradually increases in rate and takes over as the predominant rhythm. So in other words, the AV node starts beating faster than the sinus rhythm and takes over as the predominant pacemaker. But that's not what this looks like, because if that were the case, then there would be a point when the sinus node and the AV node were sort of like competing with each other, and you'd usually have some kind of fusion between these two separate rhythm sources. In that case, what happens is the sinus node is going along, and then when the AV node starts to accelerate, the PR gets shorter, right? Because now this QRS has come from the AV junction, but the sinus node still fired. So you should see progressive shortening of the PR interval. Eventually what happens is the P wave disappears and can sometimes wind up being retrograde if the junctional rhythm is fast enough. So you have fusion here between the two separate pacemaker foci, the sinus node and the AV node, and this is an example of AV dissociation, where the ventricular rate is going faster than the atrial rate. But that's not what we see here. The P just simply disappears. Well, the clue happens to be in the 12 lead, because I actually took this off of a 12 lead. Now here's that exact same rhythm strip down here, lead 2, and you've got these 3 P waves, and then the P waves disappear. But they're not really gone. Up here in V1 and V2, those Ps are there. In fact, you can see here in AVR and AVL. The PR interval doesn't even change. So how can you explain the P waves disappearing in lead 2? Well, it all has to do with the P wave axis. Unfortunately, the limb leads here in 1, 2, and 3 are the only ones that record these first 3 beats, because AVR, AVL, and AVF are recording the beats with no P waves. But if we look at the axis circle, and this is lead 1, and here we have lead 2 and lead 3, well, the P waves are upright in 1, 2, and 3. So where do you think the axis might be? Well, it's positive in lead 1, so it has to be in this part of the circle. And it's positive in lead 3, so it has to be in this part of the circle as well. And where those two circles overlap is this segment right in here. So we can infer from these 3 leads that the P wave axis is down here, somewhere between maybe 60 and 90 degrees. And that's kind of where you expect a normal P wave to arise from if it came from the sinus node. When the sinus node fires, the wave of depolarization goes down into the patient's left. So the normal P wave axis is around here. But now what about these 3 beats? Now it happens to be up in AVL, which means it has to be in this half of the circle. And in fact, it's nearly isoelectric in AVF. So that means the axis has now shifted to more like 0 degrees. And in fact, I think AVF is a little bit negative, so if you wanted to be more precise, it'd be about minus 10 degrees. Well, remember, lead 2 is down and to the patient's left, and if the axis is now minus 10 degrees, what happens is that the signal is going isoelectric to lead 2. In fact, you can see little tiny P waves. They're somewhat positive, and that makes sense because the perpendicular to lead 2 would actually be minus 30. So this P wave axis is somewhere between minus 10 and minus 30, and so it's nearly perpendicular to lead 2, and it's nearly perpendicular to lead AVF. And it's a little bit faster than the sinus rhythm. So what happened? Well, now it becomes obvious that the atrial rhythm shifted downwards, that you now have a pacemaker site in the atrium that's somewhere down on the right atrial free wall, and now what's happening is the wave of depolarization has shifted leftward to the point where the P wave is now going almost isoelectric to lead 2, and that's why it disappears. Not because it's gone, but because it's isoelectric in the lead that we're monitoring. It's going perpendicular to lead 2, and so the ECG machine can't see it. So the diagnosis here is wandering atrial pacemaker. That's kind of an old-fashioned name, but it suits the purpose because the heart rate did not change much. It's not like we can call this atrial tachycardia, even though it's the same kind of mechanism where a focus away from the normal sinus node began to fire and took over. And just to be complete, let's look at the QRS complexes again. The QRS axis is markedly leftward, about minus 90. And the QRS complex has a kind of an odd appearance in V1 and V2, something that we would actually call a QR prime. And it goes along with the right bundle branch block, but but you have a Q wave in V1, V2, and only little tiny R wave in V3, V4, V5, and V6. So this was a patient who has an ischemic cardiomyopathy. He's had an old anteroseptal MI. So septal forces are missing and you have Q waves and poor R wave progression. So there's essentially no anterior forces, but you have a right bundle branch block and this axis of -90. That's consistent with the left anterior fascicular block or left anterior hemiblock. So you have a right bundle branch block, left anterior hemiblock, an old anteroseptal MI, and you have secondary T-wave abnormalities in AVL, V1, and V2 that kind of go along with the bundle branch block. But I just thought this was neat how the P waves seem to disappear, and I wanted you guys to appreciate how you figure that out. And most people don't pay attention to the P wave axis, but I hope this Chalk Talk will get you tuned into looking for those changes and help you become ECG experts. Well, until next week, this is Dr. Nick with the ECG Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and today we're getting back to basics. So I have a simple rhythm strip here, and I'm going to show you beginners how to approach a strip like this. The first thing to do when you approach a rhythm strip like this is look at the whole entire strip. Look at the forest, and then you can begin to look at the trees. And you can see that there are 2 beats over here, and there are 2 beats over here, so it's obviously irregular. Is there a pattern? Well, we're not really sure, but you do see a couple of beats here and a couple there. And then there's this pause in the middle, and we have to figure out why there's a pause there and analyze this strip according to the physiologic principles that we learned in the course. Now, the next thing to do is start examining the QRS complexes and look for P waves associated with each one. And the QRS looks reasonably narrow, with a fairly normal QT interval. The T wave does not reach the midpoint between the 2 R to R intervals, so that's probably normal. And when we look at the PR interval, we see that it is quite long. Just eyeballing it, it looks like about 9 small boxes. If you want to be more precise, you can take a pair of calipers, move it down to the beginning of the P wave and the beginning of the QRS complex. Then you lift it up and place one of the points on a heavy line and read off how many small boxes there are. And it's about 9. That's 360 milliseconds, which is quite long. So we know there's something wrong with the AV node. At the very least, we have a first-degree AV block. And as we look at the second QRS complex, we see there's a P wave in front of it as well. And we can go ahead and look at that PR interval, and it's just about the same. We can come up here and look at this lead, and it's about the same. And so now we have to deal with the fact that there's a pause here. We know what the QRS complexes look like, and there aren't any. But we also know what the P waves look like, and it looks like there's one right here. So it looks like there's a P wave that fails to conduct to the ventricles. And then as we look across, we see there's another P wave, and this one does conduct, and the following P wave conducts as well. And we remember from the course that if some of the P waves fail to conduct, but some do, then what we may be dealing with is second-degree AV block. Now, there's 3 different kinds of second-degree AV block. There's type 1, there's type 2, and then there's high-grade or advanced AV block when you have 2-to-1 and 3-to-1 and so forth. So experienced readers will then take their ECG calipers and try to distinguish between type 1 and type 2 by measuring the PR interval. So if we take these calipers and move over here to this PR interval, we notice that, this PR interval looks a little shorter. Instead of 360 milliseconds, it's more like 320. And then when we measure this one over here, it's back to being about 9 small boxes. So there did seem to be a very slight decrease in the PR interval to 320 and then 360. Now, is that enough of a change in order to call type 1 second-degree AV block? Or let me throw a fly in the ointment. Could there have been such a long pause here that maybe this beat could be a junctional escape beat, which would have moved it forward and therefore shortened the PR interval? Of course, if this QRS morphology was different than all the other beats, then I would buy this idea of a junctional escape. But in reality, this is all wrong. And you say, what do you mean it's all wrong? Wait, the PR is getting longer. It went from 320 to 360, so this must be type 1 second degree, and I'll say no. What you need to do before you call second degree AV block is make sure that this P wave came on time. So if we take a pair of calipers and make them a little bigger, and we look at this P to P interval, and we compare it with the first P to P interval, we can see they're equal, but now look what happens when I measure this P to P interval. Now it becomes apparent that this P wave here that's hanging in the breeze is not a sinus P wave. It came earlier than it should have. It's a premature atrial contraction, or PAC. It wasn't a sinus beat. And so therefore, you know how the AV node hates premature beats. The AV node doesn't conduct premature beats well, and it also doesn't conduct rapid rates well. Well, here you have an AV node that you know is abnormal because it's already got a first-degree AV block. The PR is already long. And now what happens right here is you have a premature beat that hits the AV node at a point when the AV node has not yet recovered from the previous beat. So it hasn't recovered from conducting this P wave because it's not so swift. And so this PAC is blocked by virtue of it being premature. That's what the P stands for, right? So you have this premature beat that hits the AV node at a point when the AV node hasn't recovered from the previous beat and it's not conducted to the ventricles. Now that's not the same as saying second degree AV block. It's not. It came prematurely. And if this P wave was on time, it very likely would have conducted fine. How does that fit with the rest of it? Well, it fits okay because now you've got this long pause. It's the pause that refreshes. And after a long pause, it's very common for the AV node to improve its conduction. Now, it certainly didn't go back to normal, and that's because the AV node has a problem. But the fact that this PR is shorter following the pause makes perfect physiologic sense because the AV node conduction improves with slower heart rates and after pauses. And then with this next beat, it doesn't have as much time to recover, and so the PR interval gets longer again. So what we have here is sinus bradycardia with first-degree AV block and a non-conducted premature atrial contraction. Okay? I use this very strip on a lot of tests that I give, and almost everybody gets this wrong. Well, how are you going to know that this beat is premature if you don't have calipers? Well, here's the trick. Look very carefully at how much time there is between the T wave and the next P wave. Okay? What we might call the TP interval. If you look at this TP interval and compare it with the interval between this T wave and the next P, look how much shorter it is. So even at a glance, you can see that this beat came earlier with respect to the previous beat than this one. Just glancing at this beat, you can see right away that this is premature. So when you look at a P wave, the first thing is to make sure it's on time before you decide to go chasing after any other diagnoses. And if it's not on time, if it's premature, then you simply have a blocked PAC. And that's it for this week. This is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is all about the rhythm. We have here a 12 lead. We're looking at the forest. We see what looks like group beating. Here's a group of 3, and a group of 4, and a group of 3. So we're going to have to do some work to figure out what that rhythm is. Meanwhile, let's take a look at the 12 lead. That's up here at the top. There are P waves, and that the PR interval is long. It looks like about 300 milliseconds, at least in this one beat. The QRS looks normal in duration. It's only about 80 milliseconds. And let's figure out the QRS axis. It's almost isoelectric in lead 2, but it's almost isoelectric in AVR. If here's lead 1, which is straight across, lead 2, remember, is down and to the patient's left. So if lead 2 were isoelectric, the axis would be minus 30. On the other hand, if AVR was most isoelectric, AVR is 30 degrees above the horizontal, heading over towards the right arm. So that axis would be minus 60. By interpolating, we get a result of just about minus 45 degrees. So it is a left axis deviation. Now, is it left anterior fascicular block? Well, you know what? It kind of depends. Some cardiologists will read minus 45 as a left anterior fascicular block, but I like to wait until it's up near minus 60. So AVR needs to be isoelectric, so I'm on the fence about that one, but it's certainly reasonable to consider left anterior fascicular block. Now, one of the things that sometimes makes up my mind is if we see early transition or late transition in the precordial leads. Now, if you look very carefully at V1, you can actually see what looks like an RSR prime, but that's an awfully teeny R prime. When you come over here to lead 1, do you see a wide S wave consistent with an incomplete right bundle branch block? Barely. So even though the computer might read incomplete right bundle branch block, I like to call this more of a right IVCD or a right-sided IVCD, and in a younger person, I'll just ignore it. I'll call it normal. The rest of the R wave progression is pretty normal. The T waves are all normal. There aren't any pathological Q waves, so the 12 lead itself isn't that impressive. So let's turn our attention to the rhythm. You know, the P waves are much easier to see in V1, and what you see is a PQRS, PQRS, and now this QRS complex comes a little bit early. If you were to map these QRSs out, the next one would occur here someplace. So this QRS came a little bit early, and I don't see a P in front of it, do you? Well, the thing is this. Some people would be tempted to call this a junctional premature beat. So let's take a closer look at V1 here. So this is the same thing, it's just blown up. Remember, I'm scanning in very high resolution. And here's that first P wave, and you've got a first degree AV block in this lead. I'd call it about 260 milliseconds. And then you have this RSR prime, and then a flat ST segment and a very smooth T wave. Now here's the next beat to come along. You have a P, you have that RSR prime, you have a fairly flat ST, and the T wave, but now the T wave actually goes up at the very end. Do you see that? Compare it with the end of this T wave. That's where the P is. So this is actually a premature atrial contraction, a PAC, that's superimposed on the T wave, and that's why you don't see it. But that's where this QRS came from. The PR interval is pretty long. It's about 300 milliseconds here. But you want to see something else that's cool? There's another PAC right here. Look at that ST segment, how it's got this little double bump compared with the ST segment of this beat and even this beat. Now you have another PAC right here. This PAC occurs so soon after the QRS complex that it's blocked because the AV node is refractory. The AV node is still busy from the previous beat. So this P wave blocks, but it's this P wave that resets the sinus node, and that's where this pause came from. I bet you thought I was going to find Winky back or some other crazy thing to cause that group beating. But no, in fact, what you have are two PACs, number 1 and number 2, and these PACs suppress the sinus node and result in this pause. And then the whole thing repeats itself. You have this PQRST and another one here and another one here, but notice that this QRS comes a little bit early. If you compare this interval, this is a little shorter. Where'd this QRS come from? Well, you should have seen it by now because you have a PAC right there at the end of the T wave. Notice that it is absent here. If you don't believe me, you can see it up here in V3 even more clearly. So this PAC conducts with a very long first degree, and then look at that, you have another PAC. So this patient is having atrial couplets. The first one conducting with a long first degree AV block, and the second one is non-conducted. And these atrial couplets are the cause of the pauses. Now that we're back to the original tracing, I think now you can start to see these little fine details. So there's the PAC that blocks, and you can see the end of this T wave has a little bump compared with the end of this T wave. So here's the first pause, here's the second pause. Now what caused the third pause? Well, this time we have 3 sinus P waves, and right there we can see pretty clearly in lead 2 and a little bit here in V1, there's a blocked PAC that suppressed the sinus node and gave you this sinus pause, this delay in the subsequent sinus depolarization. And I thought this was a very different electrophysiologic explanation for group beating. So until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching.
Hey, this is Dr. Nick with the Ecg Academy, and last week I was called to the burn ICU to do a consultation on a patient who had some really wacky rhythm thing that the attending noted on the monitor. And this strip has 2 simultaneous leads, and I always tell people to look at the forest first, look at the entire tracing, and get a sense of what you're dealing with. And boy, it looks like a mess, doesn't it? Some of this in here really looks like something to worry about. In fact, that's why the attending called me. She was afraid there was some VTAC going on. But as you glance across this thing, you have to try to use your analytical mind to see if you can pick out any patterns. And remember that these 2 leads are going simultaneously, so don't let one lead distract you from the other lead. So when you come down here and look at this bottom lead, there do seem to be regular signals here and here that very well could be QRS complexes. And so use both leads and notice that there is a signal in the top lead that seems to correspond with that. But if that's the QRS complex, then what's this?
and this, and this. Well, it seems to correspond with a signal down in the bottom lead that almost has a sort of a sawtooth pattern to it. But keep analyzing, keep looking past the obvious. Because when you look in the top lead, you see a very large signal here that's separate and distinct from the QRS complex that you've already identified. It almost looks like a double bump, and people will look and say, wow, is that like a bundle branch block or something? Because then you see it here as well, a double bump. But here the second bump is larger than the first, and here it recurs again. There's two bumps here, but then look what happens. These bumps actually get closer and closer together. Now, how could that be? If those two signals are moving independently, then they must be unrelated. Not only that, but if you keep glancing across the strip, you see that there are larger signals that seem to continue through the strip at the same rate as in the beginning. So, have you figured this out yet? All this junk is nothing but artifact. That's right. In fact, in this lead, the artifact is bigger than the QRS complex, and it's very distracting. But what you see here is a sharper signal here and here, and that corresponds with this QRS here and here. And so you can see that the normal rhythm is marching through, and you can't have two separate rhythms going simultaneously, and so these very wide, bizarre-looking signals are nothing but artifact. Well, it sure fooled the surgical attending, and this is the kind of strip that will trick a lot of experienced people. But you have to use your eyes to filter things out and try to separate the wheat from the chaff. And remember, the first question you should always ask when you're presented with something bizarre looking like this is it real? And on that note, this is Dr. Nick with the ECG Academy. Thanks for watching.